Good morning, everyone, and thanks for joining us today. My name is Adam, Content Marketing Specialist with Henry Schein. On behalf of Henry Schein, Dentsply Sirona, and CDocs, I'd like to thank you for attending today's online learning session for Exceed with CEREC. Before we get started, I would like to remind everyone that today's online learning is divided into two sessions. In between the morning and afternoon session will be a 2-hour lunch break. We are not offering continuing education credits for attending this presentation live or viewing it after the fact. Throughout today's presentation, we do encourage your participation via the Q&A function. If you have specific questions, please type them into the Q&A section. We will be monitoring questions as they come in, and we'll have many live opportunities throughout the day to answer your questions. Today's session is being recorded, and everyone attending will receive the recording, but please feel free to take notes throughout the day as we will be covering quite a bit of content. I'd like to thank Dr. Snider for presenting and being with us today. Take it away.
So good morning, everyone. Thanks for the introduction, Adam. We have done this program a number of times, and in general, before the world of COVID, this is obviously a hands-on event, and it takes on a different form when we're having to do it virtually like this. So I want to make it as interactive as possible. As Adam said, please use the Q&A function. It's hard for me to know if you have questions or if I'm covering our material too fast without you guys using that. I will try to take breaks throughout the presentation today to answer those questions directly. During the lunch break, I'll probably stick around for a little bit once we finish to answer any questions on the Q&A, and I'll probably come back a little early rather than that 3 p.m. Eastern time to answer questions there. We'll also leave time at the end of the day to either go back over anything you want. This event is generally a 2-day event, and so we have shortened it quite a bit to fit it into one day. I know it's tough to take time out of your practice to watch something like this. So I'm going to be covering a lot of material in a very short amount of time. So let's kind of get started and see where we're at. Just a little bit about me. This is my office that you see on the left side of your screen. I practice in Greenwood, South Carolina, which is a relatively rural town, about 50,000 people. I have a pretty large team, 5 hygienists, 4 assistants, and 4 at the front desk. The young lady in the middle is my associate. She began working here a little over a year ago now. She was actually a patient of the practice and then joined the practice as an associate. On the right side of the screen, you see my daughter, that's Reeves, and then James at the bottom. They are fantastic and what I spend all my time doing when I'm not in the office, but totally different personalities. So this is Reeves on the first day of school, smiling and cheesing and kind of ready to go. And then you see James on the first day of school and quite a different individual. I have been a visiting faculty at CDocs for quite some time. I've been a CEREC user for over 10 years now. Started with the red cam and then the blue cam, the omni cam, and now the prime scan in my practice. It's how I run my office. This technology is what my entire practice is based around. And so I want to get into that a little bit more today to show how it fits into my practice and then possibly how it would fit into yours as well. So, we have a couple of goals. If we lay those out at the beginning, we can talk about what we're going to be doing over the next couple of hours today. But I want to introduce all of you to the new CEREC system, the Prime Scan and the Prime Mill. I do want to jump into materials a little bit. I'll try not to make that too boring, but the CEREC really excels because of how many different materials there are available now and different clinical indications of those materials. And then rather than the hands-on portion, you guys are going to see me design and make restorations, but we're not going to obviously be able to do that as we would normally do. So if we talk about conventional dentistry a little bit and where we've been for years, things have worked. It's just that there are better ways of doing these procedures now than the old analog fashion. I mean, in my practice, we're no longer doing these kind of film-based radiographs. Everything is digital. I still do use diagnostic wax stuffs a lot of times, but it tends to be that these diagnostic wax stuffs are coming from 3D printed models, not from impressions in stone. I'm still taking some impression or a model, but I'm doing that again digitally rather than using VPS or polyether, no triple trays, and I'm not having to pour up models to then get a restoration. The difference with CEREC in the system is that I'm able to now scan rather than impress, and then I'm able to design my restoration and make it same day. This has been a huge benefit to me throughout my practice, but even more so now post-COVID. I have patients that have been out of work for months and they're coming in and they don't want more appointments and more time off work. And if I'm able to get them in and treat them same day, it saves them a lot of headache rather than having to take more time off and things like that. So let's talk about the indications of CEREC. I know you guys are probably aware of a lot of it, but the one thing I like to really start with is the inlay. You know, CEREC has done crowns, like you can see here on number 20 for years, and everybody's aware of that. But the inlay is something that really makes a big difference in my practice. In that initial slide, you saw that I had 5 hygienists. And if I was having to check 5 hygiene all day and I was doing conventional composite restorations, I would have a difficult time keeping up with the schedule at my practice. But by doing these composite restorations as inlays, it saves me a lot of time and it makes the entire procedure much more predictable. So let's say we had a quadrant of, you know, 2, 3, 4, 5, and they're all MODB, MODL, that kind of stuff. It would take me an inordinate amount of time to prep those, isolate them, and then layer the composites in there and not have contacts that are, you know, wonky and not even. Instead, with my CEREC, I just prep that quadrant for composites and scan it, and then I'm able to mill out these inlays and seat them all at one time. Now my occlusion's right, my marginal ridges are nice, the contacts aren't open, everything's fitting very well, and the cost savings is there, so my patients don't have to pay any more for this inlay than what they would for a general composite. The blocks are about the same, and we can kind of dive into that a little bit more as this goes along, but it doesn't cost me any more money to do this inlay than if I were to be wrapping Toffelmeyers and matrices or paladins and wedges and bands. All ends up being around the same fee for the practice. So really nice scenario, way of doing that rather than having my head down and doing direct composite dentistry for 20 or 30 minutes trying to do 3 or 4 teeth at a time. I can get up and go check hygiene, see another patient, come back. My assistant has these, you know, restorations ready to go. We isolate the quadrant and seat them. And, you know, and the onlay is kind of the same thing. I tend to be as conservative as possible. You may look at this picture on the right and say, you know, that's definitely a crown in my practice. And I would tell you that that's fine. The CEREC gives you a lot of options. You're not prepping necessarily for the machine, more for the material that you're using and selecting a different type of, you know, ceramic or zirconia or these sort of things. But I love when, you know, we can see these patients same day and take care of them because it always presents relatively the same. The patient has a big, maybe MO amalgam on this upper, you know, first molar, and they break off like a mesiolingual or a mesiobuccal cusp. And instead of having to entirely prep that tooth down for a crown, what I'm able to do is just simply remove the old alloy, clean up any cracks or things that I see, and do a conservative restoration. And because we can do this out of these new hybrid ceramic materials that we're going to cover later today, this whole procedure in my practice takes less than an hour. So the patient's in and out, you're getting compensated for your time very well, and it makes a big return for your practice. And, you know, we all know that CEREC can do crowns. You guys have seen these, I'm sure, for years and know that the crowns work and they fit. I would argue that if you have seen some poor margins with the crowns or perhaps poor anatomy in a CEREC restoration, that has more to do with the practitioner that's actually using the machine than it does the machine itself. But these are, you know, our kind of standard day-to-day operations, 1 and 2 units of crown and bridge that kind of keep the practice moving along. But if we start looking at it from a scenario of how does this work in terms of doing some endo along with the crown, now we start talking about being a very productive appointment and saving the patient a lot of time. So, you know, if you're doing this in a conventional analog manner, perhaps the patient comes in, you do the endo and the build up, and then they leave. And then they come back and have the crown prepped and temporized and leave. And then they come back again to have the final crown delivered. So, you know, the patient at this point has had 3 appointments. Instead, at our practice, what we'll do is, you know, we know that the tooth is going to need endo. So we go ahead and anesthetize and prep the tooth for the crown first, removing any decay, building it up, getting a nice solid prep. Then I scan that into the system and go ahead and have the crown being fabricated. Now I can isolate with a rubber dam, access through my crown prep, which gives me a nice kind of flat surface to measure from for my working lengths. It also keeps my working lengths a little shorter because the crown's already been prepped. And I do the endo while the crown is being made. Once the endo is completed, I do the build up back flush to the occlusal surface of our prep. Then the crown's out and seated. So rather than 3+ appointments for this patient, and in and out of your office, we're able to do this all at one time, and to be highly productive, but also be very convenient for the patient to be able to get this work done. And, you know, CEREC can do quadrants, CEREC can do, you know, 2 teeth, 4 teeth, CEREC can do 32 teeth at a time if you want. You know, that's probably not where we would begin for a new user, but the software definitely has the capability to propose as many restorations at a time as you see fit. And the quadrant doesn't have to necessarily be all the same restoration. You know, we could be doing, we could be doing a, you know, an inlay here, a crown, an implant, another crown. You have tons of options with the CEREC and able to kind of go through the software and tell it what kind of restorations you're wanting to do each time. We can do bridges. This is something that's, you know, newer in the software, has been around for a couple of years, and it's more based on material. In the anterior, we have an option of doing Emax bridges. We also have an option of doing some of the more aesthetic zirconia. In the posterior, same Emax and aesthetic zirconia bridges, or even some more zirconia approaching that kind of Bruxier, highly strong, maybe not as aesthetic, but multiple options that make it really nice for the patient. And again, nice for you. This patient doesn't have to walk around with a temporary that they don't really want for 2 or 3 days. Instead, they can come back and have it done all at one time. And then we have options to do implants. I'm sure that if you're not placing implants in your practice, most of you are probably restoring them. And so we have the option to now do these chairside. Again, implants can be relatively expensive when you're looking at the lab bill for something like a custom abutment and a crown. And to be able to fabricate these in office after the patient's already been waiting 3 to 4 months for a restoration is really nice to be able to control the entire emergence, the tissue profile, and the contacts here. Personally, I really like screw retained restorations in the posterior, and to be able to do a screw retained crown same day for a patient is really nice. Not only is that have no cement cleanup or sepsis to worry about, but the seat of it just becomes so simple that this is a really rewarding procedure for me and for the patients alike. And then we can do guides. So what you're seeing here is what we call a CEREC Guide 2. We can mill these in office. I'm going to show you some cases of those and also show you how the cone beam that I have within my practice matches up with my CEREC machine and my overall software. So I can print these guides, I can mill them. A lot of options to be able to place the implant based on where the crown is going to be, rather than placing the implant and then trying to figure out how to make a restoration fit it. Really nice to be prosthetically driven. Again, it's just predictability day in and day out with this software that makes it a must-have in my practice. And we can do anterior restorations. You know, I've heard discussions about aesthetics and things like that. And, you know, I would argue with you that unless you're asking your lab to press the ceramic, probably most of you are receiving milled ceramics now, but learning how to contour, stain, glaze, and finish these is imperative in terms of getting a lab quality type restoration. And CDocs has an entire curriculum set around this. So after today, there would be a level 1 training course where you get a little more hands-on. And then we move on to level 2 where we dive in deeper to the software. Level 3, we focus on, you know, implants, things like that. Level 4 is all on anterior aesthetics and how to stain and glaze and contour these restorations so that you can have lab quality anteriors all produced within your own office. And these are the type of restorations that you can get. I mean, if you see this case and you look at the wear and the breakdown of that 7 through 10, what you're looking at on the lower is actually an aesthetic zirconia. And I would argue that, you know, these milled restorations look as good as anything that I would get from my lab. I think they turned out quite nice. I love the irregularities in the incisal edge and the contacts, and being able to control all this on our end and not worry about occlusion, contacts, and fit, because we know exactly what we're going to get from our machine every single time. And we can do ortho. Clear aligners is something that I do a lot of in my practice. I use Sure Smile, which is a company owned by Dentsply Sirona, to fabricate my aligners, or to at least fabricate the plan for the aligners, and then perhaps we're making the aligners in-house. But it used to be that, you know, scanning full arches would be kind of an onerous task. It may take a little while, but with the Prime Scan, you're seeing my colleague here, Dr. Mina Barsoom from Chicago. We have a full upper, a full lower arch, and a bite all recorded in about 3 minutes. And that's relatively the same amount of time that the PVS would take to set. And the models that we get are phenomenal. You're looking at the clarity of the model here. We can really zoom in and check these sort of things out. And if any of you are doing clear aligners in your office, you know how picky those companies can be when you start submitting to them the polyvinyl or polyether impressions. What we're able to do here is actually upload these images to the aligner company, and if they have a problem, they'll let us know. And I can even find out really while the patient's in the chair. Most of the time I can see it myself here. If I see a bleb or something, we go back and just fill it in instead of having to take an entirely new impression. But if we submit it to the company and they have a problem with it while the patient is at the office, we can go in and do any remodeling or reimaging that we have to do. This then exports directly to the SureSmile portal, and that allows us to go right forward with having a clean check and looking at tooth movement. So I want to talk a little bit about the prime scan, the imaging, and how it works. But prior to doing that, I'm going to stop for just a moment and answer some questions. So one is, do inlay-onlay preparations for CEREC follow the same preparation principles as traditionally made ceramic inlays and onlays? And my short answer is going to be yes, you're prepping for the ceramic, not the CEREC machine. So it depends on what type of material that you're going to be using for that restoration. After the initial break here, we do have an entire section that's just going to be on prep design. And the prep, again, is not for CEREC. The prep is for ceramic or zirconia or hybrid materials, depending on what I'm picking. And those are what's going to determine how I prepare the tooth, not the CEREC machine. So that's great. I like having those questions. I try to make this, again, as interactive as possible. So let me know if anything else pops up along the way. So what you're seeing in this initial slide is kind of the CEREC ecosystem that we work in now. On the far right, you're just going to see the prime scan. In the middle, the prime mill, which is the newer milling unit that was just released. And then on the left, the speed fire oven. We're going to get into each component throughout the day, and you'll see kind of how these all work together to make it a very predictable, again, system. So the prime scan, the most accurate scanner ever made, that's not just hyperbole, that's a true statement. There was a number of studies out of University of Zurich and other places that have looked at cross-arch global kind of accuracy. So comparing the scanner to polyvinyl and polyether, and this scanner was as accurate as traditional impression materials when looking at cross-arch accuracy. Not looking at a quad, not looking at 2 or 3 teeth, but actually looking at a full arch and seeing that. It does have a large field of view. This widescreen monitor is really nice. It's impressive to patients. You can rotate it around and show them their teeth, and it brings the patient into the experience with us. And it is totally, a touch interface, which is nice. We're used to working on tablets, iPhones, iPads, that kind of stuff. And so it's just more intuitive, I think, than the trackball and things that we had previously. Overall, when you're looking at the prime scan itself, there's no longer, like we said, the trackball or keyboard here. This is a totally kind of sealed surface with a trackpad, which is nice. You're able to sanitize and sterilize this in a very, efficient and quick way. Same with the camera. You can just kind of wipe it down, cavi wipes and things like that. There are different heads that go on the camera where the lens is at. They're actually disposable ones now, if that's something that interests you from a hygienic or sanitization standpoint. I would tell you that the one I have is the steel one, and it's cavicided and wiped down and has been for a couple of years at this point, and it still functions every day just as well. There's a couple of USB ports on the back of this monitor. If you were looking at it in person, you could rotate it around and see that. We use that for exporting intraoral images or that kind of thing. But overall, a great system. I like the cart. It keeps everything stable. We're able to move this room to room throughout the day. It's constantly being used somewhere in the practice, whether it's for scanning a night guard or scanning a crown or ortho, whatever. So I'm going to jump into kind of demoing what imaging with the CEREC system looks like. Talk to you guys a little bit about what the appropriate way to do the imaging is, and I want to answer any questions along the way. So one has popped up. Are autoclavable reusable camera sheaths available at this point? So I don't know that the autoclavable one is available. I know that the disposable one is available. The disposable one is a resin that would snap onto this portion here, and you could change that out between each individual patient. The one that I have is this kind of steel model with the sapphire lens, and this is just disinfected between every patient, just as everything else in the operatory is. In terms of the autoclavable one, I don't know. I know that there was one being made that had a lens that could change out as well, but in terms of availability and things, COVID has changed a lot of scenarios, as I'm sure you're aware, between PPE, sanitation products, everything within the practice is a little more difficult to acquire at this point in time. So I'm going to switch screens for just a moment, and hopefully what we're going to do is look at the CEREC. So when we're looking at a CEREC system, this is the screen that you're going to see once you open the CEREC software. And everything is going to work in the CEREC environment from left to right. So when I look at this initial screen, I'm going to go to the bottom. I'm going to hit add a new patient, and then I'm going to start by just adding myself, and you guys can track with us today. So you're going to see that the touch screen pops up. The keyboard is there on the screen. I'm able to kind of enter myself here. I'm probably already in this system a number of times from doing these webinars, but we'll have the date of birth as today, so it'll be a new patient. And then we're going to hit add case. It wants me to change this. Sorry, everything being remote sometimes gets a little bit out of sorts, which is what you're seeing right now. One moment. We may have to restart the system here. Just a second.
We do have a question that came in.
Sure.
I have a iTero scanner. By any chance, can that be used?
I guess I would want to know what you want to use the iTero scanner for. If you're asking me if the iTero scanner can be used to fabricate a restoration with CEREC, then the answer there would be no. The CEREC software and the validation process that goes through there requires that you're using a CEREC camera, right? The OmniCam Prime Scan, something like that, to then bring that impression into the software to be able to design the restoration. I'm not sure if that answers the question or not, but I don't know if the question was basically how do I use my iTero or not. So what we're going to see in this initial screen is we've added the case. You're going to see my name at the top. That's going to where your patient data is going to be. And we're going to work from left to right throughout the day. So here we have a crown. Here we have a bridge. Here we have an implant. And here we have a guide. And as we select whatever restoration we're doing, it's going to give us different options to pick from. And we're going to do that. And then again, moving from the administration to acquisition onto model phase until finally we get to the manufacture phase at the end. For this initial scanning demonstration, I'm just going to pick crown, and we're not going to get so much into these design modes. We're going to do that when we do the partial coverage restoration right before lunch. But let's just say we're going to do something on number 3. So now what I see on the right side of the screen is that I'm working with auto detect. It means the camera is going to decide whether this is an inlay, onlay, or crown. I'm going to be doing something out of Emacs. It gives me my mill selected, and we're going to move on to the acquisition phase. Now in the acquisition phase, what you're seeing on the left side is where the prime scan is going to be imaging. On the right side is where the model is going to be generated. And the minute that I pick up the camera from the cradle that it's in, it's going to turn on. So you're going to see me pick it up, and now the camera is active, and I can start scanning. And you're getting maybe some audio cues. Sometimes it doesn't come over great on these webinars. But that noise, kind of this Geiger counter sound, lets me know that I'm taking an image. If I start getting a really high pitch noise like this, that means that the software cannot find congruent data. It can't stitch what I'm trying to scan. So the noise that I want to hear is more of this kind of Geiger counter popping noise. This can be changed in the software, but that tells us that we're taking good images. Now, the software works by taking all of this data, stitching it together, and so you can see in real time, and then you can go and start rotating the model around and seeing if there's any voids or anything you missed. If so, you can actually just go back and just fill in anything that you missed. So not having to re-impress anything. The software is actually really good at editing it out bad data as well. So if we go in, and I'll use my finger as an example, but think of that being maybe the cheek or the tongue when you're trying to scan. If I'm in here and I start trying to scan my finger, But then if I come back and retract it and scan again, you can see how it automatically cut my finger out. It would do the same with the tongue or the cheek, or even, you know, blood, spit, or saliva. You want to just lightly dry the area and then go back and rescan it. And that way you're ending up with some really good data. So let's talk a little bit about kind of the scanning protocol and what the right way to do that would be. We don't want to just, you know, wave the camera around in any sort of form, because what we start having happen is generating a lot of redundant data. If I hold the camera in this position for 5 minutes, I'm not doing anything but generating the same images over and over and over again. And as that happens, the file gets bigger and bigger and bigger, and the computer has to really work to whittle that information down to generate a working model. So what I want to do instead is I want to scan linearly. And what I mean by that is that I'm going to start on the occlusal surface of the most distal tooth. I'm going to come up to the midline. After I come up to the midline, I'm going to rotate down to the buccal, get the entire buccal vestibule, come back up the occlusal again, rotate down and get the lingual. And by scanning in these 3 lines or patterns, we stay very efficient with the scanning, but we also are able to generate a really clean model. So you'll see that demonstrated here. Starting on the occlusal, coming up to the lingual, going down the lingual, back up the occlusal again, all the way to the midline, rotating out to the buccal, filling in any missing data here, and then coming back and always stopping on the occlusal surface. At this point, I kind of have the quadrant done. I would rotate around and say, hey, I missed the, you know, distifacial or distal of that canine. Simple. Now I can go back in and fill that area in directly, and always come back and stop on the occlusal surface. So what we're thinking about doing here on most restorations is we're thinking about doing something similar to a triple tray impression. You could scan a full arch because the prime scan is, you know, that efficient and easy. But do I need to do that every time I'm doing a single unit crown? The answer is probably no. So now that I have the upper arch, I could jump down to the lower, turn the camera on, and we're gonna do the same thing again. This kind of linear scan up the occlusal to the midline, down the buccal surface, up over the occlusal surface again, and then down the lingual. So kind of painting these 3 lines and then finishing on the occlusal. So now I have 2 models, a lower and an upper, but I need some way to relate these 2 models together if I'm going to design a restoration. So then I have to take a bite registration. And the way we do that is the buccal bite. We'll click on there. We have the patient close. Then we turn the camera on and we just take a very simple image. It has a little bit of tissue on the top, a little bit of tissue on the bottom. And what you're gonna see are these 2 ghost images kind of snap together. So if I zoom out and rotate this around, you'll see that now I'm able to look at my upper model and my lower model oriented. And most of the time we take this occlusion or this bite prior to the patient being anesthetized or while the anesthesia is starting to work. You guys all have patients, I'm sure, like I do, that once they're numb and you ask them to bite down, they kind of bite like this or like that, and you're not getting a true record of where they are. So what we're able to do is actually take this bite registration prior to even prepping the tooth. The software uses this meeting of the gingiva and the tooth, and then the same of the adjacent teeth on the arch you're working on to orient the models together. So this would be kind of my standard scan. To be perfectly honest, if I'm doing a single unit, let's say it's number 30 in my practice, my assistant has already scanned the upper arch, has already scanned the buccal bite, and she's already scanned in the lower arch. Then what I do is I come in and just fill in the data over the prep. So when I walk in the room and I get done prepping, all I really have to do is go to this site and add to the scan that she's already taken of the tooth that I've prepped, set it off, and we're ready to move forward. So I want to stop for a moment just to see if there's any questions in regards to this kind of quadrant or, you know, triple tray type imaging. And then I want to move on a little bit to full arch imaging as well. So let's see what's in the Q&A.
So I see we only have one, and it is, would you normally scan that quickly?
Yes. So it's imperative really to scan quickly and efficiently because, again, moving the camera very slow doesn't do a lot for you except generating more redundant data. You know, the camera has to be moving to be seeing different things. If I were to keep the camera right here and move extremely slowly, I haven't really done anything but generate more and more redundant data. What I want to do is be moving efficiently. The camera can move and record this data very quickly because it has such a wide field of view. If it had a smaller camera, you may have to move a little slower, but because of this camera's size and because of the focal trough that's there, you're able to move this very, very quickly and record very accurate type of restorations, images, impressions, however you're working.
Are you cutting away the original scan in the prep area before you scan the actual prep, or layering new data over it?
Layer new data over it. So we don't like to really use the cut tool in the acquisition phase. That was something that was more maybe used during Omnicam days and things like that, where you would actually cut out this portion and then come back in and refill in the data. And what we've seen is there can be generated some inaccuracies by how that stitches together. So if my assistant scans this full quadrant and then I come in and prep the tooth, I just simply scan in the prep and the software will stitch the prep right in there. But I mean, you don't have to do that. The prime scan's so quick. You could have the assistant or team member scan the upper and the bite, and then you come in and actually take the final impression. I just like to have that model work and everything done. So the only thing I'm really in charge of scanning is my interproximal contacts and the tooth that I prepped itself.
Are there any laws related to licensure for dental assistants and scanning?
So that's interesting. I will tell you that's probably state by state, and you should check. That's why I scan and marginate my restorations, or maybe one of the reasons I do. Some states do not allow assistants to take a final impression. South Carolina is one of those states where I practice. So I don't know what constitutes a final impression with something digital, because if my assistant scanned it and missed something and I wanted to go back in and rescan, that's a pretty simple thing to do. But legality wise, I don't really know. Again, I would say check with your state, but to me, I'm always scanning my prep myself, and whether it's one prep or 10. And I'm also always marginating those things myself. It's a way for me to kind of look at it. I'm the one that's been looking at those preps under loops for, you know, whatever amount of time I've been working on it. And I like to be the one that marginates it because I have been the one staring at it. The margins are very easy to see because of the color discrepancy. You'll see kind of pink tissue and white tooth and be able to draw that margin clean. But I still like to be the one in charge of that. When it comes to designing the restoration, if you have a good prep and adequate reduction, there's not a lot of design things that have to happen. The software is actually quite intuitive now and does 90 to 95% of the design for you. I would tell you, if you're having to spend a lot of time in the software designing the crown, there's probably a prep issue, whether it's under reduced or not smooth margins or something like that. So my assistants do that part. They finish the restoration, stain, glaze, polish, and then I'm the one that comes in and delivers it. But the final scan and the margination are both on me personally.
All right, that's all for the questions. We just had one comment that says, I believe they use the term reversible or irreversible.
Yeah, so, you know, the problem with using reversible or irreversible is I don't think any of that happens with a digital scanner. But I again, state by state kind of laws. My hygienists are different than hygienists in Illinois or New York or Texas. You know, here, my hygienists can do infiltrations, but they can't do blocks. They can't use lasers. There's all these different rules. But, you know, I go 2 hours north of me to North Carolina, and you can only have 2 hygienists per doctor. You can't have multiple hygienists without multiple doctors in the office. So I would just say relate to your state board and your state regulations and make sure you follow those. So I'm going to delete these catalogs that we have. And what I want to do now is I want to talk to you about doing full arch scans, because whether it's with implant cases, making surgical guides, or, you know, with my clear aligner cases, we're obviously taking full arch scans, or bite splints, we're taking full arch scans. So let's talk a little bit about how we do that, because sometimes, you know, people get relatively proficient at scanning quads, and then they start trying to scan a full arch and get a little lost. But we're going to do it the exact same way. Okay, we're going to really look at scanning a full arch as basically 2 quadrants. So I would start again on the distal, on that occlusal surface, come up to the midline, rotate down, get that lingual surface, come back up. Now rotate down and get the buccal surface. Now, when I come back up the occlusal this time, I'm just going to get the linguals of the anteriors. Then I'm going to scan the other quadrant, down the occlusal, rotate, get the buccal surface, back up the occlusal, down the lingual surface. Once I have those 2 quadrants done, now I'm going to finish filling in the anterior, and that's going to kind of stitch everything together. So in roughly, I don't know, 30 seconds or so, I have my full arch scan done. Now, what we have to look at, especially for doing something like aligner cases, is that this area right here, these interproximal embrasures are very important to get, because that is where the aligners are going to engage. So now that I have kind of the skeleton or framework of the full arch, I can come back and start scanning more interproximal here to make sure I'm filling in all these gaps and voids. And then maybe I rotate this around and I'll look and I'll say, hey, I missed the interproximal here at the anterior. Well, now I come back and get that information. And then the same here. So that we have all the imperative data kind of filled in. We're going to do the same on the lower. So again, starting on the most distal on the occlusal, all the way to the midline, down that buccal surface, that same linear scan up the occlusal, down the lingual, then coming back. This time maybe we pick the facial surface of the anteriors to connect to that other quad. Scanning that other quadrant, same linear fashion, occlusal, lingual, occlusal, buccal. And now I'm going to come back and finish that anterior to connect everything together. Now, again, we can rotate this around and start looking for missing data. I probably didn't pitch the camera, so I won't miss these interproximals. No problem. Now I come back in and I can look right at that interproximal surface, right at that interproximal surface, and make sure I have them filled in, and then turn it back off. Now I have an upper arch, I have a lower arch, and we need to relate the 2 together. So rather than just a single bite like we did before, the nice thing with the new software is it's going to allow me to take what we call a dual buccal bite, and it's going to recognize which side I'm on. So I'm going to turn it on, and I'm going to go ahead and scan the right side, and you're going to see that it stitches the 2 quadrants together. Well, now I'll take the camera and I'll actually scan the other side, and the software will pick up the other side automatically. And now I have a really accurate bite because I've been able to take my occlusion on both sides. The reason I like having this dual buccal bite feature is when I start doing bite splints, I can usually put a leaf gauge, Lucia jig, whatever your kind of occlusal philosophy is. When I have that in the anterior and I have the patient positioned where I want them, I can actually take this bite open, and it will mount those models or orient them to each other in space at that opening. I can then use that to generate, the bite splint. I can use that when I am doing the mandibular advancement devices for sleep apnea. As I'm moving that mandible forward, I can actually take this bite open and take that patient's bite at the protrusion that I want. So when I submit that to my lab that's fabricating the appliance for me, there's no guesstimate about where to put the patient. We're putting them at that mandibular advancement that we've already tested them at. So very easy. You saw 2 full arch scans there. There probably are little bubbles here and there, and that's because I'm working on a plastic model, but very, very easy to do. So any questions on anything with the full arch scan, anything with quadrant scanning, bites, dual buccal bite, anything with that?
Don't see anything, so I think we're good. Okay,
so what we'll move is now, since we have finished that area about, 10 minutes or so early, there's not a lot of Q&A. I'm going to switch back to the presentation. And since we're trying to kind of squeeze 2 days into one, I'm going to move a little bit quicker through the presentation, see if any other questions are generated, and we'll move along. So, we've done this quadrant scanning, and there were some questions about preparation already in terms of inlays and onlays. And I think it's important to discuss that because there's always been maybe this mindset or thought that we're prepping for CEREC. And the truth of the matter is that you're not prepping anything for the CEREC machine. The CEREC machine is simply imaging and then designing a restoration for me. What I'm prepping for is the type of restoration that I'm doing. So I'm going to prep a zirconia crown on number 30, a lot different than I prep an EMAX crown on number 30. And I'm going to prep a veneer of Empress different than I would prep maybe a PFM on number 8. So we need to make sure that we're prepping for the material, not necessarily for the CEREC, as you're seeing here on this slide. So let's talk about kind of all ceramic preps, what we need and what we should see with those type of preparations. And the thing that I like to start with in an interactive form is generally this slide, because I'll ask dentists kind of what they see in that top right photo and what their treatment plan would be. And it's interesting because, sometimes people will say, well, I'm just going to watch and do nothing. Other times people are like, oh, they're all 3 getting crowns. Somebody will tell me, well, maybe, that second premolar there is getting a crown. Maybe the other 2 are getting just direct composite resins. And again, I'm able to pick and choose what I want with the CEREC. In your office, this may be 3 crowns. This may be a direct composite, and a crown. Or it may just be watchful waiting. And I think it all depends on once this alloy is removed and seeing what that underlying tooth structure looks like. It's probably what would be the determining factor in my office. But when I look at this, I would say, I bet by the time I prep out this amalgam and get these cracks gone, I bet this mesiobuccal cusp comes off. So in my office, this is probably an onlay because I'm going to be replacing this cusp. Tooth structure being gone here, this is probably being some sort of full coverage ceramic crown. And then the first premolar here, I'm probably prepping this out and doing that inlay so that I can fabricate all 3 of these at the same time with the milling units and things here in the office. Same story goes here on the bottom. When you see some breakdown around this large occlusal composite or occlusal alloy, and you see this crack going toward the distal, it may be that in your practice standard, this is just another direct composite. Perhaps it's a crown. To me, it's going to be anesthetizing the patient, removing the alloy, and then seeing what happens with that cusp. And this is the scenario that I talked to you guys about early on in terms of the onlay. Patient walks in, they had a large existing restoration here. The cusp broke off, we have some recurrent decay. And, could doing a crown here be an appropriate treatment? And I think the short answer is sure. If I did not have my CEREC machine, I probably would be doing a crown here all day long, because it would be very difficult to impress an onlay. It's very difficult to temporize an onlay because of the type of draw that you have to prep for. Either the onlay temporization is going to come out, or it's going to lock in, and then you're going to have to be cutting it out and possibly altering the prep when you're doing that to go to deliver the final. But in my practice, because of the CEREC, I'm able to kind of clean up these broken areas, clean up this exit angle here interproximally, and just do this as an onlay restoration, being much more conservative and preserving almost all of these functional cusps, and definitely preserving the marginal ridge and things over here. So, all ceramic preps, again, this is what's so important with any digital system, honestly. But it's imperative to spend time on the preps. If you're having issues with design, if your lab's calling you often and giving you reduction copings back, or asking you to change from a glass ceramic to a zirconia, there's probably something going on with the prep, whether it's inadequate reduction or in not really smooth margins. And these are things that we want to correct on the front end, because if we work on them with actual, the drill and polishing and that kind of stuff, we save ourselves just tons of headaches and time in terms of fabricating the restoration. So, I don't know what you guys prep with. I use 4.5x loops. I'm definitely not using a microscope or 20x when I'm prepping teeth, but it's very easy to blow up your preps. And the common story from almost every new user with a CAD/CAM system is when they start seeing their preps blown up 20x, they're like, there's no way my prep looks like that. They think their preps are a lot smoother than they really are. And it's always nice to see how that changes over time. The more you start looking at your preps blown up that large, the more you start seeing what your lab has been dealing with on a day-to-day basis. You start really spending that time to finish and polish these preps so that you don't have those problems going down the road. There is instant feedback within the CEREC system. We'll talk about that a little bit later, maybe after the break, but we can look right away after we finish prepping to see if we have adequate or inadequate reduction. We can look and see if our margins are smooth or not. The software helps us with all of that. And we don't have to wait till we're already fabricating the restoration to figure out we don't have enough reduction. We can see it right away, go back and alter the prep, and then just simply rescan the area. We're not taking a new impression or anything like that. Just trying to be very, again, efficient and timely for us and the patient. So the whole kind of grand scheme of things is this sentence at the bottom, excellent preparations are the foundation for excellent restorations. And that goes with anything, whether it's a CAD/CAM, whether you're impressing in an analog manner and submitting this thing to a lab. If the preparations are not good, if it's not isolated, if you can't see the margin, you cannot have a good restoration. So those steps on the front end are just have-tos and things that we want to see to be able to generate good restorations for ourselves and for our patients. And I said this on the first slide, but there's no such thing as a CEREC preparation. I'm always preparing for whatever I'm using. Empress needs a different prep than Emax, and Emax needs a different prep than Zirconia. And those are just things we have to take into account. We cannot prep all teeth the exact same way and put different materials on there because each material has its own specific minimal thickness and ways of bonding and things like that. So, if I'm cementing a tooth, and we'll see if we have some time to get into bonding because that can be quite a talk. But if we're cementing a tooth, I need to have that really nice ferrule with that 6-degree taper of walls so that my restoration will be mechanically retained between the cement and the crown. And that's going to be something like I'm doing for zirconia. Zirconia is going to be a very traditional type of preparation. But if I'm doing something like a glass ceramic, whether it's Emax or some of these other hybrids that you guys are going to see later today, I'm probably not prepping that as conventional nor as retentive, because the only reason we prep things that way now, or maybe you prep that way now, is to retain your temporary. And if I'm making these things same day, I don't have a temporary to keep on there. So, when I'm doing these things out of Emax or other glass ceramics, I'm able to keep my margins kind of high and dry, kind of having them in enamel to bond to rather than taking so much tooth structure away. So that really needs to plan from, day one and the beginning of the appointment, is to say, what am I doing? Which material am I using? And then I'm going to prep in that manner. So, 2-plane axial reduction, this is stuff we all have in dental school and maybe forget and get away from. But if, we drop a chamfer all the way around this way, that's great. But if we don't start bringing in this second plane of reduction, these sharp points that are left right here are just going to be areas of stress and fracture, whether we're doing zirconia or if we're doing a glass ceramic. And we can use something such as this, just a little fine football diamond to go around and round off these edges. But this is the type of restoration that I'm looking for. I do not want a really sharp line angled anterior prep or posterior prep, because that's going to create two problems. One, it's going to have stress on the inside of that glass ceramic that I'm trying to deliver to the patient. But secondly, when we're milling restorations, there's a phenomenon that we have to know about called over milling. And I'm going to show you guys a diagram of that. And that'll happen when we leave these sharp images behind. But, this is a type of prep that all of you can do. And I hear the question all the time about, can CEREC image subgingival? Can you get that low? Of course you can, but you have to isolate the margin and you have to use proper retraction. And whether that's a cord or a laser or whatever you like to use, some sort of retraction paste, you can see here that we're actually relatively subgingival. And look at that nice bright white line of enamel that's still there. Even this far down below the tissue, there's still some enamel that we can bond to. But the key there is isolating that and getting all that tissue out of the way. If I just left all of this tissue over here, it doesn't matter if I'm putting polyvinyl, polyether, or scanning with a camera, nothing is going to be able to impress that margin unless the tissue and everything is gone. So this is that overmilling phenomenon I was talking about. And if you look at the premolar and the way it's been prepped here, you're going to see these sharp angles that are left on the occlusal surface. What happens in these milled restorations is that the diamond that's milling out the restoration has a very specific diameter. And when I leave a sharp point like this, that diamond only has two options. Either one, it can undermill this area because it can't get into this little tip right here. So if it undermills it, that means the restoration won't seat. We go to push it down and it's going to rock and bind on this area. Or the burr has to come in and overmill that ceramic and end up with a weak spot. And the reason this ends up being weak is if you were already under reduced, let's say we were to that minimal thickness of maybe 1 millimeter to 1.5 millimeters, and all of a sudden we over mill this area, now we have way less than 1 millimeter here, and we're going to start seeing some fractures and failures in our ceramics. The other problem that happens with these over milled areas, if we go back and look at this anterior restoration, if I left a really sharp angle here and it over milled the intaglio of that, whether it's on a CAD/CAM system in your office or whether it's coming from your lab, and you're using a cement and a translucent ceramic, then the cement's going to show through. You're going to start seeing these kind of headlights or bright spots right in the middle of your restorations. You're going to have this really nice veneer case or really nice anterior crown case. And after you deliver it, you're going to start seeing these white spots show through right where that overmilling was, where there's a big bulk of cement within that ceramic. So just extremely important to make sure we're rounding, smoothing all these sort of things because of this phenomenon that happens when you're generating milled restorations. I use this picture a lot. If you haven't seen the blue thing in the background, that's a rubber dam. So I always like some form of isolation. The go-to in my office, honestly, is an isolate. Whether I'm doing a direct composite, CEREC, whatever, everybody's getting an isolate in there. It keeps things dry. It keeps my work better because the tongue's not in the way, the cheek's not in the way, the patient's not, choking and gagging on their own spit and saliva. It's just a much cleaner and better way to work. But the important thing in this photo is the burr that you're seeing used. And I went ahead and put a blown up photo to the side of it with the Henry Schein item number. This is a Meisinger burr, and I like Meisinger. Brasler has some similar burrs. Kerr has some similar burrs. But the big deal here is occlusal reduction, okay? The most common problem that we see is inadequate occlusal reduction. The yellow stripe burr is a 2 millimeter burr. And you need to have 2 millimeters of occlusal reduction if you're going to be using a glass ceramic. If you're going to be using zirconia, I would use this exact same burr, except I would use the green stripe one. The green stripe burr is 1.5. You're not going to hit the pulp at 2 millimeters. You're not taking away too much tooth structure. You're not going to be having sensitivity because of 2 millimeters of reduction. If anything, generating, kind of pulpitis and sensitivity is our axial reduction and how much we're bringing in the walls of the tooth toward the pulp horns, not occlusal reduction. If your lab is calling you and asking you to spot the opposing tooth and do some reduction at time of delivery, if they're sending you reduction copings, if you're asking for an Emax crown and they call you back and say, hey, can we switch it to zirconia? It is because you are severely under reduced on this occlusal. Zirconia gives us a lot of leeway in terms of having less occlusal reduction. And a lot of people like the fit of zirconia, like the strengths of zirconia, and like how minimal reduction it can be. But I would tell you that every single zirconia restoration is milled. There's no other way to make zirconia. So if you like zirconia crowns, if you like the way they fit, then you like CAD/CAM dentistry. But we need to make sure that we're preparing for that material each time. So again, here's the part number. This is a Meisinger burr. Get the yellow one. Use it when you're doing glass ceramics, whether it's in the anterior for incisal edge reduction, or whether it's on the occlusal surface of posteriors. And if you're doing zirconia on the posterior, use the green stripe one because that's 1.5. So again, here's what I'm wanting to see. When I'm doing an adhesively bonded ceramic. So when I'm actually bonding in glass ceramics, I need to have minimally this amount of reduction. And if you're seeing CERECs in your practice, or you're seeing your own CERECs or glass ceramics come back with very flat occlusal surfaces, not very much anatomy, it's because they're under reduced. If I don't have this rise and fall of 2 millimeters, I cannot generate anatomy. If you're seeing really flat, provisional, temporary looking type of restorations, again, it's generally always an occlusal reduction issue. You don't have the room from the opposing tooth to have rise and fall. You've only reduced 1 millimeter, so everything ends up looking really flat all the way across. So using that burr that we showed is just kind of the key to getting that right. Now, this adhesively bonded, and we're saying that you need 1 millimeter actually, 2 millimeters over the cusp and 1.5 at the fissure. That is if these are bonded. And again, if we have time, I'll get into bonding a little bit, but I do not mean a self-adhesive bonding cement when I say adhesively bonded restorations. Taking an Emax crown and putting it on with SpeedSim, Unisim, MaxSim, anything like that is not adhesively bonding, and that will probably fail because of the lack of occlusal reduction. The only way that EMAX or other glass ceramics are going to get their strength that they need is one, again, adequate occlusal reduction, but two, they have to be bonded to place. And that's where we're talking about using a true bonding system, something that has a primer or a bonding agent or something that's going on the tooth, etching and silinating the inside of that ceramic, and then, cementing, bonding the two of these things together. If you're just taking a one-step cement, nothing to the tooth, you really should be having more occlusal reduction, because EMAX can be cemented and it's indicated for that, but it has to be at least 2 millimeters at the fissure to survive that kind of thing and have the strength that it needs. So if we're getting 2 millimeters at the fissure, that means we're taking away even more. And that's why people like zirconia, right? Because we can get away with less reduction, but we still need adequate reduction to pipe, no matter what the material is. So a little different with zirconia. We're cementing this on, so I can get away with 0.7 at my central groove on zirconia. I tell you guys 1, because if I tell you 0.7, then you'll do 0.5, and then it's going to break. And that's just what we do as dentists. So make sure you're using that 1.5 millimeter burr when you're doing zirconia. You're definitely not going to see pulp anywhere 1.5 millimeters into the tooth. And that's going to allow you to have some rise and fall and be able to generate some anatomy. Much more important that we have this ferrule and really nice tall walls when we're cementing something on with zirconia. We need that mechanical retention to keep it on the tooth compared to what we're doing when we bond a glass ceramic in. And there's multiple types of margins that can be done with glass ceramics. You can do a shoulder, you can do a chamfer. Honestly, what I'm doing 90% of the time is a chamfer. Anytime I can keep it super gingival, I do. But when you're doing zirconia, a little different. You can bevel, you can do a light chamfer, you can do a knife edge. The problem with a knife edge restoration is really kind of determining where that margin is at. Doing this with gold is a little easier because then you can kind of burnish it and make sure that's smooth. But with zirconia, I think this is a little tough for either you to marginate and design or for your lab. So I still stick with a lighter chamfer when I'm doing zirconia. And super gingival obviously is better. I'm high and dry, and this is going to be easier to bond to. But the world I live in is taking out old restorations and restoring teeth that have already been restored probably once or twice. So those are at least equigingival, and if not, they're usually subgingival. Okay, so this is my day-to-day right here. The issue with subgingival restorations is a lot of times patients and dentists will leave these sort of margins. And that's because our burr comes in and it's rounded and we're prepping. And as we come away, we leave this little lip or this little J or ski jump here. And we gotta have a way to get rid of this, because if we don't, we're gonna start seeing a couple of things on our radiographs. One, the ceramic is gonna be really thin right here, so it's probably gonna chip away a little bit or not mill adequately. And second, this is gonna be very weak tooth structure to bond to. So what happens sometimes on these post-op bite wings when your prep looks like this is you start seeing things that look like open margins. So the way that I get rid of this is once I finish prepping with my coarse diamond, I always go back and finish with a fine diamond of the same size. And then my last step of any prep is a slow speed carbide round burr, and not rotating into the pulpal wall, but laid on its side and rotating in this direction. So that may be a 2 or a 4 or a 6. And as I take that slow speed carbide round burr through here, it starts knocking off all of these little lips. The other thing that happens is any little tissue tags that were left behind from the diamond going subgingival here and maybe leaving little, bits and stuff here that are going to affect my image, that carbide cleans all that off and cleaves it away. So we end up with a nice, slick, smooth margin all the way around. And that's what I want to see each time. These are some images here of kind of the difference in preparations. You're going to see the all ceramic prep on the left. That's a pretty heavy chamfer, maybe even a shoulder, compared to the zirconia prep on the right. Obviously more occlusal reduction on the left and more axial reduction because we're bonding that ceramic to place. We're mechanically retaining the zirconia with the cement, and then the zirconia in itself is a much stronger material. So we can alter our prep a little bit and be more conservative in some manners than with the glass ceramic. But again, this kind of becomes a little bit of semantics, because I would argue with you that a lot of times my all ceramic preps are actually much more conservative than my zirconia preps. And the one thing I'm talking about there is when you start thinking about second molars in the mandibular arch. So if I'm looking at number 18 or number 31, and I have this really big distal retromolar pad, the only way I can put a zirconia crown there is to drop that margin a mile below that tissue and really prep that tooth away. And now I'm working quite subgingival, and I've put this really deep subgingival margin on the patient that they're going to have to maintain. I have to prep that way because, again, I need that mechanical retention and that ferrule from the zirconia prep to keep it on. Controversy, you know, the other side of that is if I do something like Emax and I'm bonding it, once I get my 2 millimeters of reduction on the occlusal surface, I may not have to drop a margin at all in the distal. I may keep that margin right at the tissue level or high and dry and drop my margin around the facial and the interproximal to the mesial, but I don't have to go that mile subgingival to get ferrule because I'm bonding my Emax on. So you have to look at each tooth and each clinical situation a little differently. What's the clinical crown? How tall is it? What material am I using and why? And there are times that, again, I think that Emax and other bonded glass ceramics can be actually quite a bit more conservative than having to prep so deep axially to get ferrule with something like zirconia. I love preparation kits. I use these all the time. Later today, you're going to see an anterior case, and you're going to see me using these sort of burrs on it. But this is how I do every prep, right? So whether I'm doing 8 teeth, 10 teeth, 1 tooth, it doesn't matter. Everything starts with some sort of occlusal reduction burr so that I know I'm getting the right occlusal reduction for that material. And then the facial surfaces across anterior teeth, I want to keep that glass ceramic the same thickness on every single tooth. So what I'll use is this reduction burr to make sure that I have adequate reduction and uniform reduction across those teeth, because otherwise I'm going to start having value issues and shade issues as that tooth stump starts bleeding through my translucent ceramic and things not matching. I'd also recommend having a red stripe diamond such as this to match any coarse diamond that you're using. So if you're using like an 858, 016, or 014 in a black or green stripe, then finish it with a red stripe to make sure those are really nice and smooth. You'll get a better bond strength that way. You know, and there were some questions about onlay preps. This is not the best example of an onlay prep. This is the one we have in the presentation, and it's so that I can kind of talk to you a little bit about it. I love this emergence here going toward the lingual. I do not like this emergence here going toward the buccal. This angle right here is going to be a lot of stress for a glass ceramic. It would be better to have this flowing smooth out, just like you see right here. I don't know if this is a little bit of decay. That looks like, to me, that should be cleaned up a little bit, but I do like seeing this nice, smooth, crisp enamel margin all the way around. But this is the type of angles we want to avoid. This is what we want to accomplish. And, you know, the same thing goes for the interproximal and the occlusal surfaces. So, you know, if we leave a bevel like this, if we don't have this as a butt joint, then what happens is the ceramic at this area gets very thin. The patient's going to function on this over time, and we're going to get some chipping on the occlusal surface. So you don't want this sort of bevel. This is more gold style prep, not ceramic. Ceramic needs a butt joint all the way up so that we have this uniform thickness all the way to the occlusal surface. Same goes interproximally. We end up with these little kind of J's or hooks interproximally. It's very difficult to image that. It's also very difficult to bond to it, and it's going to be difficult for the patient to clean it. The patient already had decay, most likely interproximally. That's why we're doing this sort of MOD type of prep. And now you've just put that margin right back where they had the decay before, interproximal, where they're not brushing and flossing it. When you're doing these inlay type preps, the right way to prep it, rather than taking a 245 or a 330 or whatever you use and dropping a box and exiting out to the buccal and lingual, the right way to do it is to come from the buccal into the box in this direction and into the box from this direction. What that allows you to do is get an entry angle like this rather than like that. Now, two things have happened. One, I can image this very well. That's going to be easier to seat my restoration than this is going to be. But the other thing is now the patient's toothbrush is going to hit this rather than having to worry about flossing and stuff here. So don't try to save every single little enamel rod like that and give yourself trouble, because that's going to be a nightmare for you and the patient. Do it more open and polished like you see on the other side. And then, you know, these are the type of things that we want to avoid in regards to preparation. This isthmus is way too skinny. Even if I were doing a direct resin, I wouldn't keep this small. The C factors and stuff there, I just don't like that. This is okay. It's got that little bit of an overhang, but at least it's open enough. I would rather see this exit angle come out. I like this exit angle here on the buccal. This is terrible. This is actually okay, but all this needs to be opened up more. Doing a prep like this has not done the patient any good. If you were to do something in gold, I guess you could seat that there. But that's not the type of restorations we're talking about. We're talking about using glass ceramics or hybrids, and we need to have these more open and flowing to be able to accomplish something like that. And then the last step is some sort of gingival retraction, whether you use cord, something like retraction paste, Expasil, copper cap, like you see on the bottom left, or a laser. All of them work. I'm not going to tell you that you need to switch whatever you're doing, but the bigger thing is if you can't see the restoration, you can't see the margin you've prepped, then the camera can't either. You have to have these things isolated well enough so that you can see it and the camera can see it. As long as you can see your margin, the camera is going to be able to get to it just fine. But if it's covered in blood and tissue and schmutz like that, there's just no way to get an accurate type of impression or accurate type of record. But when we do these sort of things and we isolate well, these are the type of scans that we get. You can see the cord packed on that number 31. You see this kind of dark purple cord. You see red tissue cord, and then this makes it very easy to draw this margin. Same here, cord in this area, and you're going to be able to see the change. So good preps, good isolation. I mean, just basics of dentistry that I think sometimes we get away from because, either it's quicker to just take an impression and send it off to the lab and cross your fingers, and hopefully the lab can figure it out for you. But you really need to take some time to make sure this prep is right for the material you're using, and to make sure that we have good isolation so that we can design our crowns and other restorations well. So before I move on to the next step, I'm going to jump into some Q&A here. First one, can you go back to the slide and what the burr is called? Yeah, let me do that because I have that burr throughout the presentation. But I want to make sure you guys have that, because the one I like is this Meisinger one. They last forever. And that's the very first burr I pick up anytime I'm doing a crown or an onlay or a veneer. I always do an occlusal reduction burr because I need to make sure that I have the appropriate reduction for whatever material I'm using. I need that, like I said, even for a veneer, I need perhaps 2 millimeters at the incisal edge for my glass ceramic to survive. So I may be prepping 2 millimeters of the incisal edge off, very minimal reduction elsewhere. But I really want to make sure I'm having the right reduction for the material I'm using. Can you mill a margin that is 0.7 millimeters, or will you have issues due to overmilling? So let's talk about that a little bit. The issues that you're going to have on a margin like this is not overmilling, okay? What's gonna determine this margin and its integrity is the material that you selected. So let's say we use something like Emax. Emax is a very strong glass ceramic. It's great material. We've been using it for years. I still use it daily. I like the aesthetics of it, everything. But Emax at a very thin margin can get chippy, okay? You have two burrs that are going against the block like this. And that's a very rough environment. Even on a fine milling mode, taking off less ceramic per swipe, it's still a diamond grinding against a weak glass because that Emax hasn't been fired yet. And if you try to mill a very thin margin with Emax, you may come out and see little chips in it. Conversely, if you're doing it out of something like zirconia or a hybrid ceramic, which we'll talk about a little bit, like a CEREC or one of these hybrid resins and ceramics mixed together, those margins on those products are incredibly stable. The resin component of the hybrid blocks keeps the margin from chipping, so those will come out knife edge and clean. The zirconia, because it's so soft before it's fired, and I'm going to get into processing zirconia a little bit so you guys can see it, but it's so soft and milled so much larger. Zirconia shrinks quite a bit when it's centered that you can do the knife edge there and not see the chipping in zirconia. So that's really going to be kind of the bigger issue. When I'm doing veneers with my CEREC machine, whether I'm doing out of Empress or Emax or whatever, I'm usually bulking up those margins so that they don't chip. I don't see any chipping at all coming out of the mill. And then I'm just finishing them by hand chairside with a wheel. And that way I know I get a really nice, crisp, clean margin. The last thing I want is to mill out some veneers and the margins be chippy everywhere. That's just obviously not ideal. Can you review the ski slope slide and it appearing as an open margin on the radiograph? For sure. So let me go back to that picture so you guys can see it, because I usually have a lot of questions about that ski slope and what's happening there. But we got to think about what goes on in terms of milling the restoration and what goes on in terms of what you're seeing on the radiograph. So remember we talked about just now how we can get chippy at the margin if we have something really thin. If you look at this margin and you have this really thin margin, what we'll see right here is the glass ceramic. When you're trying to marginate this, the machine cannot mill this little margin right here, okay? Because the margin is now a positive. So you're asking that diamond burr to come in there and make this small little undercut that we know it can't do. So one of two things is gonna happen. When you go to bond this in, it's gonna not be closed. You're gonna see that two structure, and then you're gonna see a gap right here because your ceramic is here. Now, it milled the rest of the restoration perfectly. It matched the pulpal wall, it matched the occlusal surface, it even seated here. But when you take your bite wing, now you see a gap over here. Hopefully that makes sense. That's why when I take that round burr, I don't go down and have it spinning this way into the pulpal wall, right? I lay that round burr on its side. Now it's spinning in this direction. So as it's rotating like this, it's rotating against this ski slope like this, not touching the pulpal wall, not making an undercut here, in this direction. And that's where using a 2 or a 4 or a 6 just depends on what type of preparation you have. But that smooths these off. Now I have a nice clean flat margin that I can image and bond to, and those bite wings should look really crisp and nice for you. When you do a bonded restoration, how much priority do you give to resistance and retention form? I would say very little. I am all about conserving the enamel that I can, because that's where my bond strength is coming from. Partial coverage restorations, inlays and onlays, are inherently retentive because they have so much enamel remaining. You're not going to have an issue there. Do I recommend kind of flat tabletop molar preps? I do not. That's not what I like. I find that those are difficult to seat. They kind of float around in the resin. So I do like to have a margin, but it could be that my lingual margins are really high and dry. Once I knock my 2 millimeters off, I may not drop a chamfer on the lingual at all, only interproximally into the buccal, and trying to keep that, again, as conservative as possible. I'm not worried about that restoration debonding, but I am using a bonding system, and I am preparing the ceramic with an etch and a silane and that kind of stuff. So I know those bond strengths are there. If I were doing a glass ceramic, then I was using a self-adhesive resin, again, something with the word sim in it, right? Unisim, Maxim, Speed Sim, whatever. Then yeah, I'm going to be prepping those retentively because I know that the bond strengths aren't there with those materials. There's nothing wrong with those cements. They work great. They clean up great. But they are going to require retention form and resistance form. Otherwise, you're going to see these glass ceramics breaking and coming off. Can you go back to the preparation slide for ceramic preps? Yeah, for sure. Let me skip back a little bit here. So I think this is the slide you were wanting to see. I don't know if you had any questions on it or just wanted to see it, but you know, I think the thing to reiterate here is to talk about how important adequate occlusal reduction is, because we need that to have this rise and fall. You can imagine here, if I only did maybe 1.5 millimeters all the way across, well, I can have, you know, the right amount of thickness at the fissure, but I don't have the ability to generate 2 millimeters over the cusps and generate any anatomy. So that means the entire surface of this restoration is going to look very, very flat. The only way I can get rise and fall is to then get below my minimal thickness in the middle. And we don't want to do that because we risk fracture of the ceramic. So having adequate reduction is what's going to be able to give you anatomy. And I hope that answers your question there. Have you tried ultrasonics to smooth the margins? No, I guess. I mean, I have just always used a matching red stripe fine diamond and then using a carbide round burr to smooth it off. That's kind of been my go-to for years. I know some people, even finish margins with like white stones that they trim themselves to fit into a handpiece and different things like that. 1,000 ways to skin that cat, whatever suits you, but the more important thing is to make sure that those margins are really crisp and clean and isolated. See if there's anything in the chat over here. Who supports the system directly? The system is down. Do we get compensated for cases while the machine is being fixed? So the support network with Shine is honestly fantastic. I haven't really had many problems with my CEREC in the past 11 plus years. Maybe I've been down like a day or something with it. So, and that's, that was, gosh, probably with the Blue Cam and not with even in the newer systems. Shine is always great about, pick up the phone. You also have Tech Central that can dial in to the machine if you're having some network issues or something like that. But the system and the support network between Shine and Dentsply Sirona is something that I really like. And that's why all of my products are with Shine and Sirona, whether it's my cone beam, my sensors, my prime scan, all the mills in the office, everything is supported by them. So I really like that system. What if the system is down? Do we get compensated for the cases? I don't know what the real ask is there. I mean, if you buy a CEREC machine and it's non-functional for a day, I don't think Shine or Dentsply is going to compensate you for the fact that your machine is down. I think that you would just kind of continue forward with whatever you have been doing in the past, meaning, fabricating a temporary or provisional or something like that until it's fixed. But again, I haven't been in that case in a while. Another question is, my Emax crowns fit well in the purple state, but not the same fit after speed fire. Not all the time. Sometimes I feel like the crown is shrinking. So Emax should not have any dimensional change when it's fired, but there are some things that can happen during finishing, whether it's the crystallization process of Emax or if it is the polishing afterwards that can affect the fit. One is Emax needs to be properly supported. Otherwise, it's not going to shrink, but it can kind of slump a little bit. The crystallization temperature of Emax is such that it gets really close to the melting phase of that glass ceramic. And if it's not supported by, some sort of putty or peg material, then you can get some distortion there. That's one. Two is I would ask you what your bonding procedure is, and if that's where you're noticing the fit not being great. So a lot of times bonding protocols require that the bonding agent be cured to the prep, and then the crown seated over that cured bonding resin with some cement. So if we look at this one, for example, if you scrubbed your bond in here and then air thinned it and cured, and you did not thin the bonding agent all the way, you left some pooled here or some pooled on the margins. When you go to seat that restoration, it's not going to seat all the way, or it may seat close, and then all of a sudden it feels high to you, or you check the bite and it's high. And a lot of that goes to bonding protocols and procedures. The other problem that can happen in this phase it depends on if you're polishing the glass ceramics, but sometimes I'll hear that my contacts are really nice interproximally in the purple phase, and then after I fired them, I feel like my contacts are open. And that goes back to the same thing. One, making sure the product is supported well. Two, if you or your assistants are polishing these restorations to finish them, then depending on the polishing wheel and the abrasiveness of it, you can actually open a contact pretty easily by polishing just a little too much. So I would be checking that. The other thing that can happen too, and it happens more often on second molars, but you tried in the mesial contact of 18 feels good to 19. There is no number 17. When you go to bond it in, remember, glass ceramics have a die spacer built into them to accommodate the resin because it needs that for strength. So it's possible that when you try this in, you're holding it with your finger, your assistant flosses it, you say, oh yeah, that's a great contact. Then you go and fire it. When you come back and bond it to place, if you're not holding that glass ceramic crown against the tooth and pushing mesial, because of that dye spacer being 120 microns around the prep, it's possible that your restoration shifts a little bit distal. And then when you go to floss, you got a bonded restoration with a wide open contact. So oftentimes what I'll tell individuals to do at first is to design that contact of the restoration. If it has no distal neighbor, design it a little heavier. That way we make sure we get that good contact, even if we do have a slight movement of that restoration on the prep. What is your opinion of materials not requiring a firing crystallization phase for posterior onlays? I would tell you that that's what I use for every single one of my onlays. I don't use zirconia or true glass ceramics anymore for onlays. Everything that I'm doing in layer onlay is being done out of a resilient / hybrid ceramic. I'll see if we have some time today. We can run through materials to make sure that you guys at least get a listing of what those things would be, because unless you're doing CAD CAM, you're probably not used to looking at a lot of different hybrid ceramics. But I stick to two, Tetric CAD from Ivoclar, I like a lot, and then CEREC from GC. Those are the two that I use in my office in terms of kind of these resilient or hybrid glass ceramics. But anytime I'm doing anything partial coverage, it's always one of those two. I'm not using Emax or Empress or any of those materials any longer, because I think the benefits, the milling ability, and even kind of the flexural strength of those resilient ceramics all suit it to being a posterior partial coverage restoration, ideally every time. Would I be doing full coverage restorations with those? I don't think so. I mean, that's where I'm going to stick with my zirconia, my Emax, my stronger glass ceramics, or things like zirconia too. But partial coverage, always going with a resilient ceramic in my office. Doesn't mean that's the right thing to do all the time. Just means that's what works in my hands, right? I think that was the last one of the Q&A. So if there's no questions about preps, and now we've talked about onlay preps and these sort of things, what I'd like to do is move forward a little bit into the software and talk to you about kind of a partial coverage restoration and an onlay. But I think it's important before we do that to talk about the milling process. We've covered it a little bit over milling and how this affects the fit, but I want to show you kind of the new mill and what would be happening if we were doing this live. And so the prime mill is new, right? This came out in January, February of 2020. It's here in my practice. It is fantastic, super fast. This touch screen that you see on the right side is so intuitive. You can put your blocks in ahead of time. Every burr has a little RFID chip that you stick right here, and it knows the life of the burr. You can see here it says 75 or 85%. It tracks it, tells you when it's time to change it, does it automatically, flips it forward. All you have to do is unscrew it and screw it in. Also has a camera on the front. The camera here on the front is going to be taking pictures of QR codes, so no more kind of keying in the block or anything. The blocks will be coming out with QR codes on that you can just scan. But the really cool thing that I like is this touch process. So, when we start talking about day-to-day use of the machine and how this fits within my practice, it used to be that we would have to get the entire restoration designed. And then once the entire restoration was designed, the machine would do a touch process, which would take about 1.5 minutes, maybe 2 minutes, where the burrs come out and confirm that the right block is in there. And that was always frustrating to me, honestly, because I knew I was going to do an Emax restoration, or I knew I was going to do zirconia. So why not have the mill go ahead and touch the block first, so that by the time I'm done milling it, it can just start and save myself that 2 or 3 minutes. And that's what happens now. So the touch process that happens first, it knows what the material is, and it goes ahead and is just waiting. So there's no more of that touch process. Once you hit mill, it's just ready to start milling. The other thing that's new is going to be this super fast milling option. The super fast milling option is going to be present for zirconia, and I'm going to be able to generate a zirconia crown in roughly 4 minutes. It's really just been a game changer in my office to be able to do zirconia that quickly. Between that and the 12 to 15 minute firing cycle in the speed fire oven, I mean, we can have zirconia crowns done in an hour. And that's just something that was unheard of even, a year ago. So let's talk about what that process looks like. Here you see on the screen the proposal of the crown. We hit start, and we're not going to have the touch process again. Remember, it's already done for us. So what's going to happen is, rather than having the touch process go, we're going to go right into milling it. And then in this super fast mode, you're going to see how soft zirconia is, and you're going to see how fast these carbide burrs start whittling it away. But it's really something incredible to watch, to see how fast these are generated. Patients love watching this in our practice. You can see here 4.5 minutes to make a crown. It's really impressive to see. So, you know, we do our zirconia milling. You could do it on fine mill. We're about 18.5 minutes. You can do it on super fast mill. Again, not much difference. You are going to see some of these little ridges, but these are simply polished away with a burr before we center it. And then here's the extra fine mill, maybe a little bit more occlusal anatomy done, but nothing significant in my mind. I'm always sticking with this fast mill mode. Same with Emax. Emax does have a fast mill option in the prime mill. I would tell you right now that has been removed while it's being tested. But there is going to be a fast mill option where you're making an Emax crown, again, in roughly 3.5 minutes, okay? Super fast to generate a glass ceramic that way. So between the prime scan, the new CEREC software, and the prime mill, we can get a restoration from the time we scan it, marginate it, and mill it to about 6 minutes. Then we have our 14-minute fire time for Emax. So 20 minutes to get a restoration is just an incredible time frame. So if there's no questions on the mill, then what I'm going to do is switch over and do a demo for you guys of the actual process and what it looks like to generate a restoration. So let's go back to, well, let me delete these first and get rid of everything here, and then we'll go through it. So remember, you know, the CEREC software, we talked about how everything goes from left to right. So if I go back to the administration screen and I get rid of this restoration, I have a typodont that is prepared for a partial coverage onlay on number 14. So what we're going to do is go here. We're going to be doing a single unit restoration. That's the onlay. Auto detect, so it's going to figure out whether it's an onlay or a crown just from the prep. We're going to do biogeneric individual, and that's where we're going to kind of live over today's, you know, examples and things like that. I'll try to get into biocopy a little bit and show you guys an example of that this afternoon in our advanced section if we have time. And then we're going to pick our material. Again, I told you I really like CeraSmart or these glass hybrid ceramics for partial coverage. And then I have my mills. So here, if you had, you know, you have the prime mill and the other two mills, you can pick whichever one you want. Now I'm going to pick number 14. And I'm going to check on the right side, the case details, make sure that I have the right material, the right tooth selected, everything done ahead of time. So here we see auto detect, single unit number 14, GC CeraSmart. And if I wanted to change anything, I would just click on the pencil and I could change the CeraSmart to, let's say we were going to do it out of Tetric CAD instead, which is the other hybrid ceramic. You just hit the check mark there, go back and check my details and make sure everything looks good. Once I have that done, the next box is going to open. I'll click there and it's going to let me move forward again to imaging. So we're going to image this upper left quad, and I'm only going to image the tooth itself. I'm not going to do a bite or an opposing, just so you guys can see how good the software is even without those sort of things. So we're going to image down the buccal, come back up over the occlusal, down the lingual, and then finishing on that occlusal surface. Now remember, you know, I don't have to get every single detail in that first pass, but I want to check, and I, you know, inherently I'm going to miss interproximal and probably a little bit here on the margin. So now that I have this framework, I can just simply come back in and image anything that I've missed to make sure I have really good data everywhere around the restoration that I'm kind of fabricating. Now, what I want you to notice in this kind of half arch image is all the way around my restoration, I'm really clean. Everything looks good. Down below the margin, everything looks nice. The interproximal contact imaged well, okay? Now, I am missing some data back here on the mesial of number 1 and on the mesial of number 2. But that really is inconsequential. It doesn't matter. So don't feel like you got to include every single bit of data. This does nothing for the restoration that I'm doing over here. This does nothing if I was taking a bite in an occlusion, would not matter. Now, if I had a big hole in the occlusal surface or a cusp, or definitely if I had a hole interproximally here, I'd go back and fill that in. And I'm not telling you to be sloppy, but what I'm telling you is this data missing doesn't matter. So spending a lot of extra time scanning that stuff is kind of a waste. So let's move forward. And what we're gonna see here is this is gonna be our first time today moving forward and actually looking at a working model. And I wanna walk you guys through a couple of steps that you may see in the software. Most of the time when you're scanning an upper, a lower, and a bite, you're gonna have the model axis, okay, or the orientation of the model already done for you. You're also gonna have the margination done for you that you can go in and correct. But in this step, because I didn't take a bite and because I didn't take an opposing, I'm gonna have to do those two things myself. So let's look at what we have. When we see this model and we see our scan, this back kind of opaque area, these are molars, this is premolars, this is anterior. So I'm simply just moving the model to fit that frame. And I wanna make sure, sometimes my mouse working remotely doesn't work as well. So I wanna go through and start rotating this around and getting everything in a relatively correct position, okay? It doesn't have to be specific, but I want this kind of my anteriors here, premolars, molars. The next thing I'm gonna look at is this bottom left box. And this is my curve of speed. So I'm gonna move up my occlusion. I'm gonna kind of level it out. And then the last thing I'm gonna look at is my curve of Wilson. I'm gonna rotate this around. Now, once I've rotated the curve of Wilson where I want it, I may have seen the model change here. Now I'll rotate this a little bit. I'm just using that line as a reference. You don't have to line it up there. And now I want to make sure I'm kind of looking down the long axis of my prep, which I am, and now we can move forward. Again, if you're taking an upper, a lower, and a bite, you're never going to see this screen. It all happens in the background, but it's at least important to kind of cover what's happening. Once I have that done, again, we're moving, remember, always from left to right. The next step is going to be draw margin. And in a scenario where you have taken an opposing model, this margin is going to be drawn for you already. But since we did not, we have to draw it ourselves. This gives us a chance to kind of roll around and look at our images. You can see how nice and crisp and clean this is once that model has been processed compared to what we saw in that acquisition window. And those holes that we left behind, the software filled it in for me. See the little kind of stone almost that's been put in those holes? Honestly, that's not accurate, right? We know that there's not this sort of shape on that tooth, but that doesn't matter. My restoration is not fitting there. There's no occlusion there. So inconsequential to what we're doing. This is where we talk about the prep being so important. If you're blowing up your preps this large, you're going to be humbled a little bit by it. If you haven't really polished or cleaned these margins, you're going to start seeing what your lab's been trying to see and trying to figure out where the margin is at. But if you've isolated it well, imaged it well, have good retraction, this is going to be a breeze. You're going to see pink tissue, white tooth, and it's going to be super easy to draw your margin. The margination tool in the software has been greatly improved. What I would tell you is, as a dentist, okay, it's our nature to want to click and kind of creep our way all the way around this margin really slow, or maybe click, 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 click. And that's just the wrong way to go about it. The software, if you have a good prep, if you have a clean margin, is really good at finding it. So what I do is I double click to start, and you can go around the prep, but after you cross kind of this equator of the prep, you're gonna see my line jump. So it's gonna have to be tacked down, okay? And so what I do is I get halfway, tack it, you can go the rest of the way around, and double click, and now my margin is done. Now, it doesn't even have to really take that long. The way that I normally will do these restorations is I will double click, I will go straight across the prep, single click, I will go straight back across the prep and double click. And you can see that the software has found my margin extremely well. Now, maybe you don't like this little bleb right there. Well, you can always come in and change this. Double click, make your line, single click, and now maybe you like this better, okay? Feel free to alter that at any time, but the margination tool works extremely well as long as, again, you have given it a good prep. So once we have our margin down, the next step we're going to look at is insertion axis. So the insertion axis is going to show us if we have any undercuts. If you rotate this model, you're going to see this big yellow area. And if that was your insertion axis, so that was the way you wanted to put it in, the software would actually block that out when it's making the restoration. I usually like to rotate this around and make sure I'm looking directly down the long axis of my prep, which I am here. We're going to click OK. We're not going to do the prep analysis here because we didn't take an opposing, so there's nothing to really compare. But we are going to go forward, and when we go forward, what's going to happen is the software is going to start doing this dance, right? It's taking that tooth and trying to fit it in to the area that we see. And even without an opposing model, I think hopefully you guys would agree that this is a really nice initial proposal. There's not a lot that I would want to change here. Now, we're not going to see any occlusion mark. We'll do that on the next thing after lunch because I didn't take an opposing model again. But, I mean, the cusp tips are in line. The marginal ridges are in line. Everything looks really good. And I want to work with you guys on just a few tools so you can see how the software functions. But, you know, if everything overall looks pretty good, a lot of times I'll hear on this proposal, maybe someone wants a little bit broader of a contact. Okay, well, let's say, you know, we have this tool called the circular shape tool. And what it allows me to do is kind of move the ceramic around how I want. So perhaps I wanted to make this a little broader to the buccal. So I would maybe bring this a little bit out. Maybe I want to make it a little broader to the lingual. Bring this a little bit out. Now I'll look down and maybe someone likes that contact better. So, okay, fine. We have this nice broad contact. But how do we know how tight that contact is? Well, we need to look at where the ceramic is touching the adjacent tooth. And there's two ways of doing that. One, I can turn off the upper jaw. Now I'm just looking at the glass ceramic. This kind of heat map or color lets me know how much pressure is there. I will tell you red, yellow, and even green probably won't seat. In my practice, I like to have it blue. So the tool that I'm going to use for that, you saw the circular tool just now. The tool I'm going to use here is the smooth tool. And the smooth tool is just almost like, you know, those waxing torches you had in dental school where you would just kind of blow a little heat on there and it flattens it some. So now we've gotten to this nice blue contact. And when I turn the upper jaw back on, I still have this nice broad contact, but in my practice, this is the type of contact that I like. Okay, this is the color that's going to be nice for floss. This is the color that's not going to have anything catch, and it's going to allow me to seat the restoration. There's only one problem, though, with turning off the upper jaw and adjusting this contact. And that problem is that if I'm using the smooth tool, it's really easy to go around a couple times. And when I turn this upper jaw on, all of a sudden, I've totally opened the contact. You know, we can see all the way through. And that's not really great. Nobody wants that, you know, for the restoration. No one wants anything packing in there all the time. And I want this to be predictable for my assistants every time they're designing the restoration. So if we go back to where we had this really broad, heavy contact again, the trick to adjusting these interproximal contacts is to actually roll this model upside down and leaving it on. There's that big red contact we saw. Remember, if I turn the model off, we're looking at it interproximally. If I turn the model back on, now we're looking at where that glass ceramic is penetrating through the adjacent tooth or being too heavy and it won't seat. So what I can do is go right back to that smooth tool that I had, and from underneath the model, smooth this away. Now, I smooth it away until the green is gone, and now I can do this all day. It doesn't matter how long the smooth tool stays here. I'm always going to get a nice broad blue contact. This adjacent tooth, which is the premolar that we're looking at, okay, we're going to reset it so you can see it again. The adjacent tooth here acts like a shield or almost protects me from taking away too much of that interproximal contact. So again, this is the easiest way for you or your assistants to adjust the contact. Smooth from underneath, turn it off. You can see that little speckle of green that was left there. You can always take that away if you like. I don't like any green. It tends to be too tight. For me, I like to have a more passive fit without having to really push it in. Some individuals like tighter interproximal contacts, obviously design it to what you want. But this is kind of where I would be. Even talking through this, I think that design process took 3 minutes. So shouldn't take very long. As long as the prep is good, the images are good, you're gonna get a really nice proposal. And there's one step left to do after we get our contacts right. The last step is we want to actually make the restoration, right? We gotta manufacture it. And so what we want to do is when we look at the restoration, the software is going to propose this sprue, or what's going to be left behind while it's milling that out of the glass ceramic, in the ideal location to mill it. So what's going to be the most efficient milling strategy? The software is going to put the sprue there. The reason we check that before we go ahead and hit start on our mill is because if the sprue is proposed here on my interproximal contact, we have just spent all this time making sure that that contact was good, and now this sprue is going to be right here and bumping into the tooth, and I don't want that to affect my contact. So the last step before I hit start at any time is to make sure that that sprue is either on a buccal surface or a lingual surface or somewhere not interproximal, so that I can avoid having those kind of contact issues after the restoration has been made. This sort of material out of CEREC, if I were to go downstairs and mill this in the practice, it would probably take about 4 minutes, maybe 5, to mill that onlay. Not very long at all. And because this is a resilient glass ceramic, and again, we'll get into materials a little bit after lunch, but this is a non-oven, non-fired material. After the 4 or 5 minute mill time is simply hand polished. That takes maybe a minute. And then sandblasted, silanated, and bonded to tooth structure. So really efficient way of taking care of these patients. And, you know, especially if we go back and look at this model one more time, let's go back to this design phase. You know, again, this is kind of the classic scenario that I was talking to you guys about, where I had a big MO amalgam that went like this. Patient busted off the buccal cusp. Sure, I could whittle this whole tooth down for a crown, no problem. But why remove all this good tooth structure if I can simply just replace it with an onlay here? And your insurance companies are going to reimburse your onlay just like they would a crown. You're not going to have trouble getting the onlay reimbursed. Getting an inlay reimbursed is going to be downgraded to a composite, regardless of whether you're in network or not. And so that's why my inlay fees and composite fees are the same. I don't charge more for an inlay. It's going to be the same as a DO composite, and a DO inlay are the same exact fee in my practice. But the onlay is going to be the same fee as a crown because it's going to be reimbursed and paid for every 5 years, just as a crown would be. So hopefully that is kind of some good examples in regards to seeing this partial coverage restoration. I would like to go to the Q&A a little bit, and then we'll see if anything else pops up. Let me kind of get out of the screen and back to here. So first question for zirconia block, which is stronger? Is there a 3Y zirconia? There is a 3Y zirconia. There's a couple of different types of zirconia. Some practitioners may not be aware of that. Not all zirconia is the same. And I'll jump into materials after lunch, since there seems to be a lot of questions about that. I'll add that into our after lunch discussion. But it depends, right? So there's some aesthetic zirconias. The more aesthetic, the more translucent, the prettier their zirconia, the weaker. So there are some things like CEREC zirconia. It is a very opaque, you know, we kind of call it white gold type of zirconia. It's strong. It's going to have that 1100 plus megapascals of strength, but it's just not very pretty. Katana, on the other hand, from Noritake, is the, you know, they call it super translucent multi-layer zirconia, and I'll show you some examples of it. It looks really nice. To me, it's on par with a low translucency, maybe even some medium translucency Emaxes. But you're giving up about 400 megapascals. The compressive strength of that zirconia is going to be more about 750 compared to the 1100. So again, that's where that prep changes. And you have to, you know, follow that. If I'm going to be using something like CEREC zirconia at 1100 megapascals, I'm totally comfortable having that 0.7 to 0.8 fissure and reducing very minimally. But if I'm doing something like Katana or a more aesthetic zirconia, I'm really going to be pushing for that 1 to 1.5 to make sure that I have what I need there. The second question was, can you use one furnace for Emax and zirconia? The answer to that is yes as well. It just depends on which furnace you have, okay? The Speedfire oven will do Emax and will do zirconia, but to do zirconia chair side and same day, you're going to need an oven like the Speedfire. The conventional zirconia ovens, the sintering time used to be 7 to 8 hours, and that just doesn't work for same day dentistry. So you're going to need something like a Speedfire. Ivoclar does have an oven as well, but it's not married up as nicely as the Speedfire is. The Speedfire transfers everything automatically from the prime mill, or from the prime scan to the prime mill to the oven. So it's a really seamless process. And I have 2 ovens in my practice. I have the Speedfire for zirconia, and then I have a separate ceramic oven for doing things like Emax and Empress, that kind of stuff. Can you use Speedfire with the MCXL in-lab milling machine or just with prime mill? No, so the Speedfire works with all of those systems. The information from the Speedfire comes from the milling process and from your scanner. So if you have an MCXL that does dry milling of zirconia, then it will transfer that data automatically over to the Speedfire through the CEREC software. So you can definitely use that. Hopefully that answers that question. If not, write me a different way and I'll try. If you accept PPO insurances, do you have issues with downcoding of inlays or onlays? So I don't take any insurance at all. So I know that's a little bit different of a scenario than a lot of places, but as rural as I am, there's not a lot of providers here. And so we file most primary insurances as a courtesy, but we don't participate with any plans. That being said, if my patients didn't have their insurance paying for the procedures, they wouldn't have them done. So we still have to play the game a little bit, even though we're out of network, right? So there's a couple of ways that you make sure that your onlays get paid for. The first is you're gonna have to have radiographs, right? So just like with a crown, you're gonna have to have a PA ahead of time, shows the roots, that kind of thing. I always take a post-op bite wing of any restoration I do. So whether it's an onlay or a crown, whatever, always do a post-op bite wing to check for cement cleanup when we're bonding these things in. So I have those 2 things. I have a pre-op PA, a post-op bite wing that shows it's seated, okay? And then I'm gonna have 2 other things that we submit to the insurance to make sure they pay for the onlay. And that is a pre-prep photo and a mid-prep photo. You want the pre-prep photo to show the restoration, to show it broken, whatever, show the reason that you are working on the tooth. And then you also want a mid-prep one. And when I say mid-prep, I don't mean pristine margins, polished, isolated. I mean like kind of the gross photo before you've cleaned everything up. That's what you want to send to the insurance. You want to send them ones that show the cracks, show the decay, show the breakdown of tooth structure underneath whatever restoration you're removing or something like that. You submit those 4 things to your insurance company, they're going to pay on the onlay and they're going to reimburse it at 50%, just like a crown. They may have a different fee for their onlay. I don't know what the allowable fee would be, but in most cases, from what I've seen, and at least with the insurances that we work with to file for patients, they allow the same amount that they do for the crown. So that's why my onlay fee and my crown fee are identical. Similarly, the inlay is going to be downgraded 100% of the time to a composite every single time you do it. But again, milling these inlays in office, I think offers me and the patient both a lot of advantages. The advantage to me is that I'm not stuck using paladins and Toffelmeyers and wedges and bands and doing composites directly for 30 or 40 minutes. It takes me a long time to do a quadrant of composites well. And I think it's really difficult for the patient to be propped open, even with an isolite, for that long while I'm doing it. And then I always have to do them kind of one at a time. I got to do one and get the contacts right, smooth up the margins. Then I got to do the adjacent one. Otherwise, my contacts are all over the place and I don't really love it. So I like it for that. It takes some stress away from me. It allows me to go see other patients. The other thing that's really nice though with milled inlays is that you're going to find that the sensitivity post-op goes way down. Okay, we have one piece of a pre-cured kind of hybrid resin ceramic block being seated, and I don't have 8-10 layers of composite. And because of that, I have a lot less shrinking and that with the polymerization process. And because of that, a lot less post-op sensitivity. So those things all go hand in hand to me, and they're a benefit to me and to the patient. I think the patient's getting a better restoration than a direct composite. Now, if someone walks in with an incipient area of decay, a little DO of number 4, do I mill that? No, I'm going to be doing that direct. Okay. But if I have someone walking in with a quadrant of amalgams that are breaking down and I got to grind all that stuff out, those are going to be milled for sure. There's no chance I'm going to spend all that time stacking layers of composite. And a lot of times I hear, well, how do I justify, paying for an inlay block when the insurance is only going to pay me for a composite? Well, the CEREC system is kind of unique in that, one, the blocks that we're using here, remember, are the resilient kind of hybrid blocks. That's what we're using for partial coverage. So those mill very quick, 4 or 5 minutes for an inlay. No fire time, so you just polish them. And those blocks are about $30 a piece. Well, I can get multiple restorations out of that one block. Other milling systems do not allow you to mill multiple restorations out of a block. But if I mill an inlay of number 4 out of a block of CERESmart, I just leave that CERESmart block in the mill and hit go again when it's time to mill number 5. And it'll continually generate those restorations for me as long as there's material there. So usually I can get about 2 restorations out of a block. That cuts my cost down on those inlays to about $15 a piece instead of 30. And depending on what type of composite you're using, you're probably paying somewhere between $8 to $10 a compule of composite. Plus you have the cost of the rings, the wedges, the bands, all of that kind of stuff. So to me, that's basically a break even, especially on a big composite. I may end up using more compules of composite than I would the price of a block. So plus then I have all the adjustment, and I'm becoming a human milling machine at the end, right? I stack all those layers of composite. I start grinding it into occlusion. And then after that, I start checking the bite, and I'm sitting there adjusting the quadrant until I'm happy versus, scanning it, marginating it, getting up and leaving, coming back to the room, the 4 inlays are ready to be delivered, seating the patient or having the patient with the isolite seated, and then I come in and just deliver the restorations all at one time. We don't deliver them individually. It's very important that you would deliver them all together. Otherwise, you're going to have bonding resin and cement and stuff all in the prep. So you would deliver all 4 at once and clean it up. But using an easy to clean bonding system would help with that. And then that way it becomes very, very predictable for you. And instead of, 30 minutes or so of stacking those layers of composite, I go check hygiene, or I go prep another tooth, or go do something else productive rather than that. So hopefully that answers your question in terms of insurances and inlays, onlays, and crowns. I don't see anything else in the Q&A, and we are right on time at 12:51. I want to come back after lunch and probably move a little bit around in the agenda. We'll definitely get to everything that's there, but I think we should probably talk a little bit about materials, because there's been a lot of questions about different types of zirconia, when to use hybrids versus glass ceramics. So I'll do a rundown of the materials that we've used, and I'll also tell you the ones that I use in my practice regularly, because there's so many in the CEREC market that you could use. There's no point in stocking your office with every glass ceramic and every zirconia. I think you kind of pick one from each category, and I'll tell you the pros and cons of what I see there, and just tell you what I use within my practice. But I don't want to jump into another topic with only 9 minutes to go. So I don't know if there's anything in the chat or anything else in the Q&A.
I think we're good for now.
Okay. I am going to put up my information for you guys here. My email is there. My Instagram is below that. You can follow me in my office there. We post cases that we do, preps, CEREC stuff and cone beam and integration and stuff like that all the time. This afternoon, we will jump into materials. We'll talk about crown design. So we'll do a single unit crown or maybe 2 crowns, we'll see. And then the advanced topics in the afternoon, I'd like to get into implants more, bridges and aesthetics, things like that, just to kind of cover in short order what all we can do with the CEREC system. And then leave a little bit of time at the end. The afternoon session is kind of scheduled from 3 to 4, then 4 to 6. And that last bit of information from 4 to 6, after we get through advanced topics and implants, I'll be happy to cover anything else within the day. Again, we've taken this 2-day course and made it 1. So I am kind of skimming over some things. If we have some time left over, we may get into bonding for a little while just to kind of discuss that with you guys as well, because there's a lot to take into account, especially when working with all these different glass ceramics and hybrids. So hopefully the morning was helpful. I will probably log back on maybe 10 or 15 minutes early to see if there's any questions that have popped up. And otherwise, I will see you guys shortly. Thank you. All right, question in the chat. What is the best technique to consider prior to scan with margins that are under the gum line? So we have these questions pop up routinely where we talk about kind of what to do when things are subgingival, or how to scan when a subgingival area. And I don't always quite know how to answer that, because I don't think it's really any different than what you would be doing for conventional analog dentistry. I mean, to me, scanning subgingival is actually quite a bit easier than impressing subgingival. If I have to take an impression of a subgingival margin, I have to do two things. One, I have to get the tissue displaced laterally away from the margin that I've prepped, but then I also have to get vertical displacement. So a lot of times a 2-chord technique or something like that, so that my impression material can read the margin, but it also needs to run past the margin. That way, when the impression is pulled, the lab has the ability to create a model and then trim to that margin. If the impression material doesn't run past the margin, or you don't get that change in vertical, then it's very difficult for your lab to trim to it, because the model is going to be flat. There's not going to be a discrepancy between tooth and tissue. It's opposite of that with digital dentistry. With digital dentistry, I don't have to scan past the margin. I just need to be able to see the margin. So I don't have to get that lateral and vertical displacement of tissue. I only have to get the tissue out of the way laterally to be able to image the margin that's there. So again, that's why I think it's easier to generate that clean margin digitally than it would ever be with a conventional analog type of impression. What is the purpose of breaking the contact for an inlay if that area is not undermined by decay? So this kind of goes back to the scenario that we talked about earlier. Let me bring up a photo for a minute so you guys can see this kind of prep that I'm talking about. So when we look at a prep like this, the question, I think, is saying if you have a very small incipient lesion here, why would you open this big contact? And I don't think that you would. Like I said, if I have a small DO on 4, an MO on 3, or something that's a very limited class 2 type of restoration, those are going to be done directly, because you're right, you'd have to remove more tooth structure than would be advantageous to do it indirectly. But if I have a big MOD amalgam like this, or a large MOD decay, it makes sense to remove this last bit of tissue or last bit of enamel here because of 2 reasons. One, that other tooth is contacting right there, and that's going to be a very difficult area for the patient to maintain and keep clean. If that margin is brought slightly lingual, then now their toothbrush can hit it, maintain it, things like that, because obviously they had a problem with decay prior. Secondly, this is a very thin area of enamel, and what's going to happen over time, most likely, is you're going to see some chipping and things here and then leaking around that margin. So when I'm doing these inlays, I want to make sure that the margins are brushable and cleanable by the patient, but I also want it to be bonded to sound enamel, not unsupported enamel rods. And so getting this contact open here and here is imperative to have draw and to be able to seat that restoration. But again, if it's some very small class 2, that's a single, kind of DO surface of, I keep going back to something like number 4, I'm going to do that with a Paladin all day long. And that's going to be a very direct thing. But doing a composite this large with, 4 or 5 layers of composite, there's no chance I'm doing that. I'm going to be milling something like this because it's going to be more structurally sound for the patient, less polymerization shrinkage, less chance of sensitivity, less chance of voids while I'm stacking those layers of composite. Plus the emergence profile and everything's going to be better as well. So hopefully that answers that question. That takes us right to 3 o'clock. So welcome back from the break. Hopefully everyone had a good lunch break or maybe saw some patients. I know we treated a couple of people here. So I'm going to go through the afternoon, and some of you that were on a few minutes ago heard me kind of give the agenda, but I like to always do that rundown so you know what to expect over the next couple of hours. I want to jump in a little bit to materials, and I know that's not on the agenda, but there was a lot of questions about materials throughout the first section. So I think it's better to cover that and at least discuss what type of materials are available for the CEREC. Jump into zirconia a little bit because I know that's a very popular material right now amongst practitioners. And then we'll go to designing a single unit restoration and planning it like we were to do zirconia. Following that, we're going to go into kind of advanced topics. We're going to start that at 4 o'clock, roughly. And the idea there is to cover other things that the CEREC can do besides single unit restorations. Give you guys some examples of some anterior aesthetic cases, guided implant surgery, implant restorations. If we have time, I can demo kind of what the imaging looks like for an implant restoration and try to answer any questions you guys have. And finishing up as close to 6 p.m. Eastern as possible. So, I know dental materials is not the most exciting subject. It wasn't for me in dental school either. But being a CEREC dentist and using it, I think it's very important to know the materials, and it's something that I've kind of gotten to be a little bit of a nerd about now because it affects the outcome of the cases so much just by material selection alone. So I want to go through these common materials that we talk about with CEREC, but the first thing we need to talk about are the different types of crown restorations. And so I'm sure you guys have seen, a PFM. We're talking about something that has a relatively weak porcelain, honestly, fused to this metal coping. We have bilayer type restorations. This is where we have maybe a zirconia coping with, again, a relatively weak porcelain fused to the top of it. And then we get into the all ceramics or zirconias, where these monolithic restorations. And the reason I have this slide up and the reason that I think it's important is we need to talk about these restorations, not from how they fit or how they survive, but really from how they fail. Because that's going to be the biggest issue with any of these restorations. And I go back to look at like a PFM or even these bilayer restorations, and I'll question you to say, as patients come into your practice and you're seeing them for, routine prophies and things like this, I would guess that daily you see PFMs or these bilayer type restorations that have porcelain that's gone from the surface. The metal is exposed or the zirconia core is exposed, and this relatively weak porcelain has sheared off or worn away. And the question becomes, is that a failure of the material? When we have these cases, live and we can do these events, I usually get kind of a mixed opinion from the group of practitioners that are there that, is the metal being exposed on this PFM a failure? And, it classically is a failure of the restoration. The porcelain is gone. Does that mean it clinically needs to be replaced? Probably not. Most patients aren't going to go in, and especially on something like number 2 or 15 or something, want this crown replaced because some silver is showing through. Totally different if there ends up being a hole in the metal and some leaking under the crown. But oftentimes we'll see this porcelain gone, the patient's functioning just fine. So we get away with a lot here. Similarly, we get away with a lot in this bilayer restoration because we start looking at inadequate occlusal reduction, not having the occlusion stable and where it needs to be, and we see this porcelain shearing off, and now we still have this coping in place, so this thing has survived. So even though it truly has failed, it's broken, it's surviving in the mouth, and it's probably clinically acceptable. That's not the case with monolithic restorations. When you start putting glass ceramics in the mouth and you don't have inadequate reduction, you don't have them bonded properly, the failure of this is not going to be chipping. The failure of this is going to be a complete catastrophic fracture of the restoration. You're going to lose a cusp, or it's going to debond, or it's going to crack in half or something like that. And so that's why, as we go through these next different slides of the different materials, I'm going to give you a lot of information. You're going to see things like material thickness, how to bond and how to cement and this kind of stuff for these materials. And those qualifications really have to be followed, because otherwise you're going to start seeing quite a bit of failures in glass ceramics, because we do not have that leeway that we have with bilayer restorations. So this is just a basic slide of some of the simple CEREC materials that are out there, ones we're going to cover today. The top left is going to be your more weaker PMMA or polymethyl methacrylate blocks. We're making temporaries and things like that out of those. As you go down, these are stronger. This is kind of this hybrid block we were talking about. These are considered ceramics, not this one. This is pure composite, but these other three. from a coating perspective are considered ceramics, but this is the hybrid. This is a resin mixed with porcelain. Neither one of these can go into an oven. If they did, they would just be a pile of ash when they were left behind. But relatively weak. These, I would say that the flexural strength of them, even though it's weak, is a benefit, especially in the partial coverage restorations. As we move to the right, what you're going to see are stronger porcelains. The two in the center, these have oven optional. So you have something like Celtra Duo, which is a lithium monosilicate that's reinforced with zirconia. And this is already pre-crystallized. You can run it through a cycle again, which is why we have oven required over here to bring the strength back up after the milling process, but you don't have to. It's tooth colored. It's going to be roughly 250 or so megapascals right out of the mill, and you can polish that and bond it right to place. Similarly, with these more aesthetic feldspathic or lucite reinforced porcelains on the top, weaker materials, right, but highly aesthetic. As we move to the right, we have Emax, which is an aesthetic ceramic, but not to the aesthetics that we're going to have with something like Empress or Vita Mark II, but stronger. So here we're reaching closer to 500 megapascals when it's bonded, about 460, 440 with Celtra when it's bonded. And then obviously zirconia gets even stronger, but maybe not quite as aesthetic. This Inchorus TZI or the CEREC brand of zirconia is going to be around that 1100 megapascals, closer to the Bruxier type of zirconia, but not the aesthetic type, right? The aesthetic type is going to fall somewhere in between these two. As you increase that amount of alumina within that zirconia material and get that more translucent, prettier type of restoration, you start losing that fracture toughness, and that's where it'll go from 1100 to 700 or so. And that becomes a debate of, well, is 500 strong enough? Is 700 strong enough? Or do we really need, 1100 megapascals? So let's start with kind of the really pretty blocks, these kind of true porcelains, feldspathic porcelains. The ones that we started with originally with CEREC were the Vita Mark II blocks. These are beautiful blocks. The translucency of them is really nice. They hand polish very well, but these have to be bonded, and there's just no other way to have this kind of material survive. I mean, I have Vita Mark II on plenty of posterior molars and premolars and full coverage crowns that are doing just fine and have been for years. There are better options now, but there weren't 10 years ago when we were doing these restorations. But as long as they have the 2 millimeters of occlusal clearance and thickness, and as long as they're bonded, they're going to survive just fine. If they're put in with a self-adhesive resin, if they're under that 2 millimeters of thickness, if they have these over millings and sharp line angles left behind on the prep, then that's where you're going to start seeing these things fracture and not survive. But they polish extremely well. I still like Vita Mark II in the anterior. Vita tends to be a very warm block to me, not quite as high in value as some of the other porcelains. And I think it blends in really nice with the A shades for sure. So wears a lot like enamel. That's due into the small particle size, but these have to be treated. So when they come out of the mill and they're cleaned up and, washed off, scrub so there's no lubricant or whatever left over from the milling process, they then have to be etched and silanated. And hydrofluoric acid etch on these true ceramics takes 60 seconds. So you use 60-second hydrofluoric acid etch, rinse that out, neutralize it, and then come back and silanate the inside of that ceramic with a silane, something like Monobond Plus, or there's tons of other ones on the market, but those all work well. Then you partner it up with a true bonding system, and these are going to do great. Empress CAD, when it came out, was very popular. I'm sure you guys have all heard of Empress, veneers and crowns for anterior restorations. I like these materials too, but from just a total honesty standpoint, I find that they're pretty high in value. If I'm doing B shades and BL2s and 3s, these look really nice. Where I live, the average shade that I'm working in is probably A2, A3 for the most of my patients. And I just don't have a place for Empress unless I'm doing a bigger aesthetic case. But similar to the other feldspathic porcelains, you're going to etch these for 60 seconds and silanate them before bonding. These can be hand polished and do not require oven unless you want to add some stains and things to them. And the nice thing about these porcelains is they actually come in multi-shades. So where Emax and Celtra are going to be monolithic and monochromatic, you can get multi-shades, whether it be Empress CAD or Vita Trilux. Sirona has some multi-layer blocks, and Vita makes one called Real Life that we'll go over that we really don't use very much. But the nice thing with that is you can get a very aesthetic restoration. If you're looking at those restorations on the upper left, those are milled Empress restorations, but they have a gradient of color in them, and that gradient's built into the block. You can see that on the right, where it's much more chromatic in this portion and lighter and more translucent in this portion. And you can then position the restoration in that mill phase that we saw, where we were able to move the sprue. We can also move the restoration up and down within the block to either increase some translucency on the occlusal surface or the incisal edge, or move it down within the block and get some more chroma in this gingival third. This is the one that I like a little bit better. This is the Vita Trilux Forte. It comes in two forms. Trilux Forte refers to the 4 layers that we have here. It also comes in just Vita Trilux, which would be 3 layers. I like the Forte. Most of my patients, again, being in that A2 to A3 range, I really like the ability to get some of that chroma in the gingival third, and these can simply be hand polished and bonded to place. I don't do a lot of staining and glazing because they look so nice coming out of the mill. The Vita Real Life block is a pretty cool concept. It's just not practical within my office. You tell the machine the shade that you want and the translucency that you want, and there's one porcelain on the outside that's more translucent, and then there's this dentinal dome of porcelain within the block, and then it positions that crown within the block to give you that shade, A2, A3, whatever you want. The only problem really with this is that the fact it takes about 30 minutes to mill this restoration. And where I'm milling out one of the Trilux blocks in 8 or 9, I just don't see the advantage of waiting 20 minutes more to mill this, and then trying to match up those shades and make sure that everyone is positioned the exact same within the block if you're doing multiple units is a little bit time consuming. So I tend to stay away from these blocks, but they are there and they look nice. They just don't have much practicality for me. Emax is kind of the workhorse and has been for a while. You could probably argue that in the CEREC early days, Emax kind of saved CEREC. There was a lot of CERECs and feldspathic porcelains that were being put in the posterior, under reduced and not bonded well, and having significant failures, more to practitioner decisions than a material decision. However, when Emax came along, we were able to start kind of prepping less aggressively, I guess you could call it. We're still looking at kind of 1.5 to 2 millimeters of reduction. But we also get a really high bond strength with this material. So when it's bonded to place, you're looking at about 500 megapascals, even at 1 millimeter thick. And so that's kind of the aim, and that's what Ivoclar advertises. But if I tell you guys 1 millimeter, then you're going to be prepping to like 0.8. So that's why we talk about doing 1.5 minimal at the fissure. That ensures that these are going to survive and do very well. A little bit of a difference with Emax, and it's going to be the same with Celtra. The crystalline structure is not the same as those true ceramics because they're lithium disilicate. They are only going to be etched for 20 seconds. So where you saw a full 60-second etch before with the feldspathics and the lucite reinforced porcelains, Emax is only going to be a 20-second etch. You know, and prepping just like normal for ceramic, like we talked about. Emax can be conventionally cemented, okay, and we talked about that too. It requires more occlusal thickness to survive if you are going to conventionally cement this instead of bond. And remember that if you're conventionally cementing this, the strength of Emax cemented is about the same as Empress bonded, in that kind of 230, 240 range, something like that. You're not getting the 500 megapascals of strength of Emax unless it's bonded to the tooth structure. So that's an important part to note and to take into account when you're looking at what type of restoration you're going to deliver. The other reason I talked to you a little bit about kind of 1.5 being the number that we want to see for you know, our minimal thickness on these is that we talked about the dye spacer and what that does to the fit of the restoration. If I click on the dye spacer here and I look at the model, you're going to see a 100 micron gap, okay? And this 100 micron gap is the thickness of resin and cement, silane, all of the things that have to go inside of this crown and against the prep of the tooth. So it allows us to have room to have a good bond. The other thing that happens is occlusal offset milling is the factor that's built in to any milling program, where due to how the burrs are moving against the surface of the restoration, the deflection of those burrs as they're hitting the ceramic, we're taking off basically an extra 175 microns from the occlusal surface. So if we add these two things together, we're at 275 microns, basically 0.3 millimeters, okay? And that's 0.3 millimeters that's coming off the thickness of my restoration. So if you have designed it to 1 millimeter, because we've said that Emax can survive at 1 millimeter, by the time it comes out of the mill, it's really only 0.7, because 100 microns has been taken off the inside and 175 has been taken off the occlusal surface. So it's important to take that into account and say, well, you know what, my restoration failed because it was only 0.7 millimeters. That's why if we're aiming for, again, that 1.5, we're always going to be at 1.2, 1.3 and have plenty of thickness for this Emax to survive. Emax does require some sort of crystallization step. That's what you're seeing here with this oven. The programmat oven is by Ivoclar. It has a vacuum on it, which allows it to fire Emax in about 15 minutes. The speed fire will fire Emax as well. It doesn't have an oven, or it doesn't have a vacuum on it. So because of that, the fire time is going to be around 27 minutes in the speed fire versus 15 in the programmat. You know, and Emax gives us some other options outside of single units. You can do bridges out of Emax. These are great to do. They do very well in the mouth. They look aesthetic. They polish well. I like these in the anterior more so than zirconia from a monolithic standpoint. Zirconia to me still looks a little opaque on anterior teeth when we're doing bridges, especially at the Ponic site. Emax also comes with a block with a hole in it. And this is what allows me to start making things like custom abutments and screw retained restorations within my practice. The implant dentistry, and as this is taking off, you guys all know how expensive lab bills can be from custom abutments and crowns and everything that goes into it. If we have some time, I'll show you later the imaging process and how we would scan and design for an implant crown. But this is basically, in my mind, one of the easiest things to do with the CEREC machine, and to be able to make this chair side, it just works extremely, extremely well. Then we get to Celtra. Celtra is, you know, not Emax, and I think there were some failures and stuff in the early days of Celtra because it was being handled and treated like Emax. That is not the case. Celtra is its own product. It's a lithium monosilicate, not disilicate like Emax is, and it's also zirconia reinforced. So when you take a radiograph of this material, it looks very radio opaque. The nice thing with Celtra is that it does come tooth colored. So unlike Emax, that's purple, and you're staining and glazing it in this purple state before it's fired, Celtra is actually tooth colored, which may make it a little easier for new users to kind of get in using and polishing and staining and glazing. It also is called Celtra Duo because you have two options in regards to how you want to deliver this. We could do it straight out of the mill, basically polishing it and bonding it to place, or we can take it and fire it, and that firing takes the strength back up to closer to what Emax is going to be. Not exactly the same, but closer. The other thing to note about Celtra, though, that's important is this material cannot be cemented, okay? This has to be bonded. If you are cementing this or using a self-adhesive resin without some bonding resin to the tooth, I would tell you, you're probably going to be ready to see some failures and some debonds. This is not indicated in any way whatsoever for conventional cementation like Emax is. So, you know, a couple things more about it. You're looking at 210 megapascals right out of the mill, and then you bond that to place, or you throw it in the oven for a short cycle. The speed fire, this is 9 to 11 minutes. You're back up to 413 bonded, which is right on par with Emax. And it's going to be a nice scenario. Here's the comparison between Emax and Celtra Duo. So, you know, Emax, you cannot just polish it. It has to go into an oven. None of your patients want a purple tooth. So that's why there's a non-applicable sign there. But if we go back to the, you know, comparisons here between biaxial fired and 3-point fired, this kind of stuff, 400 to 370, 530 to 560, relatively similar. I think the biggest difference between these two materials in my mind is the delivery of them. And practitioners that like to cement restorations need to be more in the Emax category because you cannot cement Celtra Duo without running the risk of failure. We're going to move now into these kind of resilient hybrids, and I'll touch on a couple of them and talk to you about the ones that I use. But Lava Ultimate was basically the leader for this material and how it came about. It is a zirconia reinforced resin. It does look radio opaque due to that zirconia that's in there. This nano ceramic was lobbied by 3M to be able to be filed and charged as a ceramic. And if it was resin, none of us would buy it or use it. But the fact that you can bill it as a ceramic, and it is ceramic by weight, it works great for those partial coverage inlays and onlays. And that's kind of my go-to for it and what I use it for. You do polish these only, they mill very quickly and very cleanly. You're not going to see the chipping at the margin and things like that you see with other materials that are true ceramics. Because of that resin component, you can mill really knife edge margins and they come out clean. They're very kind to the burrs as well. You can probably get 50 plus units of these milled out of a set of burrs compared to, 12 to 14 units when you're doing glass ceramics. CERESmart, this is the one that I kind of like. I feel like CERESmart, just kind of like the Vita ceramics we looked at, is a little bit warmer of a block, okay? It's gonna match those A2s, A3s, A1s a lot better. Lava, because of the zirconia reinforcement in it, is a little bit higher in value. So I usually would step down one shade. If I think it's in, an A2, I'm probably putting in an A3. If I think it's an A1, I'm probably putting in an A2 and having it match with some cement. I don't have to do that with the CERESmart. It tends to be true to color with Vita shade guide, and it mills, again, really clean, quick polishing. This is a very, very nice material. Vita Anamic is Vita's kind of way of getting into this market of resilient ceramics, and it's been around for a while. This is the only resilient ceramic that you're going to treat actually like a ceramic. And that's because it's a feldspathic kind of honeycomb that's then infiltrated with resin. And so you actually etch the inside of this. The other hybrids, you're just sandblasting the inside and then silinating them. But with Vita Anamic, you are hydrofluoric acid etching the intaglio surface for 60 seconds before delivering it, and then delivering it to place. It also comes with a block with a hole in it. I don't use these very much, to be honest. Anamic IS is the Anamic implant solution. That's what they call these blocks. I use these for custom healing caps when we mill those in office. But to me, they kind of look like bisacryl after a while. So I wouldn't use these as my final restorations. They mill super fast and super clean. You can mill a crown out of this other block, the regular block for a regular unit, probably in 4 or 5 minutes. This one's gonna mill in about 10 or 12. So really nice material for that. I just can't use it in my hands from a long-term scenario because it just doesn't hold up with the polish and shine like I want it to. And then here's just kind of an option of what a Vita Anamic crown would look like on a titanium base, or milling at a custom abutment out of Vita Anamic and then putting basically whatever you want over the top of it. Another Vita Anamic crown, an Emax crown, anything like this could go there. Or you could do it the opposite. You could be doing Emax or zirconia here for the abutment and then putting some Vita product over the top. Paradigm, this is the old MZ100 composite from 3M, tons of studies done on it. Before the resilient blocks came out, I used this a lot. And this is what I use for my inlays and onlays, and was building them out as composites because that's what they are. But when the resilience came out, I started using those. I can't find much room for this material in my practice anymore, only because they're roughly the same price as the resilient blocks, and I just use those instead. So let's talk about zirconia. That's kind of the hot topic, I guess, right now in terms of material. All the different zirconias coming out, and until the Speedfire oven was released by Sirona, there was really no way to generate zirconia chairside. The old sintering times or firing times of zirconia at fastest were 7 or 8 hours. So until this induction type furnace was made and got that firing time down to 12 to 15 minutes, just wasn't a chairside ability. But now we have that. So let's talk about zirconia a little bit. Again, here's the Speedfire oven. This links up directly with your PrimeScan, OmniCam, whatever imaging system you have through CEREC. After it's done milling, it transfers the program to this little tablet. You basically place the zirconia here, hit go, and it takes it up and fires it and centers it for you. The CEREC zirconia, this is again that more opacious but really strong zirconia, about 1100 megapascals. And this is the kind of stuff you're gonna get right out of the mill and fired. There's not a lot of staining and glazing done here, right? This is basically spray glazed. A little bit of color added to the occlusal surface here, but these are very opaque. They fit great. Zirconia is a really nice material for milling. The tissue responds to it well. It just tends to not be quite as aesthetic as the other ceramics. Out of the mill, though, you're going to notice there's a lot more occlusal anatomy from a zirconia restoration than what you're seeing with glass ceramics. And that's from the processing. That's how these are made. When you see a zirconia crown made, it's made about 23 to 24% bigger than the final restoration. And that's because due to the composite nature of that block, whatever the composition is of alumina, zirconia, everything built in there, that restoration is going to shrink upon sintering. Each one of these blocks comes with a barcode, and the barcode that's on there relates the software how much bigger to mill this restoration, and it also controls the firing time to control the shrinkage of the restoration. So rather than these big diamonds that we looked at before that were milling our or grinding our glass ceramics, we're going to be using these carbides to make our zirconia restorations. And you can see how needle-like this restoration would, or this burr is going to be into the occlusal surface. This allows it to really dig in finely to those grooves. And because it's milling it so much bigger, it cuts those grooves really deep. Then when it shrinks, that anatomy looks even more defined than what it would be prior. This is going to be the rest of the mill. You're going to have an external vacuum hooked up to it because this is a dry milling process. There is no water coming on during this process. So the vacuum turns on automatically. All the dust starts being evacuated from the milling chamber, and then you're going to produce the crown. Once the crown is made, it's removed off the sprue. Again, remember, zirconia is extremely weak compared to something like any glass ceramic, honestly. Right now, it's basically chalk until it has been sintered. So it does not get cut off the block like a lot of the other crowns do. If you've seen a crown be milled and you open the CEREC milling unit, then down on the floor of that is sitting the restoration. That will not happen with zirconia. With zirconia, it's going to stay stuck to the block because if this fell off and hit the bottom of that milling chamber, it would be likely to crack and break. So you would remove this sprue and polish it, then place it on this firing pad, and it would go up into the oven. You then have the option to glaze it if you want. To be perfectly honest, we don't glaze any of our zirconia restorations. All the zirconia restorations that we have are hand polished. I am a big believer in hand polishing glass ceramics. Glaze, especially on zirconia, will wear over time. And if you have not polished that underlying surface, you have this big bulldozer of zirconia down there that's going to be beating up the opposing dentition. If you polish it well and get a nice smooth surface that way, that polish will stay and not come off like the glaze will. So, here's this example again of it being milled. About 4 minutes to mill these with the prime mill and the super fast milling cycle. Another 13 to 15 to dry fire it. And if you want to glaze it, 5 to 7 minutes. But I'll tell you to look at the inside here. Remember we were talking about over milling with those glass ceramics. You're not going to see a lot of over milling on zirconia. And that's because, again, we're using zirconia as really big when it's milled. And we're also using those very fine burrs. So we're going to have a much more intimate fit of the intaglio surface because there's not that over milling. We talked about the aesthetic zirconia. This is from Curare Noritake, the katana block. This is really the zirconia that I use in my office if I'm going to be using zirconia. It is on par aesthetic wise with something like an Emax LT or MT block. And I do like the gradient of color that's in there. So it's quite nice. You can see the restoration there and you can see it hand polished. There is no staining or glazing. That kind of translucency at the incisal ledge to the more chromatic gingival third comes from the built-in nature of the block. So 4 minute mill, 18 minute center. Now 700 megapascals and bonded. So, bonding zirconia is something that maybe is a little questionable depending on who you talk to. Curare does have a specific system they recommend for bonding their zirconia into place. And that is the cement I use when I'm putting in these blocks. Because I do want to try to keep it as strong as possible, knowing that I'm not at that 1100 megapascals I am with a standard zirconia. I am a little bit weaker, but they look nice, they do well, and we can talk about bonding and cementation afterwards. But make sure you're, again, following manufacturer guidelines. This is not allowable to go to that 0.7 that we were talking about with the other zirconias. This needs to be 1 millimeter. If it's not 1 millimeter, then you're going to run the risk of it fracturing. So we're going to go through a crown demo, and I was going to do 30, but I'm actually going to do 18 so you guys can see some contacts. But I think there's a couple of Q&A questions, so let's see. First one is, please explain biaxial polished and 3-point polished. Okay, so stuff like that comes up a good bit. Let me go back to that screen for a moment. What that's referring to is how these materials are tested. So a polished Celtra biaxially, what that means is taking that Celtra block after it's been polished and squeezing it like this to see when it fractures. So biaxially, coming in from two sides on its axis, right? 3-point is the other test. So that would be where there is 2 points coming down on a block of Celtra and 1 point coming up on the bottom, and it's trying to break that bar of Celtra. So the 3-point test gives it 210 megapascals. The biaxial test is the other way that companies will measure their toughness of their ceramics. So at that one, it's 413. The real thing to compare here is to look and see, all right, the 3-point fired, meaning I took a piece of Emax and fired it, put 3 points on it, 2 on the top, 1 on the bottom, and pushed. It broke at 400 megapascals. Celtra Duo broke at 370. Then Emax fired biaxially. We're pushing it like this at 530 megapascals. That material failed or fractured. At 560 megapascals, the Celtra failed or fractured. I've heard that you can stain your zirconias prior to sintering. Then you have to dry the restoration and sinter it. How does that work? So the actual terminology for that is zirconia infiltration. I'm not going to get into that too much today, just because honestly, there's not enough time. But zirconia, if you fire it while it's wet, if there's any moisture at all, it will shatter because it fires at such a high temperature so quickly. So the way that infiltration works is, and if you Google it, you'll see it. It looks like watercolors, blue, greens, yellows, pinks, reds. It doesn't look tooth colored. And you're going to paint almost like a watercolor that onto the zirconia. And because that zirconia is chalk-like, it's going to absorb those stains. You would then run a drying cycle to dry out any moisture. So those stains have now infiltrated into the zirconia. It has been dried, so there's no moisture. Then it would be sintered. That stain is then kind of embedded into the zirconia. Conversely, if you're doing something like stain and glaze with zirconia, what's going to happen is you're going to sinter it. Then you're going to paint the stain and glaze on and then fire it again. That ends up being more surface. And that's the stuff that's going to wear off over time. And that's why I want to see that underlying structure really well polished, so I don't have an abrasive, hard material like zirconia beating up the opposing dentition. What polishing system do I use for zirconia? So from the beginning, you guys knew that I am a member of CDOCS and do the visiting faculty there. There's actually a CDOCS kit by Meisinger made specifically for polishing zirconia. And that's the one I use, but it's basically some twist wheels by Meisinger. They have little kind of arms all around them. They come in blue, red, green, yellow. And the process that I have is I take the zirconia off the block. I take a very fine carbide acrylic burr and polish away the sprue. And then I start with the blue twist wheel and do a very light polish over the entire surface of the zirconia. Then I fire it. When that comes out, then finish it with a red and a yellow twist wheel. And when I say I mean my team, my staff, they're the ones that do all this for me. But that's the system that I use. What material do I go to for inlays and onlays? So again, there's two that I use. There's a host of them, but I really like GC CERESmart, and I like Ivoclar, Vivadence, Tetric CAD. Those are kind of a toss-up for me. They both work great, and I like them both. I guess I used to use only CERESmart because Tetric CAD wasn't available. I really like Ivoclar's product line. I like their cement systems. I like their composites. I like their bonding agents. So I stick with all that in one family. And that's why I'm making that transition probably more to Tetric CAD, because I use so much of all their other products. But those two are interchangeable to me, and both are very predictable and work well. So while that's going, let me see if I can get my CEREC connected again, and we'll go on and do a single unit. Nothing else in the chat, right, Adam?
Correct.
Okay. So this morning, the first thing we did was we did the partial coverage restoration on number 14. We didn't take a bite. We didn't take an opposing. You kind of saw how that process works in regards to designing and milling that restoration. So now what I'm going to do is do a single unit number 18. So let's go through the process again. We'll go to add a new patient. And then I'll see myself and we'll add a case for me. So now what we're looking at here is the same thing. We're going to progress from left to right on the screen. We're going to be doing a single unit. Auto detect, it's going to figure out whether it's veneer, inlay, onlay, or crown for me. Biogeneric individual, that means that the software is going to propose a crown by looking at the adjacent teeth. It's going to look at the tooth behind, the tooth forward, the tooth opposing, and figure out a tooth that's going to fit in there. Copy, and we'll go into that a little bit later today, but that would be when I'm actually copying something that's already there. Copy and mirror would be, hey, copy 7 and put it on 10 or something like that. In this case, let's look at doing a zirconia block. And so we can do Dentsply Sirona. We're going to see CEREC block. And what you're going to see on here for CEREC zirconia grinding, CEREC zirconia milling. We've been able to actually do zirconia restorations in office for a long time. We just haven't had the speed fire oven for as long. And that was the real game changer. Now that we have the ability to mill, though, that's where the carbides come into play. And by milling this dry, it doesn't have to go through a drying cycle. If we were to select grinding, it would be using those diamonds and it would have water come on. So we're going to select CEREC zirconia milling. And then we're going to pick number 18. So I can check my case details over here. We're doing a single unit number 18 out of CEREC zirconia. It's connected to one of my mills. It's ready to go. I probably need to change this because that mill is not set up for grinding. Okay. So now we're going to open up the software. The camera is going to, come on and allow us to start scanning, and we'll start some imaging. So I'll pick the prime scan up, and we're going to start doing that same linear scan again, okay? We're going to go from the most distal up the occlusal surface, down the lingual, up over the occlusal again, down the buccal. And now I'm going to kind of pitch that camera a little bit, getting into the contacts to make sure I have all that image very well. So there's my preparation. I have my interproximal contacts image, all my necessary data. I'm going to do the upper jaw now. Just the same linear scan each time. It just makes it very predictable. You don't get lost in the patient's mouth. You know what you're supposed to be scanning. Last step here is we're going to take a bite. So now we have our bite recorded. We get a green check mark at the bottom. That means that everything has been stitched, and then we should be good to go. Now, something I always find interesting with this case when we teach on it is if I asked all of you to look at this number 18 and saw the occlusal reduction on it, okay? When you look at the occlusal reduction on this number 18, I would be interested to think or see what you guys think about how much reduction is there. Do you think this is 2 millimeters of reduction? Do you think this is 1 millimeter of reduction? Do you think this is enough reduction for a glass ceramic restoration? Because when we go forward and look at the preparation analysis, I think that you'll be interested to see how much reduction is actually there. We're pretty bad at guessing what 2 millimeters is, and that is why I suggest having that reduction for all these cases. I did have one other question. Someone asked me about imaging and then taking photos. When I was talking about the inlay onlay, remember I talked about having kind of a pre-op photo and a mid-prep photo? If you look down here at the bottom, we've been scanning the whole time, but this camera can actually act as an intraoral video camera or still camera. If you click on photo or video and go to photo, you can pick up the camera and actually take still shots of the case. So you're already going to have it in there while you're doing the inlay or the onlay. All those images are saved, and then you can put these right into the patient's chart. Okay, so just another function that you would have there. Once we have our green check mark, we'll move forward and slowly making our way across. While the models are working, I will look at the Q&A for a minute. Maybe.
Yeah, we've got a couple. Do you flatten the proximal contacts of the adjacent teeth to facilitate accurate contacts?
So That's a good question. Let's see when this model pops up. I'll be able to explain it maybe a little bit better because we'll have a diagram to look at. Anytime I'm doing a restoration, a crown, all right, and I have an interproximal surface that I need to be working on, I am almost always, it would be rare for me to not take some sort of fine, extra fine, ET burr, flame diamond, carbide, something, and finish this surface and finish this surface. Because oftentimes there's some old restorative metal, composite, maybe a crown that doesn't have a good emergence profile. So I want to go in and smooth these up so I can get nice draw. Otherwise, you're going to have a difficult time seating the restoration and having a predictable contact. Because what will happen if you leave a big lump of amalgam right here and you don't polish it back, then when you go to seat it, it's going to be tight while you're trying to seat it. Then once you get it past that contact point, that contact's going to be open and loose. So why not go in and finish back that restoration to the tooth and have it be nice and sound? That's going to be the same thing for any implant restoration that I do as well. When we're doing implant restorations and we do them screw retained, this contact and this contact have to be parallel. If they're not, then the screw retained restoration won't seat. So what I need to do is go in and contour those before I do my digital impressioning or scanning for an implant restoration.
All right, and then one more question. Does the OmniCam have the ability to take still photos like the Prime Scan?
Yes, they both do. So the OmniCam, the screen is going to look a little, well, actually not now. If you're running this same software, because the OmniCam is now running this 5.1 software that you see on mine, it'll look the exact same. But yeah, it'll have the photo video option, and it has had that from the beginning. So when we talked early on about the USB that's on the back of the monitor, whether it's the OmniCam or the Prime, they both have a USB plug-in on the back of the monitor. That's where you would drag and drop these JPEGs that are made on the case, and then you put them right into Dentrix, EagleSoft, whatever you're using. And then those can be uploaded for the insurance claim along with any radiographs.
All right, that's
so
it.
Perfect. So let's go back and, what you're going to see, you guys remember setting the model axis and drawing a margin on that onlay. We had to do those ourselves. But because we took an opposing and because we took a buccal bite, that set model axis has already been done for us by the software. It also has already drawn a margin. Now, the margin may not be exactly right. You need to check that and make sure, especially if you have subgingival margins, you want to go in and check and see where the computer placed the margin. But the fact of the matter is that if you have something well isolated, it's going to catch probably 90% of it. If we zoom in right here, to me, it looks like it fell off the margin a little bit. Well, that's no big deal. You basically just double click your way around and correct the margin. Okay. And then I would roll this around and kind of look. And this goes back even to the discussion we had about who's drawing the margin, who's doing what. And that's where I really like to do this myself, because I'm the one that's been looking at that margin under loops for that long of a time. And so I draw the margin, I get to here, and then I basically get up and walk away. Early on, you may want to check some of these other steps. So insertion axis we're going to look at. We're going to make sure that the path of insertion looks good. We don't see any undercuts. The computer for some reason didn't propose it like this. It's usually right on. It's going to be, kind of dead on as you're looking at it. The next thing we're going to look at is preparation analysis. And this is going to be interesting because I know you guys looked at that kind of prep, and I talked about the clearance that we were looking at. If we go over here to the heat map, we're really only getting, in some areas, we're getting tons of clearance. Other areas, we're only to 2 millimeters, and it looked really heavily reduced, I know, to you guys when you're looking at that photo. But all in all, that's a pretty ideal amount of reduction, especially if we want to get kind of rise and fall from the anatomy of the tooth. In this area, if I had anything light up this royal blue or even red or pink, I would know I'm severely under reduced. And what I could do is simply go back to the acquisition, polish that area down a little bit, and then rescan. The other thing that I can look at here is I can look at my margin. So this margin has been polished very well. Everything is gray. If you start seeing orange pop up anywhere on your margin, that's some irregularities that it's going to have a hard time milling to, and you may end up with some chipping or bumping at the margin. So I encourage you early on to use these tools to look at, to at least know kind of what you're giving the computer and what's happening there. The surface one doesn't do a whole lot for us. We'll see if it'll give us some texture. But if I have a lot of irregularities, it'll show me that, but everything looks pretty good because we have a nice prep. Now let's move forward because we're gonna do a little bit more design here than we did with the onlay, because now we have 2 contacts and we have occlusion to look at. So I'm gonna get some of this stuff out of the way and we're gonna walk through what a normal, okay, design would look like for me. So if I start with a crown, the very first thing that I look at is the fissure thickness. And how do I know how thick my fissure is? Well, there's a thing called cursor details that's going to pop up and be there every time you do a restoration. And it's going to tell me right now that my fissure is 1.2. So that means coming across the thinnest part of my restoration, I'm at 1.2 millimeters thick. Well, remember, we selected CEREC zirconia, and we said that zirconia needs to be 1 millimeter thick at the fissure. So I'm great here. I'm at 1.2. I'm not going to have any issues. But if I were doing this same restoration out of Emax, I would need this to be more than 1.2, because remember, with Emax and bonded restorations, we have occlusal milling offset and we have die spacer. So 1.2 would really get me 0.9, which is under that 1 millimeter, and likely, if not bonded correctly, if it's in a high area function, you could see fracture. But since we're doing zirconia, 1.2 is plenty. So the very first thing I look at is my fissure. The second thing I look at is my occlusion. Now, I'm not going to get too much into occlusal philosophies and whether you do tripod or cus fossa or whatever, but I do like to talk to you a little bit about how I adjust my occlusion, because we have all these tools, and you guys saw these earlier, shaped circular, where we're able to kind of grab a portion of the tooth and move it, you know, kind of in and out. We have that smooth tool that we saw earlier, which also has an add function. So if I wanted to, you know, add some material on, I can make a really big kind of bump here on the tooth. Or if I wanted to remove it, I could go in and kind of flatten this out, end up with kind of, you know, a big divot or something like that in the tooth. Or I have the smooth function where I can go in and polish all this back. So all these other tools, they don't do a whole lot for me. I like to basically just use the circular shape and the form tool. So the circular shape tool is what I'm going to use to adjust my occlusion. Instead of that remove tool, because I'm not trying to ditch out a hole, I want to keep the anatomy. So when I go to the circular shape tool, I can click and drag this down, and you're going to see these kind of high spots go away. I like to see this royal blue for my occlusion. I don't like to see these spots. Those are going to be high in my practice. Again, everyone's a little different. Whether or not you wanted some occlusion on this marginal ridge or not, up to you. You know, you could pull this down, up, totally up to you. And we'll leave that up to the clinician. Once I have my fissure thickness, I'm still at 1.18, and I have my occlusion set, right? I don't have any high spots. The next thing I'm going to look at is the contour of the tooth. How does it look from the buccal contour? Does it look too bulky? If so, I'm going to keep that same circular tool and start bringing in the facial surface a little bit. Okay. Now maybe that looks a little better. Do the cusp tips look a little too high? If so, maybe I want to shrink this down a little bit and get these cusp tips a little more in line. So now maybe I like the overall contour. Now the last thing I'm going to work on is my contacts. When I work on my contacts, I still am on that same circular shape tool. I'm going to take the ceramic and maybe bulk out this mesial contact zone. And then I'll do the same and bulk out the distal contact. And now we've had these contacts too broad and too heavy, but better. So I can go to the shape, form, smooth, flip this over from the underside. And remember, by doing it this way, we can't take away too much. We're only going to take away the heavy spots. That takes care of that one. Flip it over the other way. Here's the other mesial contact. Polish it away like that. Now we have nice broad contacts. We have cusp tips that are in line. And if we turn off the model, we can see our contacts look great. If you want to get rid of that little green spot, polish it away. Same here, simply polish it away. Now, that's kind of the decision-making process and the flow for fabricating a crown. First thing is fissure, and I'm going to be adjusting that with that circular shape tool to make sure it's the right thickness. Next step is occlusion, still the circular shape tool. Third is contours, still the circular shape tool. And then contacts, still doing circular shape tool until the very end, I'll switch to smooth. So even though, again, there's a whole litany of different tools that you can use, those two basically do 99% of the work for me. Now, something that's a little different with zirconia, when we move forward, as this goes to the manufacture phase, you're gonna see that really big sprue. And remember what we talked about? We said, if this sprue is on my interproximal contact, I mean, that's right adjacent to this tooth, and this sprue could get in the way, and I'm having to do that by hand. That's the last place I want that sprue at. So what I want to do is take that, and I want to rotate that sprue around somewhere like the lingual. Now that sprue is positioned on the lingual. It's not on either contact. When I cut this off and polish it, life's going to be a lot easier, okay? Once I go to mill, if I hit start, I believe my mills are turned on downstairs. Let me check and see if this is going to work, because I want you to see the one other step. So what's going to happen is the restoration is going to be sent to the mill, as well as being sent to the speed fire oven. I haven't selected dry milling, but that's fine. We'll hit yes. And my speed fire is not turned on. Okay. I haven't been working today. But anyway, at this point, what's going to happen is we're going to see please scan barcode. And that's what I was telling you guys about that shrinkage factor with each individual zirconia block. So there's a barcode on those blocks. The MCXL has a scanner. The Prime Mill has a keypad where you'll type in that barcode, and that's going to relate to the mill how much bigger to make that restoration so that it will shrink by the factor it's supposed to and then be fired. If you don't have the scanner, you can see right here where it says insert barcode, and you could just simply type in the barcode number. It would transfer that, and then it would also transfer it to the speed fire. So I don't know if any questions popped up during that time, but that puts us kind of right to 4 o'clock. We've talked about materials. We've talked about designing a single unit restoration. That's going to be kind of the bread and butter of everyone's day, I'm sure, 1 to 2 crowns at a time. And that's something that's super easy to do with CEREC. You've seen how few tools it takes to do something like that, and really how easy it is to image and marginate. So I want to spend probably the next hour and a half to 2 hours discussing some more advanced topics. We don't have a lot of time in a one-day session to jump into anything in too great of detail, but I think it is worthwhile to see everything else that the system can do. The return to me on my investment from CEREC doesn't come solely from just doing these little inlays and onlays. It comes from the ortho and the implants and all the other advanced stuff that we can do with it. And that's something that we have a curriculum set up for between Dentsply, Henry Schein, and CDocs. When you have one of these machines to kind of go through these courses, and when you purchase one of the machines, the courses I believe are still, maybe the first 2 are included, maybe 3. You'll have to check with your vendor on that and your rep, but I know that there are some credits to CDocs courses which are offered in Charlotte and in Scottsdale, Charlotte, North Carolina, and Scottsdale, Arizona. And the curriculum is fantastic, tons of hands-on. We are coming back from COVID to have those classes. I think they're all starting in the early September. We're finishing the month of August, and then we'll be doing live training again, obviously with necessary social distancing and things like that in place, but you will be able to get some hands-on training that way. So I saw a question pop up, or no?
No, we're good on questions. Just a reminder, today's webinar is being recorded, so everyone who attends today will get the recording sometime in the next week via email.
Very cool. So if there's no questions and there's nothing really about the crown, I want to, like I said, go into the advanced topics. So let me skip a little bit ahead, and that way if any questions are generated from that, or if anything pops up from the other talk, we can go from there. So when we start talking about advanced uses of CEREC, you know, there's a lot of things that maybe haven't been thought about or ways of troubleshooting that I don't know how I would do them without my CEREC machine. And the first thing we can talk about is bridges. To be able to do these chairside and to do these in one appointment is efficient, economical, and highly profitable for the practice. And the fact that we can do these now with zirconia makes it even more predictable. You're not worried about glass ceramic bridges in the back and if you're going to have fracture, because we know the strength of these zirconias. The interesting thing to me, and I don't know, because it's been so long since we've really done one of these with a lab, I don't know what the standard lab bill is on a 3-unit zirconia bridge like this, but the CEREC zirconia block for me to make this bridge costs roughly 30 or 40 bucks. So, I mean, the cost savings there is huge, especially the return that you see from what you're getting compensated from the insurance company or by the patient. It ends up being a really nice scenario. Not all of my patients can have implants, whether it's due to, some health or medical issues that kind of prevent them, or they're contraindicated in, or there's not enough bone and they're not willing to do some sinus augmentation and the necessary grafting. Bridges can definitely be a really nice option. And rather than getting a pontic with a tissue bearing site that you don't really like, you maybe want it more ovate or more ridge lap or whatever your preference is, and the lab doesn't send you back exactly what you want, these we can design in the system. I'm able to not only design these 3 crowns, but I can flip this over and pull out this tissue bearing surface and get the type of emergence and tissue pressure that I want, all by my own design, rather than someone looking at a stone model somewhere. So really, really nice advantages there. I usually take a survey of the room and ask how many people are doing Maryland bridges. And I maybe will see one hand in the room. And I think that's unfortunate. I think Maryland bridges are a severely underutilized type of restoration. We do these routinely in practice. And I think the reason that most people avoid Maryland bridges is because they can be unpredictable, right? I mean, they always present the same way. It's usually a patient that's congenitally missing a lateral. They've had like a PFM Maryland bridge in for years. They call and one of the wings is loose or debonded. So you work them in and you kind of try to tease back the wing and etch and bond, squirt some cement in, squeeze it, tell the assistant to shine the light on it, and you cross your fingers and say, oh, I hope this stays. And they call back a day or two later and the whole thing's off. And the reason that that happens is that we've all been taught to do Maryland bridges incorrectly. Bonding these 2 teeth together is inherently bound to fail. And the reason that that happens is when we have to think about the person or the patient's function, we're bonding this lateral to the central and to the canine. And those 2 teeth, when the patient's in function, do not move in the same plane. 8 moves facially and 6 moves laterally when the patient's functioning, right? And so what we've done is bonded this piece of glass between 2 teeth, and we're just slowly twisting this back and forth every day while they're chewing, waiting for one of the wings to debond. At that point, both have been under such load that the other one ends up debonding and they fail. Maryland bridges that are done with single wing, so that the pontic and the wing, it doesn't matter if that wing is on 6 or on 8, but when that pontic and the wing are together and there is no other wing, now the pontic can move with that wing and it doesn't have this torsion on it. And these things last for a very long time. I have PubMed articles I can share with you and email you so you can look at survivability. But the survivability of a 2-wing Maryland bridge at 5 years tends to be around 70%. The 5-year survival of a single wing Maryland bridge is over 95% or 94, somewhere in there. So it's a marked difference. And that all comes from not having those antagonistic type forces pulling that Maryland bridge back and forth. So, why do I do Maryland bridges, or what's the reason? Well, one is going to be, pediatric patients, the 14, 15, 16-year-old patient, not ready for implants yet, doesn't want to have a Holly or an Essex or a flipper while they go through high school. I can do these non-prep by simply bonding the wing to the lingual if there's enough room. We work with the orthodontist to make sure there's some room on the lingual when those teeth are finally positioned, that I can put that wing on there, because I don't want to prep this tooth. And we do that out of Emax, and we bond into place and they do just fine. But the other area that these are really important are for my patients that are getting anterior implants. When we place implants here, or if I'm having it referred from a periodontist or an oral surgeon, it's always for this. The periodontist and oral surgeon have done a lot of soft tissue work, bone work, whatever, when they're placing this implant in the anterior. And the last thing they want is a flipper put on that site, or an Essex, which is filthy, put on that site and beating it up for 3, 4, 5 months until the implant's integrated. Instead, what we do is we mill these out of those resilient ceramic blocks, that CEREC or Tetra CAD, something like that. We bond these to place non-prep, okay? And then that patient doesn't have to have a flipper. So when my patient goes out to dinner and their peers are with them, my patient's eating, the peers are taking out their flipper because they're getting an implant as well. And my patient's like, what are you doing? And this ends up being a self-referral. You know, patients come in asking for this because they really hate wearing flippers for those 4 to 6 months. And the question always pops up, you know, like, well, how do you do this non-prep? If the patient's class 2, there's no room to put this temporary Maryland bridge in for 3 or 4 months. What do? Well, rather than putting this veneer on the lingual, I simply just put the veneer on the facial. I make the veneer the exact size and shape of the facial of the tooth, just like doing a minimal non-prep veneer. It's going to be very thin. And I tell the patient, you know what? The facial of number 8 is going to feel a little bulky, but it's going to be polished back and it's going to look like a tooth, and the translucency of this material looks fine. And then they don't have to have that thing coming in and out while they have the potting in place. We haven't altered the tooth structure. We haven't prepped anything. We've bonded it on, no different than bonding like a bracket or something. So when the implant's healed, we simply take an ET burr and we can cut through that resilient material very easily, polish away any resin, and the patient's ready to go and never had to go with a flipper or anything like that during those months. So the tissue stays really healthy, the implant heals well, and it just ends up being a very nice situation for a patient compared to having to wear something, again, like a flipper for months at a time. Now, just because I have a CEREC doesn't mean that everything in my practice is done in-house. There are still times and places that I need to use a lab, especially when I'm doing diagnostic wax ups and things like that. And there's times that I want my lab to do the case because honestly, we're not taking the time to mill out 20 restorations and fire them and stain and glaze all of them. I'm going to scan that most likely and send that to my lab when I'm doing those full mouth rehabs. But I still want to use my CEREC system for that, because why would I want to go back to trying to get that many units in an impression at one time and miss one with a bubble or something like that? Way easier to just do it digitally. So let's talk about that case. You're going to see an individual here. He has some chipping and wear on the anterior teeth. Not happy with it. This is his kind of pre-op condition. We're going to overlay kind of some photos here so you can get an idea of what's going on. Endo's been done here. You can see the wear, some lack of posterior support. Here's the radiographs overlaid the situation. You can see the composites that are in these anterior front teeth. See the endo done on number 7. And then you're going to see a scanning software, CEREC Connect. So this is all now integrated into the 5.1, but you would basically scan, submit this to your lab. And when you submit it to your lab, they're going to get this digital model. From this digital model, they can do a diagnostic wax up. They can 3D print models. That's what you're going to see here. Or you could 3D print these in your office if you wanted. Then they can send you a digital wax up. The nice thing with this is this digital wax up's interactive. You can rotate it. You can move the lower teeth away and just be looking at the upper teeth. You can email this to the patient and let them look at the wax up and see what they think about the position of the teeth. And then from there, I'm doing conventional dentistry, okay? None of that changes. And to me, if I'm doing more than 4 units, and usually even with 4 units, 7 through 10, I'm almost 100% of the time getting a wax up. And the reason that I want to do that, even if I'm making the restorations in-house, is I want to know what my final product's going to be. And I needed to determine the thickness of my ceramics from what my final restoration is, not from just picking up the handpiece and starting to prep teeth. And that's where this CEREC matrix or Copyplast matrix or whatever you want to use becomes so beneficial. By having a mock-up done and having a CEREC made of it, what I can do now is put in conventional temporary material and transfer that to the patient's mouth. When I transfer that wax up to the patient's mouth, I now make all of my depth cuts through this bisacryl material. I'm not picking up a handpiece and just whittling away at the teeth, because if you remember, he had a good bit of wear on the incisal edges of 8 and 9. So I don't need to take off necessarily 2 millimeters there. I need to take off 2 millimeters from where I'm going to end up. So what I can do is start making depth cuts through the facial surface. And here you're seeing this 1.5 millimeter depth cut burr. And what you see is I hit some tooth here and here, but we didn't hit any tooth here, okay? And when we don't hit tooth, we know we don't have to cut anything off the facial of those. When we pull this off, we're basically going to make our margin and clean it up, and we're not over reducing the teeth. And that's going to guarantee us that at the end, all of these restorations are going to have that same uniform thickness across the facial and across the incisal edge. We can then mill out the provisionals. I don't know how often you guys provisionalize large cases, or even single units. I'm sure if you're doing these with cold cure acrylic or cold cure temporary material, it's porous. And when that patient comes back 2, 3, 4 weeks later, especially on one of these large cases, and you take these temps off, the tissue is really angry. And that's because it's collecting debris and bacteria and stuff. It never smells good when you take those things off. These being made out of those pre-cured PMMA blocks that we saw when we were looking at the material section are milled to the exact margin that my final restorations are going to be milled to. They're pre-cured, so they're not curing in the mouth, so we know they're not porous. And the tissue comes back looking pristine, like this, not red and angry. Here are the provisionals polished and in place, all splinted together, right? Then the patient comes back and has his finals delivered. So you can see here, he decided to go with 7 through 10. You guys saw this case earlier. This is anterior zirconia, hand polished. And the restorations turned out quite nice. Before and after, and I think from a digital dentistry standpoint, there's no lack of contour, color, aesthetics. I don't think anything in this case could have been accomplished better or differently by using conventional impression materials. So I want to talk a little bit about biocopy, because that's something that I use in my office on a daily basis. And it tends to be an underutilized, I think, technique with CEREC. So what biocopy does is it allows me to make an exact one-to-one copy of any restoration in the mouth. So if you think about this case, this patient comes in, they have a cast RPD, they have a PFM, that's a survey crown with a rest seat on this number 21. They have recurrent decay at the margin of that PFM. So we don't have a lot of options, right? If we don't have a CEREC and we don't have the ability to biocopy this, we can cut off the crown, we can prep the tooth, and then we can take an impression and send the patient's partial off to the lab, so they have to go without their partial for weeks. Or we can try to make a little jig or something of the class. We can try to do all these different things, and none of it really works, right? It all ends up being kind of an okay fit, maybe, and it ends up being a lot of work. Instead, with CEREC, what I can do prior to prepping that PFM off and removing it is I go ahead and scan the preoperative condition or the PFM into the software, rest seat and all. Then I cut off the crown. After I cut off the crown, I scan my prep. The software will merge that pre-existing condition and the post-prep condition together, and it will give me a one-to-one copy of the PFM that was there prior, only changing that bottom maybe third where I've altered the margin from the recurrent decay. So now the patient can have the crown seated, the partial is going to snap right back into place because it's an exact copy with the same contours on the facial and lingual to accommodate the clasp, and the same rest seat to accommodate onto that occlusal surface. So that looks something like this. This lady presents to me, she's roughly 85, 86 years old, lives in an assisted care facility. This cusp, obviously you can see some breakdown here, old amalgam. And I start looking at this and I'm like, what am I gonna do here? And I don't want to necessarily have her go without her partial, so I know I'm gonna copy it. But I have to start thinking about the patient's scenario. Remember, we talked about materials a little bit. And you may say, well, let's go ahead and do a crown. And that would be a fine option. The only problem with doing a crown here, okay, is that one, we talked about she's in an assisted living facility. She doesn't have the best oral hygiene. The partial probably doesn't come out. The teeth probably don't get cleaned like they need to. And if she gets recurrent decay around my crown, now I'm gonna have to cut that crown off and redo it maybe in a couple of years, and I don't wanna do that. So what I like to do here is we start looking at doing an onlay. And let's talk about why. So here's the preoperative scan. You can see the large amalgam here, the broken down area. Here's our other anterior teeth. Here's the margin after everything's prepped out. You can see that tooth cusp that was broken off, still maintaining these other two cusps, tons of enamel here to bond to. Here's the stitch. So the kind of white is the porcelain or the proposal, and everything's stitching together, the preoperative and the postoperative condition. Now I'm gonna make this out of CEREC. And I'm gonna make it out of CEREC because one, it doesn't have to go into an oven. The patient's not gonna have to be here all that long. She's gonna be here less than an hour to get all this done. I simply just polish it, 5 minutes to mill it out. And here it is seated, and you're gonna see the clasp and everything wrap around just like they did prior. Now, the reason this is beneficial to me, if this patient gets recurrent decay right here at the margin, or over here on the buccal, or down here at this lingual margin, because this is a hybrid material, it's repairable. If this were Emax, zirconia, and she got recurrent decay, I'd be cutting the restoration off. Because of the resin component of these hybrid blocks, if she gets recurrent decay anywhere around these margins, I can have her in, anesthetize her, and I can simply prep out the decay and then phosphoric acid etch and bond and fill in with composite to any of these margins and keep her patched in and doing well without having to cover this tooth with a full crown. It's really nice to be able to work with patients like this. They're super appreciative to not have to go without their partial. She's in and out in less than an hour. She hasn't had any recurrent decay around this restoration. It's been in service for years now. But it's just a really nice scenario that if I didn't have my CEREC, I don't know how I would be doing this case for this patient without a lot of headache and for me and heartache for her going without teeth for a number of weeks. So again, how would I do this? I could take a second impression with a partial in place and send that to my lab, and hopefully they can duplicate that and generate something that would maybe fit. I can do a jig. I started in a pros office my first couple of years of practice, and we did all that stuff with like Duralay and jigs and how to make copies of clasp and try to do that, but none of that really works. And then I could send the partial to the lab, and now that patient that's already missing, all the posterior teeth besides that one molar is also missing 23 through 26 and has no teeth to function on for a number of weeks until we're able to get everything back to place. So, I want to go now into discussion a little bit about implants, because I think that's a relatively kind of hot topic within digital dentistry, and the things that we can do from an implant standpoint tend to be, I think, better than what we can do in an analog manner. So if we start talking about implant dentistry, doing it digitally, abutment design, there's a lot of benefits to me and to the patient by doing this digitally. The impressions are 100% in my mind easier than general impressions from an implant scenario. The accuracy is definitely there by comparison, and it's much, much more cost effective. So if we look at what is a conventional implant dentistry impression from an analog standpoint, you're looking at either a closed tray or an open tray technique, okay? And I mentioned that I had been working in pros for a while before this practice, and most of the impressions that I did there were open tray, but I would probably assume that the bulk of individuals are using closed tray techniques. The closed tray technique has some issues, right? I mean, it works. We get restorations back, and I think probably the bulk of the time it's okay, but we're screwing this to place. We're taking an impression, and then we're peeling the impression out. And so we know that this site distorts. It has to. That's the only way that we can get this out of here. Then you unscrew this, and either you're kind of eyeballing and sticking it back in, and hopefully it's the exact same alignment, or the lab guy is, or someone. And then an analog is being put on the end of it. Then some soft tissue model is being poured here. Then stones being poured here. Then all that's being separated. There's so much room for error along this path that I really am surprised a lot of times that this works as well as it does, because we don't have a lot of options for how this abutment or restoration is going to seat. It's going to go in a very specific way. These are engaging connections unless you're asking for something conical. And if it's off at all, we're just kind of, dead in the water. The other option is to do this technique, right? These open trays. And we used to do custom trays for implant restorations. And, I would do this kind of thing like dental school where you block out the area, you put in the large open tray copings, you take the impression, you're unscrewing them. Now, this does avoid the possibility of not putting that impression post back in the exact manner that it was in the mouth. So that takes out a little bit of error, but we still have to put an analog on the bottom of this and have it just kind of sticking up in the air. We still have to pour a soft tissue model, which can displace. We still have to pour stone, separate it. There are still all these components and issues that can arise with conventional implant dentistry that we just don't see in terms of a digital image. And what you're going to see here is an impression of an implant site. And what you're seeing stick up is two pieces. You're seeing a scan body, that's the gray piece. And then underneath that scan body, you're seeing some silver metal, that's the scan post. The scan post is basically a closed tray impression. Okay, it's specific for each implant system. You're going to have one for Straumann or Nobel or Astra or whoever. And then this little scan body is going to snap onto the top. And this gray scan body that you see in this image has a triangle or a pyramid on the top. The pyramid on the top tells the software a couple of things. The tip of the pyramid that's sticking up right here tells the software how far away the implant platform is. So it already knows where to start designing the restoration from. The pyramid is also an isosceles triangle. You'll see that it has a point right here kind of pointing to 9 o'clock. Well, that is a timing indicator. So whether this is a trilobe or a hex or whatever kind of connection, it only is going to engage in that way. And then that relates to the software where that rotation is. So now not only do we know the depth of the platform, we know the exact rotation of it. And what we can do from there is move forward with fabricating these in-house. And fabricating these restorations in-house has a huge cost benefit, like we talked about, for the practitioner. We do have some consumables. We got to use a tie-based kit. This is going to be the titanium component. We also have to use a scan body. These are disposable. But the scan post, the silver component, is autoclavable and reusable. And you'll use these over and over, just like you would a closed tray impression technique. And I always get asked kind of what implants, but it's really all of them, right? So BioHorizon, Astra, Biomet, 3I's, now Zimmer, Nobel, Straumann, Camlog, and really all the clones of those, okay? There's not very many systems that aren't supported by the CEREC company or CEREC software. We do have some costs. It's not free to do this kind of thing. The tie-based kit, this titanium component, and the prosthetic screw cost me around $90. And then I have a block that has to go on top of that. So that's costing me another $72. The block with the hole in it's a little bit more expensive than a regular block. And so if I do a screw retain restoration, maybe I'm in $165 or so dollars. If I do a cement retain one, I'm in $185. And that's because I have to have another crown, right? I have one block that I make the abutment out of, and I got to make something else with the superstructure. So still under $200, whether I do custom abutment crown or screw retained. And if I'm doing these with my lab, and when I would do these kind of gold abutments or titanium custom abutments with my lab and then put a crown on them, my bills were generally $550 to $600, about $400 to $500 for the custom abutment, another $100, $150, $200 for the crown. I realize that there are probably some labs that are much less expensive than that, but on average, about $400 to $450 is the general going rate for a custom abutment, and you're still putting another, at best, $100 crown on top of there. So, the comparison of $165 to $500 is a pretty big difference for every single restoration that you do, and that's where these cost savings become really, really interesting for me. You don't have to do that many crowns a month for the CEREC to kind of pay for itself. So I never look at it in terms of how many single unit crowns or anything I have to do, because I'm doing all these other ancillary procedures like implants, like custom healing caps, like guided surgery, like ortho. All those things combine to really give this system a huge return on investment. So generally I'll ask, when we show this case to the audience, if anybody has any guesses of where the implant is. I'll let you guys kind of look for a minute. I'm not sure if, any of you can kind of pick out the implant right away, but the implant here is this canine, okay? 6 is in the position of 7. The patient was missing number 7. They retained the deciduous C. And so C was extracted, implant was placed, and the implant was temporized same day. And that was done without impression material, without any goo or powder or anything going in the patient's mouth. That looks something like this. So implants placed, good torque, loaded same day out of occlusion with a screw retained temp. Now this is that PMMA block, and yes, it's a little bit light, but it sure looks a lot better than that dark tooth. The bigger deal here is this tissue contour. This tissue is going to heal to the shape of a crown. It's not healing to the shape of a round healing cap, because teeth aren't round. Teeth have, molars are more square, and these anterior teeth are more elliptical. Putting a stock healing cap on and going straight to an impression only leaves you with the possibility of kind of poor outcomes. If we go back and look at this picture, what you can tell exactly what happened here for this impression, right? Patient walked in, implant was placed at number 19. Patient needed the implant crown. The stock healing cap was removed. The impression post was placed. The impression was taken and pulled out. And do any of you think that is what number 19 would look like if you did a coronectomy and looked at the roots of it? No, I mean, it's not round. So now your lab only has 2 choices. They can either, one, under contour that crown and make it follow this tissue profile that you sent them, okay? And what happens then is we end up with a big pumpkin on a little stick, and everything in the world packs in around that brand new implant crown that the patient got. Or your lab can do a full contour from the platform up, abutment, which is what should be done. But the problem with doing that is when you seed it, this tissue and this tissue is going to blanch. And if you don't take care of that and you just seed it, then the patient's going to have tissue necrosis and have issues with the implant abutment as well. So one of 2 things needs to happen, even if you're not doing this digitally. If this is the type of impression that you're sending to your lab, you need to tell them to go ahead, build that abutment to full contour, and then at the day of delivery, you need to be willing to alter the tissue a little bit so that you can seat that abutment. Meaning a little drop of anesthetic in this papilla, a little drop of anesthetic in this papilla, and then a 15 blade straight across the ridge. Not flapping it, not reflecting it, just releasing those circular fibers so that when you seat that full contour abutment, that tissue doesn't blanch and turn white and get angry, okay? It's gonna heal right to it. So be willing to alter that, or stop using the stock healing caps and start doing some healing and customization and growth of that tissue so that we can take a really nice impression. So here you can see we're developing these papilla because we don't have that round healing cap. We have a nice solid tooth there that looks good. And this is the type of tissue that we get at the end. Okay, this is milled, Emax, a little bit of staining and glazing, blends in great. All because the tissue here was maintained and handled in appropriate manners. There's a lot of other workflows though. Maybe you don't want to make the titanium abutment in your office. Maybe you just want to make the crown. Well, because the Atlantis lab that makes custom abutments is in the same family with Dentsply Sirona and owned by Dentsply Sirona, if you have a CEREC, there's a specific workflow to go with the Atlantis lab, where you can actually get these custom abutments at a discounted rate because you're using your CEREC machine. So here's an example of a tooth that needed to be extracted. Here is the implant placed with a regular healing cap. Here is the Atlantis specific scan body. So these work just like a closed tray impression. Screwing them to place, they are reusable, okay? You screw this in place, you scan it, that gets sent to Atlantis. And what Atlantis is gonna send you back within 24 hours is a design that looks something like this. So within a day, you get this back in your email, you open it and you say yes or no. You can change where the split level is. If you don't like the way they've drawn the margin, if you don't like the emergence, you can change any of that. Once you say that you like it, they are then going to send you what's called a core file. And the core file is that abutment already in the CEREC software, already in the patient's mouth, marginated for you. So now you can design these crowns yourself. And then within 2 days, that abutment is at your office. So there's the custom titanium abutment. There's a zirconia crown over the top. You can see everything in place here. And then we get this really nice emergence. Now, look, you see a little bit of blanching here, but that's because that releasing incision was made in both places and this full contour restoration was seated. It's not this little skinny stalk following where that custom or that non-custom healing abutment was, and then coming up to this large restoration. I hate when I see those things like that because everything in the world is going to pack right here on the patient and underneath this overhang. But instead, by being willing to alter the tissue, we can create proper emergence profiles. Any questions on that so far? Let's see. Will you discuss accuracy of full edentulous arch scans? I'll get into edentulous scans at the very end. We'll talk about that a little bit. If I forget, type that again, but I'll get into that in the digital denture workflow a little bit. What cementation do you use for the biogeneric crowns? How long will it last considering the on and off of the partial? So I'm going to cement that with Panavia SA Universal because I'm usually doing those out of zirconia, and it is going to last just fine. No different than the PFM that was on there before. You know, that one that you saw that was the onlay, same deal. It's going to hold up way better than that amalgam that she had in there, and that had been in there for years. So to be fully confident in those and in that material, as long as it's getting into true bonding. The way this is kind of going here, we may have ability to talk a little bit about bonding. I usually like to do that to discuss the material, so I'll make sure we try to get to that. I really like talking about guided surgery because I don't know that I would be doing implant surgery in my office if it wasn't guided. I've been doing implant surgery for years now, and it's so much more predictable with a guide. It's way easier on my nerves and stomach lining to have a guide and to have everything planned prior to the patient coming in. So let's talk about what that looks like a little bit. The CEREC Guide 2 is a system where I can scan the patient within a Sirona CBCT, scan the patient with OmniCam or Prime Scan. I can merge those files together and go ahead and kind of do my surgery digitally within the CT and then generate a guide from that. So that looks something like this. I'm going to scan the patient. You can see they're missing number 19. After I scan them, then I'm going to scan them with the camera. Now you're going to see the image here. You're going to see this blue line drawn. That's the margin. Okay, that's where I want the software to, you know, marginate or make my crown to. And then here's my design. So I get my proposal for my crown first. I don't put the implant in and then try to figure out how to put a crown on it. I design the crown and then place the implant based on where that crown needs to be. I can now take this design, this crown, and import that into my CBCT. So in the CBCT, what you see is you see the inferior alveolar nerve marked. That's super easy to trace right through here. You see the incorporated crown. And now I can move this implant and place it so that the screw access hole is going to be right at the central fossa, knowing that I'm going to be able to screw retain this restoration. So instead of placing the implant here or angled, knowing that it's going to be placed dead on, vertical, super easy to restore. I send this plan where the implant is placed back to my CEREC machine. The CEREC machine then generates this guide for me with this hole that allows the drill to pass through, but not to go mesial, distal, buccolingual, also not to go too deep, because the drill looks like this. The implant drills fit into these sleeves. They have a vertical stop. So basically, you place the guide in the patient's mouth. After you place the guide in the patient's mouth, you just bury the drill. And you bury the drill each time. until it's finished. And we end up with a nicely placed implant. Now, these blocks are quite big. It does take about 45 minutes to mill out one of these guides, but this block only costs like 45, 50 bucks. The bigger ones cost about 60, but they do make a mess. So you're gonna see in this milling unit, this kind of fiber sitting down here. That's just some aquarium filter to keep all the dust from getting down in the tank. 45 minutes to mill, and it's very, very loud because you're grinding on acrylic. But you can see all the acrylic kind of piling up here at the bottom already on top of that filter. And that's what I want to keep out of that tank and keep it from clogging up. So that's why the filter's in there. Now, in the past year or two, I really have gotten away from milling these. I'm still using the workflow of designing the guide within the CEREC software. But once I get to here, now we have the option of being able to print these guides. So most of the time I'm not doing this implant surgery same day. I'm planning it, scheduling the patient, having them back. If I was doing it same day, the milled guide is really nice because within 45 minutes, I can do a fully guided surgery. But if I'm doing it a couple of days later or a week later, whatever, I can take that guide, export it, and I get something that looks like this. I can drop this right into my 3D printer. This is what it looks like when it's printed, okay? Has this little raft of resin. You can see the screw hole here. This is a Formlabs printer. So this is made from their surgical guide resin, which is actually FDA approved for implant surgery. Once it's printed, it needs to go into an alcohol wash or a bath. And that happens twice. So one alcohol bath here, then another clean one here. There's also some automated wash techniques that Formlabs has that you can use as well. Once we go through the alcohol wash that gets all the resin off, it needs to be cured. So this is a curing oven, basically that you get like from a nail salon. You can order these off Amazon. It's a UV curing light. Once this is done being cured, you can see that it has turned different colors. That's how you know the resin's cured. You can do the entire surgery now through that hole. We're able to access it with a punch. We have plenty of keratinized tissue everywhere. After removing the tissue, we go stepwise in our normal kind of recipe of doing the implant surgery. And then we're able to place the implant with that depth control, the mesiodistal control, all done with these metal sleeves. Something else that I've really been enjoying lately is the Azento workflow. And Azento has now been around for maybe 2 or 3 years from Dentsply. To be perfectly honest, it's kind of become my go-to for single tooth implants because it's so predictable and it's incredibly easy. So this is what the Azento system looks like. I scan my patient with any scanner, okay? It doesn't have to be a CEREC. It happens to be a CEREC in my office, but it doesn't have to be. And I scan the patient with any CBCT machine. Doesn't have to be a Sirona one, but again, those are the companies that work together, so it works out. I submit that to Dentsply, and what they send me back is the plan. They actually plan the implant, design the crown, design the abutment, and do everything for me prior to surgery. I get that plan and I can make alterations to it. I can move the implant, change the implant size, change the platform, the depth. I can even change the emergence of the abutment. So I do all that digitally. Once I approve it, I send approve back to Dentsply. What they send me back is this nice little box. And this box makes my assistant's life 1,000 times easier when we're setting up for implant surgery. No longer is she having to spend all afternoon setting up for an implant and making sure the drills are new, or how many times have we used drill 1 or drill 2 or drill 3. This box comes with brand new drills every single time. It comes with the implant. It comes with the surgical guide. It comes with a custom healing cap, so I'm no longer milling those like we were doing before because it's already done. It also comes with a final custom Atlantis abutment, and it even comes with a temporary crown out of occlusion if you want to load it same day. So the thing that's really nice about this is the process. I scan the patient. I scan them with the cone beam, and I'm not doing this. I send this to Atlantis, and they send me this proposal back. I then place the implant through the guide. This carrier has a little notch on it, and the guide has a little notch on it. That's what's controlling the rotation or timing of the implant. So as you're placing it, you make sure that those two notches line up. Now your timing's right on. You can go ahead and place either the custom healing cap, you can see the nice emergence here, or go ahead and place the custom abutment with the temporary crown and end up with a scenario like this on the same day. Now, to me, all of that makes it so predictable that when we do these cases, there's some planning on the front end, but the actual procedure time from anesthesia to the patient walking out the door is usually about 25 or 30 minutes, all said and done. It's an incredibly quick implant surgery. As long as you have good bone and tissue, you're not even laying a flap. If you don't have enough keratinized tissue, maybe it's 5 minutes longer because we've laid a flap and we got to suture it back. But when we have plenty of keratinized tissue, it's just a slam dunk every time. The core file is also sent to you because remember, they're sending you this temporary crown here. So they send you the core file like we saw earlier of the abutment already in the CEREC software. Now what you do is there's the final abutment that they sent me. It's already marginated. I'm going to design my final crown and I'm going to go to the mouth and deliver it. Same deal here. Here's the custom healing cap. There's the custom healing cap in place. Here's the core file with the custom abutment designed. I have the custom abutment that came with the box for Azento. I make the crown myself, deliver the crown, and the patient's good to go. Another option for guided surgery in the CEREC workflow is with working with CCAT. CCAT is a company out of Germany. They have a couple of options for you in regards to getting some guides made. You take an optical scan, you take your CBCT scan, you actually plan the implant yourself using their Simplant software, and then you send it to them. When you send them the plan, they can make what's called an opti guide, where they make the guide for you and send it back with the sleeve in there. You can take that plan and make your own CEREC guide too, like we've seen, or you can have them make you what's called a digital guide. A digital guide is where they design the guide and then they send you the STL, or the file that you can print. You print this in your office, you snap in the sleeve, you go forward and do your surgery there. They also have the option of doing something called a classic guide. A classic guide, we're doing these for our bigger all-on-4 cases. We're doing these for cases where there's a lot of zirconia and metal in the mouth and it's difficult to get the CBCT data to merge with the optical impression. So in this case, we use some radiopaque markers within the stent and we make our guide that way. But tons of surgical options with Dentsply Sirona. Something as simple as a single site CEREC guide too, very cost efficient, but does require either printing it or milling it in-house. The digital guide, having CCAT kind of verify the plan that you have, making sure the merge is good, some extra kind of certifications there, still printing it yourself, or having them print the guide for you, or again, having them make the guide with some radiographic markers. If you have them send you the DigiGuide from CCAT, what that looks like is this. I merge the data. So I've married up my CBCT that you see on the right, and I'm looking at my optical impression on the left. I'm finding common points. As I'm finding these common points, the software is saying, all right, there's that lateral incisor, here's this lateral incisor, and we go around and mark good data, and that allows the software to merge these two together and stitch them. Now, when these are merged together and stitched, I end up having the CAD/CAM data integrated directly into my CBCT, which is what you see here. You see this quadrant scan overlying the data, and you're going to see this yellow line following the occlusal surface on what we see on the radiograph. Then I can place my two implants virtually. I can look at them and make sure they're in the bone where I want. I can set my boundaries, my kind of safety zones. Do I want 2 millimeters between implants? Do I want 3? You know, all that kind of stuff, whatever your preference is. After we get the implant positioned and rotated like we want, we can move to the other one. We can make sure if we want, we can parallel the implants in the software. We can look at our sleeves and make sure they're not going to bind against each other. After we do that, we can then export this directly to CCAT. So when we export this to CCAT, we tell them we like everything. They're going to look at the merge. After they look at the merge, here's the video of the exportation. So you see AstraTech, that's what we're replacing in this regard. Next, we go to the CCAT portal. And what's going to happen when we log into the CCAT portal is we are going to find our case. And so the cases are going to be listed here. I can see the ones that are transported, the ones aren't. I can click on digital guide. That's just an STL or a file that I can download. I'll download that. Here's the cookbook for how I'm placing the implants. Tells me which drills I'm using for this one, which one I'm using for 28 and 29. I'm using the 9 to 11 drills for the 4.8. I'm using 9 to 11 drills for 4.2. I import the STL of the guide. When this imports into the software, you'll see the guide there. We flip this over so the supports are not on the intaglio or tooth side. They're on the outside of it. So basically flip it 180 degrees. We're going to tell it to generate some points of contact for me. Here's my little raft. We go forward with printing it, and I have this done within about a day. So we're not going to wrap up just yet. We're doing things a little bit out of order by trying to fit all this into one day. But I want to see if there's any questions or anything like that before we jump into the next category. No questions on the implant dentistry. No questions on guided surgery. All that's making sense. Perfect. Very cool. Okay, so, oh, maybe one. Let's see. Just a comment, not a question. Okay. If one does pop up, let me know. Before I jump into the bonding part of the lecture, since we have some time, I think it's probably worthwhile to address some of the edentulous scanning questions that have popped up. Oh, now there's 2 questions. Hold on. 3 questions. I do have a comment on oral hygiene. There was a lot of calculus on one of the cases. Well, I think that that's probably unfortunately standard with a lot of patients. We do all we can with our abilities while they're in our office, but we cannot always make them have the ideal home care, no matter how often they're coming in. Some patients, you recommend 3 or 4 month recalls and they still don't come in, but for 6 months or something like that. So you're correct. It's just like patients that you fix teeth on and they come back with decay in the same teeth 2 years later because they don't maintain them. But okay, so before I get into the bonding, let's talk a little bit about the edentulous arch scans. The prime scan is extremely accurate and easy to image edentulous arches. It stitches them together very well, okay? But you still have to have some way of relating the arches together. The other thing you have to do when you're talking about, and my guess, Nicholas, is that you're asking about for removable, like for a conventional denture or something like that. The only way that you can get adequate seal and suction from like a conventional maxillary denture is by loading the tissue. There's no other way to do that. So if you think about what's happening when I'm scanning, I am taking the cheeks and pulling them out, and I'm running the camera inside the mouth. I'm getting the vestibule, but I have the cheeks pulled, and that's not the true drape of that tissue. I also am getting a static image of where the soft palate is starting, which is exactly where those little minor salivary glands are that we're trying to compress to create that posterior palatal seal on the denture. So we do scan to get record bases, wax rims, all that stuff so that we can then create a bite. However, we don't have the ability to do straight from there to a denture. What has to happen is once that record base has been created and we take it to the mouth, I'm still going to have to do some sort of wash to get a copy of that vestibule. There's just no other way to get that functional movement when you're pulling the patient's cheeks around, moving the frenum back and forth, having them move and posture, or even doing a little coughing or something, so they're marking that posterior palatal seal where that needs to go, that has to be done with impression material. That's really about the only thing in my office I'm still using impression material for. And we still scan initially, and it's really nice to get those digital models, and it's nice to have those bite records and move on. But there are some workarounds to be able to do a bite record to mount those to each other. But I still feel like from a conventional denture standpoint, we start with a scan, but we still go to, again, that wash for accuracy and for loading. Instead of a wax up, is it possible to scan the mouth, digitally design the new smile, and print it rather than a wax up? So kind of is probably the right answer, okay? The way that we do our wax ups is we scan the mouth. After we scan the mouth, I send that to my lab, and my lab digitally waxes up that model. They send me back that STL, which is the 3D wax up. I send that to my printer and it's printed. So now I have a 3D model of the wax up. I then make my silicone matrix on that so that I can transfer that to the mouth. You can go off the digital wax up, just scan it and stitch those two together and do it like a biocopy case. Copy the wax up 1 for 1 and generate that, 4, 6, 8, 10 unit case that way. But I still think it's a better use of the dentist time to be doing the dentistry, and a better use of the lab technician time doing that wax up. And I work with a couple of different labs that are happy to do the wax up, knowing that they are only going to be doing the wax up, that they're not doing the actual restorative case. And they know that we're doing everything here at my practice digitally, so that it works very well. Great, I'm glad that answered your question. If there's no other questions, I think what we'll do is we'll go on to a bonding talk for a moment. So, if you look at, bonding protocols, and you look at all the different bonding systems, you may see something on this slide that looks familiar, something that you're using in your practice. And I think the real key with bonding systems is that they all work well, they all are good, but the scenario is that we have to work with each one individually. The chemistries need to work together. The chemistries need to be the same one. So I don't need to be using the bonding system from 3M and a cement from Ivoclar. I really need to be using the bond and the cement and everything that works together, okay? So what are we trying to do in bonding? We're trying to infiltrate these dentinal tubules. We're trying to get something, resin, to go in there so we can get a mechanical bond to these teeth. And we also want to seal up these tubules, because by sealing up these dentinal tubules, what ends up happening is we end up with a lot less sensitivity. So there's some specific steps we have to go through to make that happen. The first thing is that we have to isolate. Cotton rolls and dry angles, as great as we want to think that is not truly isolating it. You may put cotton rolls and dry angles and everything in there, even a high volume suction, and the minute the patient breathes out, you see your mirror fog up completely. And that's all moisture, right? And so that's what's contaminating the prep and contaminating the bond. And to make sure that that doesn't happen, I need to have something in there, whether it's an isolite, which is my preference, or a rubber dam, which works well too. I just prefer the isolite, but something has to be in there if we're going to be truly bonding to make sure we have good isolation. Even the Optrogate is better than nothing, okay? I use these a lot when I'm doing my ortho scans. It keeps the lip, the cheek out of the way. It's really easy to do full arch scans with these in place. They're disposable. They're very inexpensive. Just use them once and toss them. So from there, we need to have some sort of form of hemostasis. Retraction paste, laser, whatever you want to use, all are fine, just something so we're not having a bunch of blood contaminating our prep when we're trying to bond to it. And then we have to etch. And what are we doing when we're etching? We're trying to kind of remove that smear layer. We're trying to infiltrate some tubules, open them up so we can get some resin to flow in there. And we're trying to prepare that enamel as well. And so we have a couple of options when it comes to etching. Option one with etching is we can do the total etch technique. The total etch technique actually works really well The only problem with the total etch technique is that we end up with some sensitivity, right? In the only time I will total etch in my office is if I'm totally in enamel. So I'm doing something with veneers or something like that, or if the tooth has had endo. Otherwise, I'm not going to do this technique because the increase in bond strength doesn't really work for me with how much sensitivity can happen from a total etch technique on dentin. But the higher bond strengths are there. Another option is a self-etch technique. And a self-etch technique is super easy, okay? You're just scrubbing the adhesive in there, but the bond strengths are just quite low compared to one that uses etch. And so you kind of run this battle of, do I use something that is less sensitivity, like the self-etch technique, but not as great a bond strength? Or do I do the total etch technique, get a really strong bond strength, but run the chance of sensitivity? Well, what we do here in our practice is kind of the in-between. And the in-between is the selective etch technique, okay? And the selective etch technique is anywhere I see enamel gets phosphoric acid on it. When I'm doing a partial coverage, obviously this whole occlusal surface, am I getting some on the dentin here? Sure, you can't just get it on enamel, but we're doing our best to keep it off the dentin. Once that is etched, then we rinse it off. And what we'd like to see is this nice kind of frosty enamel appearance. From there, I got to apply my bonding agent. And when you apply the bonding agent, it's important to do it for the amount of time that the manufacturer says. You know, it needs to be 20 seconds for some, it needs to be 10 seconds for others. Curare in their clear fill now has one called Quick Bond that's only 3 seconds. But for whatever that is, it needs that amount of time, and that's quite a long time. You know, it's not like a 1, 2, 10. It needs to be actually 10 seconds to infiltrate those tubules, to make sure that the desensitizers are getting in there, to make sure that you're getting an adequate bond. If you don't, you're probably going to get an incomplete bond. You're probably going to have some sensitivity after the bonding. And that's something that isn't fun for anybody to deal with, especially if you're doing, you know, large cases and you have patients coming back and they're sensitive or having problems. It's just nothing that you want to do. So, you know, this slide is nice because it ends up being a really good presentation of what's going on with, you know, dentin bonding and tooth bonding for that matter. I'm sorry, I have a puppy in here that decided it wanted to attack. So, you know, we have something that is totally wet, we have something that is moist, and then we have something that is dry. And we want to avoid getting really dry, and we want to avoid getting really wet, because those two things don't allow us to do good bonding. We need to be in between areas like this where things are moist. So to do that, we need to, you know, not over etch the dentin. We need to rinse the phosphoric acid off. After we do that and leave the dentin moist, we can now scrub our bonding agent in, evaporate the solvent, cure. And now we have to start preparing the porcelain. And how do we do that? Well, we talked about this a little bit in the materials section, but we can either, one, etch the porcelain with hydrofluoric acid. Remember, the feldspathic porcelains and the other ones need about 60 seconds, where Emax is only going to be 45. But each one needs to be handled correctly. After that, we need to move forward with silinating it. Now, there are options to use a hydrofluoric acid etch and then monobond plus, or Ivoclar has an option called monobond etch and prime. This is your etchant and silane all in one. I really like this material because it keeps the hydrofluoric acid out of the office, which can be kind of pretty nasty stuff. So it's a little easier to work this way. You know, we start looking at cement systems. I'm going to go through a couple that are true bonding systems. Multi-link is a great cement system. I have difficulty cleaning this material up. It sets a little quick for me. I don't love the A and B. It always would seem to me like we would run out of one before the other, and they're supposed to be equal parts, and I don't really like that. You have to mix these together before applying it to the tooth. But it is a really high bond strength system. And the other thing that's nice with this system is you do not have to cure the bonding agent to the tooth. You can simply scrub this in, thin it, and then apply the cement. So that avoids that pooling of resin that we talked about early on and preventing the full seat of the restoration, because you do have a primer that you don't actually have to cure. So it requires an etchant and some silane. You know, another one that you can use is Reliax Ultimate. Reliax Ultimate is a really nice system as well, but to me, it has a couple of drawbacks. One, this bonding agent, if you are using it or if you haven't, it's pretty thick. It's like about 40 microns film thickness. And with something that high, it's very syrupy on the tooth. So you have to really, really thin it to make sure that you don't have any of that pooled on the prep. The other thing here is that when this resin touches this resin, the curing starts. So it's gonna set very quickly on you. If you even kind of flash a light at it, it's gonna be rock hard and you're gonna be scraping it away. I don't really love the radio opacity of it either. I like to see my cement on the x-ray. This one's pretty radiolucent. And the other drawback here is any cement that has a cement and a bonding agent that'll self-cure. What causes those to self-cure are things called camphor quinones and these tertiary amines. The tertiary amines that are in resin systems like this can cause shade shift over time. And that may not be totally important on like a number 3 or a number 2, but when you start talking about cementing anterior restorations and anterior crowns, it can be quite important if you have shade shift of that cement over time. So if you are using this system and you want to use it in the anterior, what I would recommend is there's a second product that goes with it. And that second product that goes with it, you have to add to the resin or to the bonding agent. When you add it to the bonding agent, it neutralizes that tertiary amine. And by neutralizing that tertiary amine, it's not going to have that shade shift over time. But what that means is now you have to cure the bonding agent to the tooth. You can't just scrub it in and thin it. You're gonna have to cure it first because that curing agent is gone, and then add the cement afterwards. Now, the cement that I'm using at my practice mostly is Variolink Aesthetic. The Variolink Aesthetic cement works really well. I like this system a lot because of the colors that it comes in. They are not shade-based systems. They are more value-based. So you end up with neutral, a light plus, warm plus type of system. It does require its own bonding agent. It uses Adhes Universal, made by Ivoclar as well. But the dual cure system here doesn't have those tertiary amines. And since it doesn't have a shade shift, we don't have to worry about that in the anterior. But what it does mean is that I have to cure my bonding agent to the tooth. I don't have the ability to just scrub the bonding agent in and then add the cement. So you gotta really make sure it's air thinned. But the bonding agent that goes with this, the film thickness is very, very thin. And that allows us to do that without too much trouble. We talked about self-adhesive resins a little bit. I don't have a problem with these cements. They actually work very well as long as you're using them as they're indicated. Don't think that by using SpeedSem and just squirting this into a ceramic and putting it on the tooth, that you're truly bonding that resin to the tooth. That's not really the case at all. So that ends up being a problem because we're gonna start seeing resins fracture. We're gonna start seeing teeth debond, all because that bond strength is not really there. So nothing wrong with the universal self-curing, self-adhesive cements. Just make sure you're using them in the right areas and we should be good from there. If there's no questions on that, what we can do, if you'd like, is I can kind of run through what scanning for an implant would look like. So you guys can see that process and we can go from there. Any questions at all?
Don't see any.
Okay. So let me get everything set up in the computer. I'm gonna grab a Typodont that has an impression post and I'm gonna get rid of our files here. And that way you guys can see the entire process and kind of how it works. May have to open up a new software, we'll see. This has been an easy day, Adam. A lot of times there's like 50 questions. I haven't had that at all today. It's been nice.
You're lucky day.
A lucky day, yeah. So let's get rid of these catalogs. Let me go here. And then what we're gonna do is start looking at doing an implant restoration. So when we start looking at doing an implant restoration, we're gonna have a couple of other things to note or to look at compared to where we were prior. The first thing we have to do is select implant restoration. So that's here. After we select implant restoration, what we have to do is tell the software, are we doing a screw retain restoration? Are we going to do a split restoration, meaning an abutment with a crown over top? Or are we going to, missing teeth? I would never use that. That ends up kind of giving you some bad proposals. So just one of the top two. And to be perfectly honest, I just stay with the abutment crown position, because when I select this, I don't have to necessarily split the restoration. I can stay as a screw retain restoration, but I can always go back and split it. If I select screw retained, which is what you see here at the top, and I decide I want to split it later, then I'm kind of stuck, because if I decide I want to split it, it's going to make me go all the way back to administration. So I would always stick with the abutment and crown. We'll do it as a biogeneric individual. It's going to ask me what kind of material I want. We'll say we're going to do an Emax, and we'll put an Emax crown on top. I can pick my mill. Now, what type of tie base am I going to use? Well, I'm going to use one from Dentsply Sirona. And if I use one from Dentsply Sirona and it's not Astra, because that's the Dentsply Sirona company, then I got all these other options. FX is going to be the old Freodent or Zyve system. I got Nobel Biocare with Branamark or Replace Select. I got Zimmer TSV, the old Astra OsseoSpeed before the EVs. I got Straumann Tissue Level, Biomet Certain. I got Straumann Bone Level, Nobel Actives. The list kind of continues to go on and on. But what I'm going to use and what I have set up is a Straumann Bone Level 4.1. So the Straumann Bone Level 4.1, and then we're going to scan with a scan post. Now we're going to say we're going to work on tooth number 30, which is here. And we'll move on to acquisition. So when we move to acquisition, you're going to notice on the bottom, we have an extra catalog that we have not had today. We're going to see one that says scan body for the lower. So what we're going to do, I have a model set up. We're going to scan the lower jaw. In that same kind of linear fashion that we've done throughout the day. After we scan the lower jaw, you can see the healing cap there in place, right? We're going to remove the healing cap and we're going to place our scan post. Our scan post is going to engage the implant, and I'm also going to have a scan body put on the top. If I put the scan post in and then put the scan body in, you'll be able to see that image in just a moment. Let me get it put together.
I think we jinxed ourselves with our lucky day. We got 4 more questions to answer.
Oh, look, that's fine.
Let's see. Let
me do this scan really quick, and then I'll start answering those since I have it set up, and we can have it processing. So now I have the scan body in place along with the scan post. Remember, we talked a little bit about this scan body. It has that pyramid on the top. You can see that right here, okay? That pyramid telling the software where the platform is and the timing of that Straumann implant that I have in the model. And what you're gonna see are the two married up, right? So if I go back to lower jaw, you're gonna see a ghost image here of that scan body in position. So now we can go ahead and scan the upper jaw pretty quickly. And then the last thing we're going to do is take a bite. Obviously, we do that with the scan post out. It's not going to be possible to do the bite with the scan post in. The patient won't be able to bite down like that. And now I'm going to let that model process and kind of move forward. Let's go ahead with the questions now that we have those.
Sounds good.
I can't bring them up when I'm sharing the screen, so it doesn't work that well.
Yep, no problem. What is the agent you mentioned to add the universal adhesive for Rely X Ultimate?
So you have to look at, I would go through your Shine rep. It's going to be something in that, oh, my camera turned off, 1 second. It's going to be something within that Rely X Ultimate system. So I don't know the exact name of it, but it's a neutralizing agent that gets rid of that self-cure in the bond. And it's just a little orange bottle. It looks like water. You just put 1 drop in, mix it with the 1 drop of the bonding agent, and then it'll be fine.
We had 2 questions regarding the Vario link. So the
Okay.
first one, what is the bonding system with it? And then also, can you go over the aesthetic again, if you don't mind?
Yeah, absolutely. So let me bring that slide back up for a minute. That way we have it. So I get back to the bonding lecture for just a moment. So the VarioLink, and again, the reason I like that system is because the bonding agent that goes with it, you can use for direct and indirect systems. So this is what it looks like. It comes in a dual cure version. That's the DC that you see. It also comes in a light cure version. That's the LC. The light cure, if you hit it with a light, it's going to cure it instantaneously. The dual cure actually has about an 8-second long tack cure. So that's a long time for a bonding resin. 8 seconds with a light, it's going to feel like an eternity to most doctors. And even after 8 seconds, it's really going to just peel away and clean up really, really good. But the bonding agent that goes with it is this one. So the bonding agent that goes with it is Adhes Universal, and Adhes Universal comes in 2 forms. One form is a bottle like this. The other form is a pen, and the pen's actually pretty neat. It has a well inside the pen. The tips are interchangeable. The pen's hermetically sealed, so you can cavicite it down. But if you just click a button and the bond comes out of the tip, you scrub it on, change the tip, put a new tip on between patients. That way you don't have all that waste in a well. But this is the adhesive you would apply. So if I were doing this restoration right here, I would apply the etch to the enamel. I would rinse that off. After I apply the etch to the enamel, I would then apply the bond, thin that and cure it. Then I would apply the VarioLink and seek the restoration and cure it all together. But the VarioLink does require curing that bond to the tooth. That's a step that has to be there. And that's there because, again, remember those tertiary amines that cause the set of the bond aren't in there, cause the auto cure of the bond aren't in there, but that's what you want because you don't want that shade shift over time.
Only other question was about CDocs, but maybe I'll let you answer that at the end when you wrap up.
That's fine. I can kind of go over that at the end and what all we offer and even show kind of a sample of that. So let's see. So let's look a little bit here. You can see now the scan, okay? If I take the lower jaw off, you're gonna see the implant, you're gonna see the tie base, and you're gonna see the emergence profile that the software has kind of designed for me. As I go forward, what's gonna happen is the software is gonna propose a crown. And it's gonna propose that crown based on the adjacent teeth and based on that impression. Now, I don't love this kind of emergence, right? That's what we're trying to avoid. But this is super easy to fix. We talked about this earlier, but you just basically use the smooth tool. And no different than when we were designing a normal crown, we just start smoothing away these overhangs in the areas that kind of have these concavities that we wish were a little more convex. We can come right here and pull this area out and then come back again with the smooth tool and smooth the lumps and bumps up and make sure that we have a really nice emergence from the platform up to the restoration. And the nice thing here, you can see how quick this is to design. Everything's pretty much done, and I can make this screw retain restoration in-house for about $160 rather than paying $500 or more to my lab. It looks like this when it mills out. You would then have this tie base component that comes in that tie base kit. There's a bonding protocol for luting the crown onto the tie base. And to be perfectly honest, that's one of these systems that when I first started doing these, I was expecting at least at some point to have some debonds or some failures because I'm bonding the ceramic to this titanium base. And it's just something that hasn't happened. that hasn't happened. So the issue there is that we want to make sure that we have a predictable implant restoration. And the way you do that is with multi-link hybrid abutment cement. So the multi-link hybrid abutment cement by Ivoclar lutes the Emax onto the titanium base. And then all the studies that Ivoclar had trying to debond this ceramic from the titanium base, it never occurred. 200,000+ cycles, they never had a debond of the ceramic from the titanium base. What they did have happen was the prosthetic screw broke, which that had nothing to do with, you know, the CEREC restoration. That was one possible failure. The other thing that happened was the actual platform of the implant flowered open and broke due to this cycle of fatigue over time. And that had more to do with the fact that they were testing it with a Nobel replaced trilobe. And that trilobe at a area is quite thin at the area of where the lobe is at, and that caused fracture. But in terms of the ceramic debonding from the titanium base, that never happened. So hopefully that is helpful. Any other questions with that or no?
No, I think you're good.
Okay, cool. So, I mean, you know, this is the system here. You can see the restoration on kind of what this looks like as it is planned to be milled, and then that's pretty much it. So that's the design of an implant restoration. I can move forward with like some biocopy, or I can move forward with a little bit more, you know, kind of materials and talk. I'm not sure what you guys maybe want to see. I know there was a question about CDocs, and so I will get to that to just talk about kind of what we offer. But let me get back to this slide. To be sure, we're cementing the tie base after the crown is milling and crystallizing. Yeah, that's right. So you're going to take the Emax after the Emax is done milling and crystallizing, and you've stained and glazed or polished or done whatever you wanted to that restoration. Then you're going to sandblast the tie base with just like a micro etcher, apply your silane to that, and then you're going to hydrofluoric acid etch the intaglio of the ceramic restoration, or, you know, monobond etch and prime, either way. And then you are going to use the multi-link hybrid abutment cement to lute those two together. Multi-link hybrid abutment cement comes in a number of shades, but I would only get one, which is the HO0. The HO0 shade is kind of like whiteout, but it masks out that underlying titanium base. So you're not going to see anything like that showing through. I have another question about how do you bond zirconia to a titanium base? It's going to be the exact same, okay? Whether you're taking Emax to the titanium base, or if you're doing zirconia, like making a zirconia abutment that you're going to put a, you know, a crown over top, it's going to be basically the same process. You're still going to sandblast the tie base and still silanate it with some sort of metal primer like Monobond Plus. The zirconia is going to be a little different. With the zirconia, what you would do is you're not going to hydrofluoric acid etch the inside of the zirconia. I use Katana Cleaner, which is a product by Noritake Kurare that primes the inside of the zirconia. And then I still use the multi-link hybrid abutment cement. So I put that on the tie base and then put the two pieces together. And it takes about 7 minutes for that stuff to cure extraorally. So you're putting all that together outside of the mouth and then going to the mouth to deliver it. Let's see. There was another question. Can I show you how to split a file from an abutment and a crown? And we can definitely do that. Let me switch screens here for just a moment. Okay, if we go back, you guys are looking at my CEREC screen now, right? Yeah.
Yes.
Okay, so if we go back and now we have the crown designed, okay? If we get real picky, let's say we wanted to bulk this out a little bit right here because that looks a little concave to me. All right, so now we have a crown. Let's say we like this overall design. Well, in the tools, we're gonna have a new tool over here on the bottom that says tool to split. When we click that button, what's gonna happen is a green line is gonna be proposed around the restoration. And I'll rotate it here so you can see it. So this green line is the split line. Now, if I were to look at this, I probably would not want the split to be right here on the facial surface. I may want to take it closer to the tissue. So that's pretty easy to do. What you do is you start kind of drawing these lines where you can simply alter it to split however you want. Now, personally, from, from a cement cleanup scenario, I would probably like to have this split line just at the gingiva on the facial surface, but probably a little bit supragingival on the lingual, if that makes sense. Because I want to see the ability to draw this line down below the tissue. So we're not going to see the split facial. But for cement cleanup, and no one's looking on the lingual but us, right? So I probably will draw my line up a little higher on the lingual. Now I know that I'll be able to clean that margin really easily and save myself some trouble of having to go subgingival all the way around with the margin. So once I've designed the split line where I want, you can check it from the lower jaw. You can see that we're kind of sub G on the facial, supragingival on the lingual. I hit the apply button. When I hit apply, the software goes ahead and proposes an abutment for me, and it goes ahead and proposes as well that crown that I already had. So this crown doesn't change, it keeps the crown, and then it goes ahead and spits the abutment for me. Now, if I were to go to manufacture, we're gonna see two things. We're gonna see the abutment proposed, and we're also gonna see, and you could change this obviously, we're gonna see the abutment proposed, and then we're gonna see the crown proposed that would fit that abutment. And those are all ready to go for you. Any other questions pop up during that time?
Let's see. Can you show how to split file to abutment and crown? Oh, you just answered that one.
We just did that one.
Nope, you're all good.
Okay. It's 5:20. I think it's worthwhile discussing a little bit about CDocs, because I think it's a really nice thing that Henry Schein, CDocs, and Dentsply Sirona all have together from a support network. So, you know, I'm gonna kind of feature our website a little bit. CERECdoctors.com is the premier kind of CEREC training program in the US for sure. And we have two facilities, one in Charlotte, North Carolina, and one in Scottsdale. We have a website. You get membership to the website from purchasing a CEREC. You also get, obviously today's talk, but you get a level 1 training, which is a 2-day hands-on course, a level 2 training, which is a 2-day hands-on course. And you also get a voucher, I believe, for a level 3 or 4. You have to ask for your Schein rep or your Dentsply Sirona rep, but I believe you even get a voucher for the 3rd course. So what you're gonna see on the website is a number of things. We're gonna have tons of discussion boards. We're gonna have digital learning videos where individuals such as myself and other visiting faculty and faculty members post cases. We also have a very, very active discussion board though. And the discussion board can be something very simple. It can be, hey, you know, I got a patient in the chair. This one is, for example, on anterior crowns. Is there a video for anterior crown parameters? And you'll have, you know, you see this one right here, the second one, within 4 minutes, you have kind of 12 responses. And it's not uncommon that any time of day, you see tons and tons of posts, whether it be something like this, where we're looking at CBCT images, or whether it's, you know, something to do with, gosh, anything from ortho to endo to materials. So the other thing that's really nice on here though is all the software and video tutorials that you're gonna see. So the software is updated a number of times. You can see here it's got like CEREC 4.5. We're now up to 5.1 in terms of CEREC software versions. And every time a new version of the software comes out, we already have hundreds of videos walking you through step by step of how to design a restoration, how to put a restoration in the computer. All these kind of things are done for you.
so that you don't end up with any sort of problems along the way. No real, learning on your own. You have tons of us that are all there to help. We also have the ability for you to submit a case. So let's say you're trying to design a crown, you're having difficulty getting it designed, whether it be a tough case or you just want to have someone take a look at it. It's really easy to export this case to the desktop of the computer. You're going to name it, whatever. It's going to be this RST file. The RST file is a file that I can open on my CEREC, or any of the other visiting faculty or faculty members can open on their CEREC machine. And when we do the RST file and export that to the desktop, you then will take it and upload it to the discussion board. So you'll click on the upload a CEREC case. You will drag and drop that case in there. Looks kind of something like this. And then probably within, I would say, maybe 20 minutes, maybe 30, you're going to have 3 or 4 responses of kind of what's going on in the case. You're going to have someone that's probably already made a video showing you how to alter the case, and whoever has done that video for you is going to send you the case back in an email and say, here's the problem corrected, or here's the design done for you, or something like that. And that way we're able to kind of make sure everyone is staying on track and keeping things as up to date and as helpful as possible without running into any major problems. I think that answers the question about kind of CDocs. Let me go back to one slide and we can kind of talk for a minute. We have our kind of wrap up stuff and do Q&A, and I can even go into the software and do some more advanced designs or things like that if you guys want. So what other type of questions does anyone have? I mean, I'm happy to answer questions on materials, or I'm happy to demo another quadrant, anything like that that you guys want, we can definitely do. Adam, they're being so easy today. Normally it's like 30 questions at a time to dig through.
Because you hit them with a lot of content in one day instead of 2 days.
Yeah, exactly. Let's do, since we have a little bit of time, let's do one more thing while we have time and see if that generates any questions. And that way we can, utilize the best use of your time from there. So let's see. Let me go to this one. All right, so let's talk a little bit about what it looks like to actually finish these restorations. If we're going through the process of milling a ceramic or milling a zirconia, what does it look like to actually finish, polish, stain, and glaze it? And the first thing that you have to remember during the milling process is, as this water is coming out of the motors, it's actually mixed with lubricant, and that lubricant is keeping it cooled off as the diamonds are grinding away on the restoration. But as that's happening, the restoration is obviously coated in oil. And what we don't want to do is take that restoration right out of the mill and go straight to the patient's mouth and try it in. Because now that tooth or that prep that we're trying to bond to is coated in this lubricant. So the first thing you want to do is clean this restoration. And there's a number of ways of doing that, right? You can do it with some alcohol and an ultrasonic bath. You can have a steam cleaner like this. That works really well. It's super quick. But just as efficient is doing it with just some soap, water, and a toothbrush. Doing those 3 things is totally fine. We all have those in our office, and those are going to get the oil off. And do that before you try it in the patient's mouth for sure. You also want to have that stuff off, because if you're trying to stain and glaze and there's lubricant on there, that can affect the finish. You may get some bubbling or pitting on the surface of your glaze as that oil is trying to evaporate out during the process. So after we have it cleaned up, you're going to take the sprue off. Remember, we saw that little sprue sticking out, and we have positioned it so that it's not on any of our interproximal contacts. And we're going to use something like a heatless stone. You're going to notice in these photos, you're not going to see gloves on hands. I do not like for my assistants to be adjusting anything with ceramic with gloves on. Even with these heatless stones, you can generate heat in the ceramic. And if you have gloves on, it kind of insulates your finger and you don't feel it until the ceramic is really hot. At that point, you've already kind of altered the integrity of the ceramic. So once this is cleaned and sterilized, sanitized, then you're doing this in the lab, no gloves on. And with Emax, Remember, we talked about how important it is to support the EMAX with some sort of peg material or putty. And there had been a question that someone had that, you know, the crowns were fitting really well in this purple state, and then after that, not fitting very well. And, you know, that could come from the fact that it's just not supported. Because that material is getting close to its melting temperature when it's at that crystallization cycle, you have to have some sort of putty in there. And it doesn't have to be anything really, you know, fancy about how you mount this. You just want to make sure that the margins are supported. So you place this firing pin in. You can turn it kind of upside down, and, you know, here we are looking at it. Everything's kind of to place. Now you can see a little bit of that putty's up above the margin. You want to make sure that that's not on your margin, because if so, then the glaze is going to be on top of that and you won't get any glaze in that area. So you're going to kind of like brush it off the margin, make sure there's nothing stuck to the tooth anywhere, make sure that everything looks good. After that, we're going to mix up our stains. Stains are just kind of these metal oxides. We're going to paint these onto the surface, and generally you're using a little bit of this dilution liquid that comes with the stain kit to mix these around. So that they're, you know, mobile. You can actually paint them onto the tooth, and not doing anything really fancy. You're going to take a little bit of this sunset color. Sometimes they come in different chromas, A1, A2, A3. You're going to paint that on the gingival third so that you have that chroma built into this EMAX. Because remember, the EMAX and the Celtra both are not multi-layer like we have with either the Katana blocks or some of those more aesthetic porcelains. So we do have to add that. We're going to add a little bit of blue. That's going to have the appearance of translucency. So by putting that on the cuss tips, you end up with a little bit nicer of a restoration. Then we're going to add a little bit of that same sunset that we put on the gingival third. We're going to add that onto the occlusal surface. And what that's going to do for us is allow us to create some depth. It's going to have that occlusal surface not look monochromatic and flat. And then over top of those stains, we're going to spray on the glaze. And so this spray on glaze, this is the EMAX version of spray on glaze. You're just going to do quick little puffs on each side. Now, I know we're showing the EMAX glaze here, but again, just kind of being honest with you, I don't really love the EMAX glaze. It's not my favorite. I find it kind of technique sensitive, and I see sometimes that individuals end up with less than ideal kind of glazing because of the just the technique and that high crystallization temperature that's required for that glaze. So I prefer to use one by a company called Indenco, I-N-D-E-N-C-O. Shine definitely distributes that. It's Indenco spray glaze. And the nice thing about the Indenco spray glaze is that it will support EMAX, Celtra, any porcelain, and zirconia. So you can kind of have a universal spray glaze for any system. A little bit different with Celtra, right? We talked about how Celtra is tooth colored already. So once Celtra comes out of the mill, you can actually fire 2 of these crowns at the same time. You can pick the case. You're going to see it. It's going to drop down. As this door opens automatically, you have this little kind of Kevlar, Teflon type firing pad. You can spray if you want the Celtra. You don't have to, but you can spray it. Or you can just fire it on there dry, and that's going to get it back up to temperature. And then you're going to polish it so you have that nice shine. And again, I really like polishing these systems because, you know, when you have a non-polished ceramic and you put glaze on it, once that glaze runs off, then we have a really rough surface underneath. So here's what it looks like when it comes down. You're going to notice probably from this look that Celtra is a little bit more translucent. You can kind of see that black underneath bleeding through that ceramic. And so I like to use the low translucency Celtra, where I'm probably using more medium to high translucency EMAX. And this is that polishing kit that someone had asked about. So these are the twist polishers. These are really nice for getting into occlusal grooves and for having, you know, just an overall nice finish without getting too shiny. The green is actually pretty aggressive, so I wouldn't use this on any interproximal contacts or anything like that. The blue is where I start polishing with my zirconia, and then to red. So that's that system. That takes us right to 5:30. Let's see if we have any more questions that have popped up.
So let's see. For a first molar,
Can the new zirconia give aesthetics as Emax? Yeah, I think that if you're looking at the aesthetics in regards to something like Katana, the Noritake aesthetic zirconia, that's definitely going to be on par with a low translucency, or definitely low, maybe possibly medium translucency Emax. The thing I like about the Katana is that built-in multi-layer. That is really nice for aesthetics because we're not doing any stain or glaze with that at all. It's all kind of built into the block. So what we end up doing is by the time it's done milling, we take it out, polish it up, center it, and then we just do a polish afterwards to make sure it's nice and slick and shiny and there's not anything being added. So I definitely think you can accomplish that. I don't know that you can accomplish that with like a CEREC zirconia because it is quite opaque, but I think the other ones are fine. What are the most common errors you see new CEREC docs have in preps and milling? So, you know, the most common problem with any, and not just a CEREC doctor, but dentists in general, is this inherent, you know, under reduction of tooth structure. And if there's anything from today's course that you take out of it, if you go and get a couple of those reduction burrs, it's going to help your CEREC journey a ton. Inadequate reduction makes it hard to design the restorations. It makes you have failure in restorations, which I know bothers me and probably bothers every other dentist. It just kills it from the start if you don't have enough occlusal reduction. So, you know, a lot of times if you are asking your lab, like I said, for Emax, and they're giving you zirconia or asking you to change the zirconia, it's almost always because of the lack of reduction. And so moving to a occlusal reduction burr, same with those facial reduction burrs, all that's going to make life so much easier. And then second is figuring out a good retraction system for yourself. And I don't just mean like retraction paste, right? Taking care of hemostasis and that kind of thing. I really mean something like an isolite. And I mean, I've had the isolite now for years. We even have it in hygiene ops because it's so much easier for the hygienist to even do their like full mouth debridements and stuff like that in there. But I don't know that I would be able to do the dentistry that I do without some form of that. And, you know, a rubber dam is obviously way less costly than an isolite, and it works just fine. I like the isolite because it has the bite block in there. The light doesn't really make a whole lot of difference to me. We have a light on the loops. So that I can take or leave the light, but the isolation, the glove, the fact that it's disposable. I know there's some other ones on the market that are reusable and autoclavable. I don't really love that idea. I kind of like tossing that thing after every appointment. It gets kind of gross between drilling on teeth and blood and old alloy and stuff coming out. So I prefer the disposable ones, but that kind of thing makes just a huge difference in the average case for any new user. Have some questions about ortho. Why don't I talk about ortho a little bit, maybe, rather than jumping right into cases, because sometimes doing an ortho presentation gets a little confusing. So I'll talk to you about kind of how I do ortho in my practice. Ortho in my practice, my kind of sweet spot is obviously clear aligners. I'm not doing brackets and bands and bonding, that kind of thing. And most of the time it's like relapsed ortho. I have an adult that comes in that has some mandibular anterior crowding or maxillary anterior crowding, or, you know, something that they didn't wear their retainer and they need to have it redone. And those cases are generally, one, very rewarding because the patient's happy to have it, but two, relatively straightforward to treat. And now if you have the prime scan, you have basically two options for the ortho that you can work with. I mean, there's a lot of third parties out there, but the main two are going to be ClearCorrect and SureSmile. If you have the OmniCam, you're going to have the ability to submit to Invisalign. Invisalign or Align Technologies has a partnership with iTero. And so unless you're using that scanner or using the OmniCam, which was previously approved for Invisalign, the prime scan is currently not, and I don't know that that's going to happen. That's more of I think a political discussion amongst companies. So I don't have a need for Invisalign, honestly. I use SureSmile and I really love the way they track. SureSmile, you take the upper arch scan, you take the lower arch scan, you take the dual buccal bite, just like we saw when we were doing full arches earlier this morning. You upload that directly to SureSmile. They have a portal just like Invisalign or ClearCorrect.
and you upload your photos, your Ceph, your pan, and they send you back a ClinCheck. Then you have a choice with SureSmile, which is really nice. Once you pay like the $299 or $300 setup fee for the ClinCheck, you can then order aligners, and they have a unlimited refinement plan. I think it's $900 or $999, something like that. That includes unlimited aligners and unlimited revisions for 3 years. So that's super helpful if you're having a tough case. But if you're doing a short case and it's only going to be maybe 10 aligners over 10 aligners, SureSmile gives you the option to print the STLs or the models and then make the aligners in-house, which is what we do a lot here. So the way that works is I approve the ClinCheck. Let's say it's 10 over 10. I request the files. SureSmile sends me those files. There's no fee for that export. That's all included in the $299 up front. So I'm in $300 for the ortho so far. I print out those models on my 3D printer within the practice, and then using a mini star, like a positive pressure thermoforming machine, you can use a Drufomat or a BioStar, or any of those would work. We fabricate the aligners here. And between the resin to print the models and the cost of doing the aligners, I'm in about $3 an aligner total. So that means a 20 aligner case between the ClinCheck and making them myself only cost me about $360. And that's just such a huge cost savings. And that's what I mean when I talk about CEREC, the return on investment not really being just this single unit crown machine anymore. There's a lot more to it than that. There's a lot more that has to do with implants and ortho and night guards and so much other stuff that goes into it that helps this machine that other CAD/CAM systems. And you're not going to hear any of us, especially any of us from CDocs, have anything negative to say about any of the CAD/CAM systems. I think all digital dentistry is great. But when it comes to implants and ortho and things like that, the only system that really has an entire working environment is the CEREC. And that's kind of where it succeeds. So for me to be able to offer Invisalign treatments, quote unquote, clear aligner treatments, right, to patients at such a low cost to myself allows me a lot of times to do some ortho almost at no charge. And I want to talk to you about kind of how that works, because if I have a patient that is coming to see me and they need some veneers, they want, 4 through 13 done. And 7 and 10, the patient has that classic like class 2 div 2 where 7 and 10 are out facially and 8 and 9 are a little retruded, and they want to do the veneers. Well, a lot of times they'll be okay with doing the veneers and the cost, but they won't be okay with doing the ortho and the cost. And what I don't want to do is I don't want to prep all of those teeth down, because I'm going to end up with weird values, and I can move those teeth for less than $400. And so we just build that into the cost. And I'll tell the patient, look, I'm happy to do this veneer case. We're going to do it for you, but we're going to do some ortho. And they're like, I'm not doing ortho. I'm not paying, $4,000 or $5,000. And I said, I get it. I'm just figuring that it's part of the veneer treatment plan, as part of the cosmetic package that we're doing for you. And so, maybe we do a limited ortho case for $800 or $900. And that way my materials are covered, my time's covered. Now I'm not doing that and not having them pay for the veneers. They're going to do for all that at one time. But it helps you mitigate your costs, and it really is a nice value add. But bigger than that, it makes it better dentistry. Rather than really prepping those teeth down that are so facial, or having to make those centrals so thick to catch up to 7 and 10, it helps everything stay in line. The tissue looks better, the preps look better, and the overall product is better. So I like having that kind of option and that kind of workflow. Hopefully that answers the question about ortho. Any other questions? I thought this slide had my contact information on it, but it does not. So let me get that back up for you guys. I'll go back to where we were before lunch, because I know it's on there. And I want to make sure that my email is there. You guys have a a way to reach out to me directly through email. You have my Instagram kind of name there. I'm happy to, when we do post cases, you'll be able to look at stuff there. But I'm happy to respond to any email. Adam and those guys have my contact information as well if I can ever help any of you guys. Like I said, CDocs and these hands-on training and even the Exceed courses that we've done in the past, the 2-day ones that hopefully will all be starting back in the fall, where we can have some hands-on and interaction and not be doing everything over Zoom webinars anymore. But I'm really happy that you guys were able to stick around for a day today. I hope it wasn't terribly boring. It's a lot to try to cram into just a few hours. And again, we normally kind of stretch this out over 2 days. But let's see, here's a question. Is the CEREC an open platform for other scanners? I'm not exactly sure what that question means. CEREC is open in regards to if you scan with the CEREC, you can export that file anywhere you want. So you could export it into ExoCAD, you could export it to a lab, you can generate an STL. In that regards, the system is open. To be able to design a restoration using the CEREC software and the CEREC mill, you have to have image with a CEREC. And that goes back a little bit to that kind of verification process that happens similarly with the CBCT data and being able to make a CEREC guide too. To be able to make that guide in-house, there has to be verifications and accuracies that are measured, and Dentsply Sirona can only guarantee their scanner and their CBCT data working together. They cannot look at Carestream, Instrumentarium, any other DICOM file and guarantee that the stitch is the same. So because of that, something like a CEREC Guide 2 or being able to scan and make a restoration is going to need the CEREC software and a CEREC scanner. But in regards to is CEREC open, can you scan and send out, then yeah, you can scan, send it anywhere you want. It is open in that regards. The whole talk of being a closed system is kind of an old talking point, I think, back when there were other competitors in the market, but that's not really applicable anymore. You can take that model and get a model out of it and send it to any 3D printer you want, or send it to a lab, or they can design it in ExoCAD or whatever software. The bigger issue is being able to do same-day dentistry chairside, and that's going to require the CEREC environment to do that. Does CEREC charge when there is a software upgrade? The short answer to that is no. The longer answer is possibly. So when you purchase a CEREC machine, there is a CEREC club fee that Henry Schein charges, and that includes all your software upgrades. It helps with some warranties on the camera, the cart, the computer, that sort of thing. I would not recommend having the Prime Scan or the OmniCam without having that warranty and not having that CEREC club fee. When the CEREC software does update, it is free as long as you're a member of that club. If you're not a member of that club, usually the software update is a couple of $1,000s. And so you save yourself a lot of headache by just carrying it. As they come out with a new generation of scanner and milling machine, is there options to trade in old versions for the new one? And yeah, I mean, historically, Sirona has always been really good about that. Even, with the Prime Mill coming out in January, we never know when that stuff's coming out. It's a surprise to us as it is to anyone else. Same with the scanner. And they've always had buyback and trade-in programs, even for older systems. So most recently, when the Prime Mill or Prime Scan came out, there was an option that you could, trade in and trade up to get some other ones. And Sirona is just a company that has always invested in progress, research, innovation. I would not want to have a scanner from a company that wasn't changing every couple of years, to be perfectly honest. I mean, if we say this is the best we can do, then we would have stopped at the blue cam years ago when we were still using powder and not seeing color images, right? And we want them to keep pushing the envelope and changing. And that's where the OmniCam came from. And I thought the OmniCam was the best thing in the world. It was color scanner. It worked great. I was doing all of our restorations with it. And I thought it was the best thing until I tried the Prime Scan. The Prime Scan is even better. And I don't think you're going to be seeing a scanner anytime soon because the Prime Scan is so new. But that's just, anecdotal evidence. That has nothing I have no rhyme or reason to think otherwise. But if a new scanner just came out a year ago and a new mill just came out months ago, I don't think you're going to be seeing anything like that in the short term. Could you export the crown file and bring it into another software, different mill, 3D printing? So no, that kind of goes back to the software system. You can scan the arch, you can scan preps, you can scan anything you want and generate a 3D model. You can even generate a 3D model that has the margin in it, okay? You could scan the model that you've prepped, send that to the printer, now you have a prepped model. But you cannot send out that design. The RST file, or the design of the crown, is specific to the CEREC mill. The milling algorithms are patented in terms of how those burrs are passing around that block and the integrity that's maintained of that ceramic. So you could take the models out, decide to design the crown elsewhere, but I don't know why you would do that, because you already have the software to design there. And I truly think, and I've used a lot of the other chairside design softwares, I think the easiest one to use is the chairside. There may be some that have other features. How useful those are to the general dentist, I don't really know. You know, the question came up earlier about doing like a digital wax set myself. All that sounds well and good, but my time and energy in my practice is better used doing dentistry because that's where I'm productive. So pouring models or digitally waxing up a case or something like that is not where my production's at. It's better off to have the lab do that, because that tends to be relatively inexpensive, even from a high-end lab, and then for me to be doing the dentistry. So hopefully that answers that question. What's the difference between CDOC's course and the clinical accelerator courses from Dentsply? So the clinical accelerator courses are CDOC's courses. That is a partnership between Dentsply Sirona and CDOC's. So when you look at the clinical accelerators courses, if you're going through the ortho, you're going to be having CDOC's faculty teaching you the ortho. If you're going through the endo, CDOC's faculty, same with implant surgery, and same with the CEREC accelerator course. Those are all those level 2, 3, 4s that I talked about. If it is CEREC, I think the surgeries are like, they're called like 1A, 1B, 2B, 2C, that kind of nomenclature. But same company, same everything. So the clinical accelerator is just a package that's set up as you buy equipment from DS. They are now providing a roadmap of curriculum to make sure that you're able to integrate that into your office easily and get trained on it. Do you have to design the case on that rolling cart, or can you design it remotely from another monitor in a room to avoid moving the machine in and out of the room? Totally up to you. You can design on the cart. What I have in my office is a separate design center. The reason I have that is it just makes life easier sometimes because there's 2 dentists here. So what that means is I may scan on the prime scan, and then when I go to that model phase before I start marginating, you may have seen a box pop up a couple of times when we were working today that said deserializing the case. And what that means is that it's sending the case to my hub. The hub is basically a fancy, large external hard drive that holds all of my CEREC data. Also manufactured by Dentsply Sirona. So it goes there. Once it's on the hub, I can access it from any other computer that has the CEREC software. So I can dial into the hub from the computer that's sitting at a desk, work and design the crown while my associate's using the prime scan elsewhere to design and that sort of thing. Although, you know, moving the cart around, that's all it does all day. At my office is up and down the hall, and if I have time, I'll design it on the computer, or my assistant will, or somebody's at the design center designing it in multiple areas and ways to get that done. $5:50, kind of right on time, Adam.
Sure.
I have 10 more minutes or so. I'm happy to answer any questions. If there are none, again, I've really appreciated you guys all sticking around on a Thursday, even after work if you're on the East Coast, because it's now almost 6 p.m. here. But I guess just let me know if there's any other questions. You have my contact information. We've gone through the 47, 48 questions or so in the Q&A and the chat. But if there's nothing else, I will wish all you guys a good evening and appreciate your attention today.
Awesome. Well, thank you very much, Dr. Snider, and thank you to everyone for attending. We appreciate everyone's time and participation. This officially wraps up the one-day Exceed with CEREC online learning. If you have questions, as Dr. Snider said, feel free to email him directly, or you can email us at webinars@henryschein.com, and we will route your question to Dr. Snider. Upon exiting today's webinar, we ask that you please complete the short 2-minute survey and let us know what you thought of today's presentation. Thanks again for attending, and everyone have a good night.